Yeah, good morning, dear friends, colleagues. Sorry for the delay. There was a technical glitch, and as today we are having a very small gathering, but we are live for both days. Today morning it was supposed to start at 9:45, but we are delayed by almost half an hour. And today we have got a master class where we will be teaching you the different aspects of minimal and basic proctology. With me will be joining my own teacher and mentor, Dr. Kushal Mittal. So I will be finishing two topics. One is hemorrhoids, that is laser and rhinoplasty. And second, we are going to finish fistula, hybrid procedures and fistula. And Dr. Kushal Mittal will be taking pyramidal sinus, that is BLFs, video assisted laser ablation of pyramidal sinus, as well as he will be teaching you how to do fishery nano with laser. So starting with today's first slide. So that is anatomy of renal cushions. Can anybody switch off the lights, please? Lights off, please. So we will try to finish it in next 3 hours, so that in the afternoon we have got very good fistula session today and tomorrow. Almost 6-7 cases of fistula are there. So hemorrhoid, even if you see 2 cases, you will understand what all is to be done. But fistula, you need wide experience to know what all modalities can be used for good results. So coming to the anatomy of anal cushions and its correlations with hemorrhoids. Now, as we know, anal cushions are disruptions of submucosa at 3, 7 and 11 o'clock position. And the theory that Thomson, anal cushions, it was given by Thomson way back in 1975. It was his MS thesis where he just discovered the anal cushions. And when we talk about any British book or American book, normally like in India we always say 3, 7 and 11, but they always say left lateral, right anterior and right posterior. And when we talk about hemorrhoids, so hemorrhoids are nothing but they are swollen anal cushions. Now another interesting finding is that if you see at 6 o'clock position, that is the 6 o'clock position. Now this is something which is called an accessory cushion. Now if you go through the original publication of Thomson way back in 1975, you will find that he had mentioned about the presence of this accessory cushion at 6 o'clock position in between 3 and 7. And this is called having a bolster effect. Bolster means like a pillow. So when we talk about accessory hemorrhoids, at that time, the name given to accessory hemorrhoids is because of accessory hemorrhoid, accessory cushion, anal cushion, which is present over there. Many people say these are secondary hemorrhoids. No, that is a wrong nomenclature. So, coming to the this thing, anal cushion has got 2 components. Excuse me, can anybody push it slightly this side? इसको थोड़ा सा इधर कर देंगे, तो the wires ना मिले. Slightly this side, please. आराम से. Yeah, slightly on top. Yeah, that is fine. So anal cushion, it has got two components. One is the vascular component, and which is comprised of CCR, and second is the non-vascular component, which is comprised of elastic fiber and connective tissue. Now, what is the importance of vascular component? Now, we know anal cushions are supplied by superior hemorrhoidal artery and middle hemorrhoidal artery. But it is only the superior hemorrhoidal artery which participates in formation of CCR. CCR is corpus cavernosus dactyl. So, why they are called CCR? Because the structure of sinusoids that resembles the penile structure. So that is the origin of CCR name, why it was called CCR. Then when we talk about non-vascular component, elastic fiber and connective tissue, as you can make out from here, now that is a conjoint tendon. So conjoint tendon, what it does, it gives the fibers medially. Now you can make out the fibers which are piercing the internal sphincter, and these fibers, they are called as ligament of Tietz. Now what happens when ligament of Tietz are there? So they hold the anal cushions to their normal position. Another important function of this ligament of teats is when the longitudinal muscles are present. Now the submucosal space is there. Submucosal space contains arteriovenous sinusoids which are present. In between the sinusoids, we always see there are sphincters or fibers which are present over there. Now with age, two things happen. Number one, the muscle component, it starts degenerating. So once it starts degenerating, so what you get at that time is basically sliding anal cushion theory, which was given by Thompson in 1976. Secondly, what happens once there is a decrease in the or degeneration of the muscles in between the sinusoids? So what happens? It leads to venostasis. So that was one of the theories which was considered behind the etiopathogenesis of hemorrhoids. So arterial supply, as I told you, it is from the terminal branches of superior hemorrhoidal artery and branches of the middle hemorrhoidal artery. And venous drainage, it is into the respective veins, that is superior and middle hemorrhoidal veins. Now this is a complete picture how to analyze that superior hemorrhoidal artery and its branching pattern. Now this was given by Eigner in 2004. We wanted to keep this picture for the book which is coming up very recently, Lessons in Proctology, and I have written to him for his permission to make two diagrams from his papers. And superior hemorrhoidal artery, it has got two branches, left and right. Just remember, left does not branch further, whereas the right gives 3 to 5 branches which are present, which supply the anal cushions. Now these branches, they may be transmural, they may be submucosal, they may be extramural or intramural. So most of them are posterior lateral. So just remember, although all these branches participate in formation of CCR, but when you do FG-HAL, that is finger guided hemorrhoidal artery ligation, or DG-HAL, Doppler guided hemorrhoidal artery ligation, or in my opinion, even if you go for transcranial suture hemorrhoidopexy, that is not a Chiptis procedure, there is no way you can ligate all these branches, because basically you just cannot reach there. So all these procedures as standalone procedures, they will fail. So that is the reason we always go for laser hemorrhoidoplasty when we talk about the hybrid technique. That is hemorrhoidal artery ligation plus the laser hemorrhoidoplasty. Idea is very simple. Hemorrhoidal artery ligation will take care of only some mucosal part of the branches, some mucosal branches, but the CCR formation which is present from the from the other branches, transmural, extramural, intramural, that will be taken care of by laser hemorrhoidoplasty. So that is the principle behind the laser hemorrhoidoplasty surgery. Now see this diagram. See this. This is a dentate line, and the submucosa always ends at the dentate line. So that is the reason the internal hemorrhoids, when we talk about internal hemorrhoids, they are present above the dentate line, and below we always say they are present the external hemorrhoids. But the most important thing to know is that at this place, now see this junction. Now this is a mucocutaneous junction which roughly indicates that it is the intersphinctic groove. So what happens in between these two, as you can make out, there are anastomosis which are present between the branches of superior hemorrhoidal artery and the inferior hemorrhoidal artery. So that is one of the reasons that you get, number one, internal external hemorrhoids. Secondly, even after Dr. Chiptis procedure, there is never ever a vascular necrosis, because the blood supply is going to come from the inferior hemorrhoidal artery. So above dentate line, it is internal hemorrhoid plexus which is situated in the submucosa, and below dentate line is the external hemorrhoid plexus. Now one very interesting thing I would like to share with you is that when Thompson was studying about all these things, anal cushions and everything, he used a term subpectinate hematoma. As the name indicates, now what is the pectin? Pectin space कहाँ पे होती है? It is in between the anal verge and the dentate line. So any hematoma formation which is there, so that he named as subpectinate hematoma. But now we call it as external hemorrhoids. Am I clear about this? So that is the difference. It is a difference only in the nomenclature. Basically, the whole pathology remains the same. So what can happen to anal cushions? They can either bleed, as you can make out, or they will prolapse, or they can become thrombosed. So one important difference which we have to know about the thrombosed and strangulated hemorrhage is, thrombosed means a part of anal cushion is involved, but strangulated means the whole anal cushion is involved. In case it's a thrombosed hemorrhage, it is an indication where you can go for clot evacuation followed by laser hemorrhagoplasty. But if it is strangulated hemorrhage, never ever go for laser hemorrhagoplasty. It's absolutely in the contraindication for lasers. So coming to laser hemorrhagoplasty, so what I always do is a hybrid procedure. So what is a hybrid procedure? It's a synergistic combination of two or more procedures for increasing their efficacy to yield a better outcome. So this is something which is very important, and this principle was given by Morinaga in 1995 when he came up with Doppler guided hemorrhageal artery ligation. So what he said was, the position of rectal arteries is not predictable. Now initially in medical colleges we were taught 3, 7 and 11. That's all. Nobody talked about other positions, and even if any hemorrhage were formed, they used to call it secondary hemorrhage. Absolutely wrong nomenclature. So first of all, position of rectal arteries is not predictable. Second, arterial blood supply is of relevance in the pathogenesis. Now we know, because we have got hypervascularization theory. I will come to that. Then ligations can be effective in the distal part of the rectum. Hall is effectively ligating procedure, and Hall is responsible for cure of symptoms. So this is a very important landmark publication by Eigner in 2004. The vessels did not course exactly at 3, 7 and 11 o'clock position. Now even if you are doing standard milling and Morgan, so the first step what we do is the pedicle ligation. Now if you go for blind pedicle ligation, you are ligating the vessel thinking the vessel is present over there, but the vessel may not be there. So that is the importance. The vessels did not course exactly at 3, 7 and 11. In my practice, I have seen instead of 3, they are at 2.5 o'clock, 2 o'clock, or sometimes 3.5 o'clock. So that is very important. Secondly, in 82% of cases, these vessels bifurcate, and 12% of cases they trifurcate. So the bifurcation and trifurcation, so where it starts, can anybody tell me? Okay, it is approximately 10 centimeters above. From there, the vessels they start coming down. So position of rectal arteries. Now the most important is that the position is not predictable. Now what we were taught, as I said initially, 3, 7, 11 primary hemorrhages. So whatever they are present at 1, 5, 9, they are all secondary hemorrhages. No, secondary hemorrhage will form only after a disease. It will not form otherwise. These are all accessory vessels. Now why they are accessory hemorrhages? Not accessory vessels, accessory hemorrhages, because these are basically branches of the right branch of superior hemorrhageal artery. Another landmark publication, now it's a well-accepted fact about hypervascularization theory. Initially, we always used to talk about varicose veins theory. In my opinion, although many people say it does not hold any long, but I still feel it is one of the factors, especially in the external hemorrhage. Many times we see the bulges which are present all around, and that is basically dilatation of the inferior hemorrhageal plexus. Moreover, multiple publications are there now where they have proved that in varicose veins, in 30% of almost cases, 30% of cases with varicose veins, they can have associated hemorrhoids. So that theory still holds good. So coming back to hypervascularization theory, so what Aina proposed was, as compared to the normal human beings or normal people, in hemorrhage patients, there is 3 times increase in the blood flow. 3 times increase in the blood flow, as well as increase in the caliber of the vessel. Sorry. So that is very important, because whatever recurrence you get, whenever we get a recurrence after any surgical procedure, this remains one of the causes of recurrence. Now, next question. Once we are talking about hemorrhoidal artery ligation, where exactly to like it? When we are 2 to 4 centimeter above the dentate line, now see, this is a dentate line. So this is the, this thing, anal cushion, and this is a vessel which is coming from there. So when we are 2 to 4 centimeter above the dentate line, the depth of the vessel is hardly 3 to 5 millimeters. But as we keep on going up, the depth of the vessel will keep on increasing. See this. When you are 6 centimeter, I will show you how it can be shown like this. See this. So this is on the left. You can make out on the screen that when we are 2 to 4 centimeter above the dentate line, the depth is hardly 3 to 5 millimeters. But when we keep on going up, the depth of the vessels keep on increasing. Now, why it happens? Because the superior hemorrhoidal artery always pierces the above the anorectal vein. So that is the most important part. So this is a picture taken during one of the conferences. Now this is very important. You will be seeing so many cases in the next 1.5 days, and this is very important for you to understand. Now see this. Now this is a sawtooth appearance, which indicates junction of the proctodium with hindgut. So that is a sawtooth appearance. Now this is what is called dentate line. Now what happens? Many surgeons, they feel this line, the mucosa which I am just pointing over here. Now that is the dentate line, which is not true, because that these are the area of inner transition zone where ornithoma orgagni are present. So never ever mistake. 3 lines are very important. Number 1 is a dentate line, and it is also called pectinate line. And second line is white line of Hilton. White line of Hilton, they present the intersphinctic, the space between the lowermost part of the internal sphincter and the subcutaneous part of the external sphincter. So that indicates that it is the mucocutaneous junction, or maybe the space which I said, white line of Hilton. Outside it is called the intersphinctic groove. So that is the difference between these. So this is a suture which we use. I will be showing you how to use this suture and what is the advantage of this suture. The needle is slightly stout, so it is not that easy that the needle gets broken when we are going for hemorrhoidal artery ligation. And it is 27 mm 5x8 circular body needle, 120. We are coming up with new needle. I think Prashant is not here. So he is coming up with a new needle which we are getting it made from somebody from Bangalore. So let us see how that needle, I think I have got 2-3 boxes, and I personally feel that needle is even better than the local suture. Secondly, the needle holder which we use is 9 inches needle holder, and I am going to demonstrate to you today how it is to be done. So coming to what is laser. So laser is nothing but laser application by stimulated emission of radiation. So laser light gets transformed into thermal energy. So what's the thermal energy is there? So what happens? The thermal energy, it leads to photovaporization, ablation and coagulation. So in the past, laser is not something new. Many people think it has come in the last 1 decade. No, that is a wrong thinking absolutely. Lasers are in vogue first in 1917. Einstein had said that laser light is possible. All of us know about Einstein, right? The genius. Then different type of lasers were used, but nowadays we use diode laser. Carbon dioxide laser was used, which had a better cutting but with a low hemostatic effect. In the last 20 years, there is not even a single publication on use of carbon dioxide laser in hemorrhoids. The people who are selling this equipment in India, one equipment that they have installed in Jasloke Hospital, Bombay. I asked the person, can you give me any literature? I met him at Bombay in IMAST, and I just asked a very simple question. Can you give me any literature of use of carbon dioxide in hemorrhoids? He said, sir, definitely I will send you. But almost after a year, I have not received any paper. And if you go on internet, everywhere it is clearly mentioned. I mean, there is no mentioning of carbon dioxide laser used in today's time as far as the hammers are concerned. So this is very important. 1470 versus 980. Before 980 it was 910. Before that it was 810, like that. Now what is the difference? 1470 is something which works under water as a medium. 980 works under hemoglobin as a medium. So absorption is 40 times more with 1470 as compared to 980. Now as I always say, whenever we go to attend any conferences, so many laser people, they run after us. अरे सर आप छोड़िए, why you want to pay so much money for 1470? 980 भी उतना अच्छा काम करती है. It's absolutely not true. It is not true at all. There are so many studies available on internet. You can go and read tremendous papers. I don't know how many of you are using 980, but it's a fact that 980 causes more pain. Because, why more pain? Because the energy which you are releasing is much higher. It's much higher. So that is the principle that 980 should not be used. It's an obsolete model. And secondly, all of us as practicing surgeons, once we purchase laser, definitely we would like to use for varicose veins also. So in case we want to use it for varicose veins, then 1470 is the answer. Now, instead of 1470, they come with 1940 also. But that is only for varicose veins. There is no role of 1940 as far as hemorrhage is concerned or proctology is concerned. So principle, as I said, photoablation. Now what happens once the heat goes, energy goes, no need to make any notes. I am coming up with a book. So we will send it to you. So that is, it breaks the chemical bond. Now what happens, the H2O bond, water, H2O bond is broken. Now as soon as the bond is broken, you will hear crackling sounds because of the release of hydrogen ions. At the same time, once the H2O bond is broken, immediately there will be shrinkage. Photocoagulation introduces protein denaturation. Now we know protein denaturation starts at around 72. Now in the literature whichever I have read in the last 1.5 years, they do claim it starts at 65 degrees. Harmonic, we know the energy given is at 70 degrees. Same is with the vascular also. So let's presume that the denaturation starts at 65 to 70 degrees, but it goes up to 132 degrees. So once protein denaturation is there, it leads to dearterialization. So that decreases the blood supply to the cushion. Photovaporization, we know water contains 70%, the blood contains 70% of water. So once the water content gets evaporated, what is left behind is the coagulum, and coagulum leads to fibrosis. Now see this picture. Now when I was talking to you about sinusoids, now these are the sinusoids. Now this is the endothelium lining. This is the sinusoidal lining composed of endothelial cells. Now what happens, we know cells, they contain cytoplasm. Cytoplasm contains water. So what happens once the energy is given, the water content gets evaporated. So what happens, there is volatilization. So once that process happens, immediately this layer is broken. So fenestrations are not there anymore, and what is left behind is a coagulum, which eventually gets fibrosed. Now when we talk about shrinkage of pyroneal sinus or fistula tracts with laser energy, the principle remains the same. It is the same. The epithelial tract having epithelium, epithelium having cells, cells means cytoplasm, water content gets evaporated, there is shrinkage. But many people do claim that with shrinkage the tracts close. I have not seen any tract closing till date with that. So indications, as I said, second to 4 degree prolapse internal hemorrhage. Thrombosed internal hemorrhage is also there. This is standard Coleman teaching. If somebody says, who says in thrombosed hemorrhoids you can go for laser enteroplasty, just tell them, read Coleman. It is very clearly mentioned that clot evacuation can be done. After that, absolute contraindication, as I said, it is strangulated hemorrhage. Pre-operatively, all blood thinners should be stopped. Now there is various school of thought. Some people say ecosprin can be continued, but otherwise other things can be stopped, like clopidogrel. Position, all cases I do in lithotomy position. Of course, jackknife is also good, but I feel more comfortable in lithotomy position. Antibiotic single shot of ceftriaxone given half an hour before surgery. And anesthesia, we do all of our cases in spinal or saddle trauma. So what procedure protocol you should follow? Now this is something important. The fiber which we use is conical fiber. I am not against using the bare fiber, but bare fiber can cause mucosal injury. There are certain companies which are in the market who are giving, this thing, laser fiber for hemorrhoids. So I don't know why, but it is fine. But it can puncture the mucosa. You can be in problem. Mode is always a pulse mode. So two modes are there, continuous and pulse. Pulse mode we use in always, in hemorrhoids. But continuous mode we always use in pyroidal sinus, fissure narrow, as well as fissura in narrow. So dosage at the time of insertion 6/1 second pulse, and at the time of coagulation 6/3 second pulse is there. And keep on withdrawing fiber every 5 millimeter. Now why we have to withdraw the fiber? Because in one activation the area covered is just approximately 4 millimeters. And area as a total energy, it should not exceed 200 joules. Now just remember, if you keep on giving more energy, thinking the shrinkage effect is going to be better, please forget about it. You are going to cause lot of cellular injury, cellular edema. Patient will complain of lot of pain, lot of inflammation is going to be there. So never ever exceed 150 to 200 joules. And believe me, once you are going for hemorrhoidal artery ligation, half the procedure is almost over. So what is left behind? Even if you give 100 joules, your job is over. I will show you today how to do all these procedures. And most important, in case the bile mass does not decrease, as I said, please do not keep on giving energy. So cosmetically what you can do, just remember there is no principle behind it. But cosmetically what you can do is RAR, recto-anal repair or mucopexy. But if you take the same procedure on principal grounds, go for Blaisdell or Farag's procedure. It is very well mentioned in the literature. Blaisdell was in 1958. So I am going to show you today. I am going to demonstrate to you, even if the bile mass is not coming out, I will still demonstrate it to you. So what we do, when we go for mucopexy or recto-anal repair, we start at the apex, then 2 to 3 millimeters apart, 2 to 3 millimeters deep, we keep on taking stitch, multiple stitches remain above the dentate line, then pull the whole mass up. Because we want to tell the patient, aapka kaam ho gaya, right? But if you take the deep stitch, including mucosa, some mucosa, and a few fibers of internal sphincter, then you tie the knot. So what you are going to achieve? It's a dearterialization. So that is Blaisdell's procedure, and the same thing was told to was the conclusion drawn by Farag, F-A-R-A-G. Farag has written a very beautiful paper on that. Then point of entry. Now where should we enter? Now see, anatomically if you see, because the submucosa ends at dentate line, and we always say that the anal cushion, the disruptions of submucosa at 3, 7 and 11. So technically speaking, or from anatomy point of view, if we say, it appears that the submucosal junction, this is the dentate line, is an ideal place for insertion of fiber. But after doing 30 to 40 cases, I realized that the external component of the hemorrhoids, it does not decrease very well. So why it does not decrease? Because of the presence of these anastomosis. So it's always better to enter from the mucocutaneous junction. So normally fibers, they are meant for single use. Many companies, they have got a locking mechanism system. They say you can use fiber for 3 to 5 times because the intensity decreases. Nothing happens, believe me. Nothing happens. It is just a selling gimmick. nothing happens to the fiber. And this is how the normal fiber looks, and this is after multiple use. See the coherent beam. If the beam is coherent, the fiber is good to go. Only thing is, just remind me in the afternoon session that all of you should know how to take care of fiber. Ask my staff, they will teach you how to clean the fiber. That is very important because fibers are very expensive and we cannot use fiber for 3 times, 4 times, 5 times, but these fibers can be used n number of times. We have been using sometimes in poor patients one fiber even in 50 times. So the cost is drastically low. So coming to the video, that is FG Hub with laser and radioplasty procedure. इसको चलाइए या चलाइए. How to play this video? नीचे वो प्ले आना चाहिए. इसको आगे चले जाते हैं. प्ले आना चाहिए. On the next slide. आप आगे चला जाइए. ये कैसे करते हैं? इसके लिए तो ये नीचे बार आती है ना, तो हमने नीचे की तरफ एक बार आती है. आगे आ गई. मेरा लैपटॉप चल रहा है. Sorry, there's some technical glitch. So this is first we insert 3 gauze pieces to identify the degree. Now that was the dented line. Now this is how we palpate all the vessels. So once you palpate, see the pronation and supination movements of my wrist. So that is how we take a stitch. Now always remember, when we are taking a stitch, it is a figure of fate. I will tell you the principle behind figure of eight stitch. Now see how I am holding the needle holder. It is, I am not putting my fingers in the fenestration at a time of taking a stitch. Now that is milking of the pipe mass. That is how milking is done. And just tie the knot. So once again palpate it, once you have taken a knot. So whenever you are taking a knot, just remember a few fiber of internal sphincter or valve is taken. So there is no pain because it is supplied by the sympathetic and parasympathetic. External and the sphincter is supplied by the pudendal nerve. So this is all the vessels wherever they are present. You can palpate, you can ligate them. So just have a look, you will have a fair idea what you are going to see in the afternoon. Now that is marked reduction in the size you can make out. Now see, this is activation of fibers right from the mucocutaneous junction. That is how we enter. And that means the light should not be very bright. That means you are too near to the mucosa. And if it is too dull, that means you are somewhere into the internal sphincter. See this. So ideally it should be parallel to the inner cushion. So just keep on withdrawing every half a centimeter and see the thing is there. After that, eye finger is inserted, which we keep for 8 to 10 minutes. Now this is follow-up. Now see this, there is no prolapse now. So that is something which is called minimal invasive proctology. So that is grade 4. See, this is injection high dose, which I am injecting right now. So wherever the pile masses are there, now what happens, high dose increases the tissue permeability immediately on the table. Within few seconds, you can make out reduction in the pile mass. It is again mentioned in Corman also. So just go for assessment of the pile mass. Now the large structure which you are seeing is the hypertrophic canal papilla, which has already been marked. So the first step remains same, palpation and ligation of the hemorrhoidal artery, all the hemorrhoidal artery branches, superior hemorrhoidal artery branches. So then making of the hemorrhoids. So just keep on palpating the vessels, keep on rotating it, 360 degree. All the vessels whichever are present, palpable, you have to ligate them. Otherwise, what will happen? There will be formation of accessory hemorrhoids because you are blocking at 3, but the blood supply is going to be getting diverted to the other places. So that is how the clot evacuation is done. A very fine, very minor procedure. So just give a nick with the help of bare fiber or a cautery, evacuate the clot. Now see, this is thrombosed hemorrhoid. This is not strangulated hemorrhoid. So this is hypertrophic canal papilla. You can go for excision. Always send it for histopathology. The other day I was going through some literature. They said that sometimes malignancy can be there. I have never seen it, but yes, it has been documented. And when we talk about, this is standard procedure, 3 o'clock position. So from wherever you have removed the clot, that becomes a point of entry. See this. So that is the way this procedure can be done. So we just move to the next video. This was recorded during one of our last workshop. So that is grade 4, you can make out. So that is assessment of the pile mass. You can make out large masses which are present over there. Again, injecting high dose. So 1 ml is available in powder form. So just make a 1 ml solution using distilled water or normal saline and start injecting, and just make sure that you always withdraw a piston so that the blood does not come. Just see the reduction of the pile mass on the table. And after that, just go for palpation of the vessels. You can make out a very big pile mass present at 3 o'clock position. Now all these things I have already told you about dentate and mucociliary junction, and HAL is always done at the apex of the pile mass. That is milking. So all other steps, no, they remain same. So nothing has changed in this. But I just wanted to share with you that even in grade 4 hemorrhoids, when there is no strangulation, you can still go for this procedure. Now this is, suppose you get a case with this strangulated hemorrhoids. Now see this, that is a strangulated hemorrhoid. Means the whole anal cushion is involved. But always remember, even a strangulated hemorrhoid, the apex is never involved. Apex is never involved. So that is the reason we can easily take a pedicle stitch over there. So the idea is very simple. How can we do all these procedures without creation of raw areas and with least pain to the patient? And of course, results, they have to be excellent. So even if it's a strangulated hemorrhoid, you propose to cut it or excise it, it really doesn't matter because HAL has to be done. Because even if you go for American Morgan, hemorrhoidal artery ligation or pedicle ligation is always done at the apex of the pile mass. So basic principle remains the same. And that is standard Milligan Morgan. You can make out the internal sphincter outwards, and that is the apex of the pile mass. So just all of you must be doing this, and of course better than me also. So that is what you do. You just excise it. Now what advantage we have got? Just see, in spite of presence of strangulated hemorrhoids, with other second degree, third degree hemorrhoids, I have cut only at one place. So post-operative pain is going to be much less. So that is the advantage which we get. So this all videos we discussed. So in case it fails, so what you can do? Now see this is a fibrous hemorrhoids. So we tried our best that this component, in case we can reduce it with laser ablative, but complete failure after using hydras as well as after HAL, and we had to go for Milligan Morgan in this case. So this is the same patient. Now this is what the standard quotation, the proverb, which was originally written by, I think it was written by Thompson, but it is mentioned in Bailey and Love about dahlia. If it looks like a dahlia or a clover, if it looks like a clover, the trouble is over. So the same patient, this is how the bone looks. You can make out it is almost similar to the mentioned in Bailey and Love. So what not to do? Never push up fiber against resistance. It means you are not in the correct plane. Never activate laser if the light is too bright. That means you are too near to the mucosa. And if it is too dull, that means you are somewhere into the internal sphincter. And if plasma does not shrink, please do not keep on giving energy. Now this is where we started. So why we should prefer a hybrid procedure? Well, the CCR formation part, which is there, that is taken care of by hypervascular, Eigner theory, hypervascularization theory related with CCR, that is taken care of by hemorrhoidal artery ligation. But whereas the non-vascular component, now this is concerned, now this is relates to sliding evacuation theory, and the remaining part of CCR along with the elastic and connective tissue fiber, they are taken care of by laser embryo-plasty. Post-operative, nothing special, just make sure you don't keep a ice pack for more than 8 to 10 minutes. Now previously we were keeping for 20 minutes. Then I happened to read one of the publications where it was mentioned that if you keep it for more than 8 to 10 minutes, it can lead to a similar condition like frostbite. So we know what is a frostbite. That means there will be crystallization inside the vessels. So since then I stopped doing that. So treat it like a sports injury. Initially we had to go for cold compression followed by hot compression. Hot means 6 bar after 24 to 48 hours. Now this is a procedure which is mentioned in the book on the literature, and it is by one of the very famous laser companies. But I will always say, please do not follow it. Perform this thing HAL to reduce bleeding during LHP. It is not true. The principle behind hemorrhoidal artery ligation is totally different, as already I have explained to you. Spray. Now many people, what they do, they spray this thing beam at the apex of the pipe mass. They say the principle, what they say is it leads to spasm of the vessels. But just remember, with 1470, you always spray 1 millimeter away, and the depth is hardly 1 to 2 millimeters, whereas the depth of the vessels is 3 to 5 millimeters. So there is no way you can go for dearterialization or you can achieve dearterialization. Small incision, make outside the anodum, insert put a scissors, widen it, then take a fiber. It's not required. I will show you this. If you have to go for such an extensive procedure like over here, as you can make out, for the insertion of the fibers, it's better to go for mechanical component. So this is not required. And pre-operative, post-operative, you can make out. So these are the results. And complications. So how to manage? Now suppose you get hematoma formation. Now hematoma formation can be there once you are taking a bite. Once we go to hemorrhoidal artery ligation, so what is going to happen? Actually, it's a blind procedure. So you can puncture a vessel. So nothing, just put the pressure. As a surgeon, we know how to deal with hematomas. Keep a pressure, control the bleeding, and in case you have got sufficient experience, go one step up and take another ligation. Otherwise, wait for 72 hours, go for slow therapy. And the other complications, pain is much less. We use diclofenac spostries post-operatively, and edema is there, but edema is there because there is a cellular injury as a result of thermal energy. After that, burning and itching. Can anybody tell me why there is burning and itching? Very simple principle. Once cellular injury is there, it is going to lead to inflammation. So once the inflammation is there, it is what is going to happen? Release of histamines. So once histamines are released, it is going to cause itching and burning. So you can go for antihistaminics for 4 to 5 days in case it is required. Hemorrhage and abscess also have been reported in my patients. 3 patients I had out of the thousands. I don't exactly remember the number, but must be more than 1,000 patients, 1,500 or 2,000. We had abscess formation in 3 patients, and 2 to 3 patients had complained that they had a bleeding after 15-20 days. But unfortunately, I could never see them, with active bleeding. So when they came to me, I just asked for wherever you had gone, show me the proctoscopy findings. And one patient from England was kind enough to show me send me the proctoscopy findings. It was very clearly mentioned, no active bleed could be seen. But just remember one thing, which is very, very important, that although people may write, no active bleeding can be seen, it may be because once the inner canal contracts, the vessels are open. So actively you will not find any bleeding, but otherwise a bleeder can be. So thrombosis and skin tags. Now that is the first publication by Plattler way back in 2009, and number of patients was 16, very small number, and results CTM 93.4% without hemorrhoidal artery ligation. And this is another paper. Now, it was a cohort study, 497 patients, different centers, multi-center trial, and LHP without HAL, 91.2% results. And this is the biggest series which we have published in appointment journal, that is 346 cases, and over here the success rate is 98.2%. And these are overall results you can see, which we have compiled from the literature, and almost we are at par with the world, 96, 96.8, 98, not much difference, 98, 96. And so this is a paradigm shift over the years. So what we have seen, the first, American model was in 1937. But believe me, original procedure was by Savon in 1836. So it took 100 years for Milligan Morgan to establish excisional hemorrhoidectomy. So that is a paradigm shift. Then of course Lord's dilatation was there, but I have written a very good paragraph, the rise and fall of Lord, how people accepted all over US, UK, and then 52% was the reported incidence of incontinence, because four-finger dilatation for 4 minutes, that is what I used to say. So that is no longer practiced, and after that transient switch and radiography is there, procedure, and the latest to add is superior hemorrhoidal artery embolization. So what they do, they just enter through the femoral, go to the superior mesenteric artery branches, release the coils. Microcoils are there. Exact size I think is 0.04 micron. But it is effective only in grade 1 and grade 2. Grade 3 and grade 4, there is no role of superior hemorrhoidal artery embolization. Maybe because the diameter of the vessels is much more, because 3 times as said by Eigner. That is the reason there is no role of superior hemorrhoidal artery embolization. So a very common question, should we go for lateral internal sphincterotomy along with laser radioplasty? The answer is no, because initially people used to think that increased inner tone has led to the formation of hemorrhoids. But there are so many studies now where it has been proved that the increased inner tone is because of hemorrhoids, not otherwise. So once you take care of hemorrhoids, every other thing will be taken care of. So only in the presence of a fissure, associated fissure, only then you should go for lateral internal sphincterotomy along with any hemorrhoidal procedure. So why recurrence? Formation of collateral circulation. Now this is a picture which has been taken from, if you remember in third year we used to read a book, McGregor, Surgical Anatomy. So that is a picture I have taken from there, and this is already have shown that is because of 3 times increased blood flow. There is nothing you can do about it. There are no medications. There is nothing over here. And recurrence, different procedures at different dates, and Milligan-Morgan is no exception. You have got approximately 15% recurrence with Milligan-Morgan procedure. Now many people ask, why lasers? Why not pottery? Answer is very simple. Laser energy releases energy at 65 to 88 degrees Celsius, but path of conduction can never be controlled. And we know with rectosurgical unit, when we call it pottery, basically it's a rectosurgical unit, the path of conduction cannot be controlled. And laser is a non-contact instrument, and the chances of injury to sphincter with pottery is much higher as compared to lasers. Another common difference between radio frequency and laser, just remember only one thing, that both are good, there is no doubt about it. Radio frequency is another thermal source, but the energy usage is quite high, 25 watts, and joules are given 400 to 1000 per pi mass. Over here, the joules are much less. So whatever you do, it is very clear that the laser is better than any other options which are available, whether it's radio frequency or it is the pottery. Another question, can holmium be used? Now the people who come to me from corporate sector, they have got already holmium in the urology unit. They always ask, can it be used? The answer is again no. Why? Because the wavelength is 2100 nanometers. Now you must be knowing the principle. Now what happens once they use it for renal calculi? So the calculus it contains water. The water content is there. So water content gets evaporated, there is a blast. So that is the way the stone is broken with hormone. But it doesn't have any hemostatic property. So that is the most important thing. God forbid if the bleeding starts, you just cannot control it. So whatever you do, it should be always be evidence-based. The best evidence, clinical expertise, patient's value and preferences, telling about all these things. Too many patients come only for laser, so I don't have to convince them about external this thing, like seasonal hemorrhoids or any other procedure. They know we have come for the lasers, and that all constitutes this parameter, the evidence-based medicines. So the most dangerous phrases we have always done is this way. Thank you very much. Any questions? We can take. Thank you. उसमें देखो तो क्वेश्चन आ रही क्या? चैट बॉक्स आएगा इसमें ना?
जाओ पाजी।
चैट बॉक्स आएगा ना? वो तो उसमें चैट बॉक्स पे भी गया ना? चैट बॉक्स पे लिखते ना? So any questions which are there? कुछ भी पूछना हो, anything you want to know.
Sir, objective, what is the handset delivery of data?
हैं? एक माइक देना हो please.
Hello. Sir, as we introduce the laser fiber, sir, then we deliver the laser energy in a fan-shaped manner. Fan-shaped, sir. Once we deliver all 3 points, then we will draw 5 mm, then again fan-shaped, sir.
Yeah.
So exactly, sir, fan-shaped, we want to know what position actually, sir.
Okay, basically fan shape we go for grade 3 or grade 4 hemorrhoids.
Sir.
The bigger the pile mass, then we remove. So what we do, first we go straight. Then we almost come from the point of entry, till the point of entry, from where we have taken the fiber inside. Then we can go below or upwards, or medially and laterally.
Right, sir.
And just the basic principle remains the same. Take it up to the end, because already ligation has been done. So the fiber is going to stop automatically. So after just 2-3 pulses on each side, that is fine. So total how many pulses will be there? 3 plus 3, 6,
9.
and 9 or 10.
9 or 10.
So 9 or 10 means multiplied by 18, 6 into 3. So 180 joules. So still it is broken. Yeah. But
Thanks.
that, the results are very good with that. Friendship.
Thank you, sir.
So energy is fired while entering also and while removing also?
We fire energy at the time of entry. It is 6 watt 1 second pulse. Basically, we activate it to pierce the fiber inside, because it's a conical fiber. It's a sharp tip fiber. No? So the entry is very easy. But when you have to enter, you have to make a hole. So once you press it at the mucopotential junction, release the energy from the pedal for 6 watts. That is automatically fixed. 1 second pulse. So that means only 6 watts have gone. So just take the fiber inside, and once you are inside, then only activate. Change the setting on the equipment. 2-3 seconds, then activate.
So while moving inside, sir, we keep on firing and then the fiber goes inside. So while moving the fiber inside, that time also we are firing energy.
Yeah, only 6 watt will be there.
And then removing also we are firing.
Yeah. Remove every time we have to do. Otherwise, you are not doing laser then. We are just putting a fiber inside and coming out like that. It has to be activated. I will show you it after. I will show you good cases. I will show you. Yeah, anything else?
In circumferential hemorrhoids, we go for LHP or staple hemorrhoids.
Honestly speaking, if you go even for circumferential hemorrhoids, so they're always present sulci. So if you are able to reduce it with highlights, as I have shown you, grade 4, there's no problem. No problem is no problem at all. Just remember, I never speak against any procedure. Staplers has got its own rule. But there are so many publications on staplers that there is never ever complete de-arterialization achieved with BPH. That is procedure for prolapsed hemorrhage, that is stapler hemorrhagopexy. Now what we are doing over there is, we are pushing the mucosa up. But practically you are not doing anything for embolies. So whatever CCR formation is there, you are not going to do anything for that. So that is the reason the recurrence is very high with staplers.
How much Hylase is given in each file mass?
Actually, 1 ml of Hylase, it is available in a powder form. So you just inject 1 ml of saline or distilled water. So 1 ml solution will be there. So somebody told me you can give 30 to 40 ampules in all the three. It doesn't matter. But I have never used more than 3 to 4 ampules. So broadly speaking, 1 mass, 1 ampule. So you can take it as a principle. But in case you want to give them 2 ampules, it doesn't have any side effect. Only thing it can lead to is allergy. Allergy can be with Xylocaine also. We know that. Xylocaine also causes allergy 1 in 50,000 cases. There was a movie, Nights in Orlando, that was by Richard Gere. So उसमें ना वो cosmetic surgeon है, and to remove one hemangioma or something, he gives Xylocaine under local, and the patient dies. So allergic reaction is a known complication of itis.
But it is very well known allergic to Hylase.
It is mentioned. I have not yet seen it, but it is mentioned in the
It
literature.
is very, very rare.
Very, very rare. But it is mentioned. Urticaria is mentioned.
In Hall, when you take the stitch figure of 8, is there any disadvantage of the strangulation of the mucosa in between these stitches?
No. Actually, it's a right question you have asked. I wanted to answer that question. What is the principle behind the figure of 8? Now, once this is a vessel, for example, you are not going to ligate this vessel like this. So, figure of 8 is basically a vascular switch. So, what we do, you start from one side, take the surrounding tissue on all the sides, and then when the surrounding tissue is taken, this vessel gets compressed, squeezed. So that's flow surgery. So that is the reason you take figure of 8 stitch. It is a typical vascular surgeon stitch.
We take the continuous stitches or you interrupt the stitches?
Always interrupted. Palpate the vessels, keep on palpating
But
to it.
Shimate procedure is
Not a Chipchase procedure is what they say, you keep on interlocking.
Yeah.
But he doesn't say go for laser angioplasty. But that is what exactly I am telling you, that with even not a Chipchase procedure, my opinion is that when we talk about the spiral hemorrhageal artery branching pattern, so there is no way you can control CCRs from transmural or extramural or
we
intramural.
should use laser.
So if somebody told me you go for instead of finger palpation, you go for a Chipchase procedure, and then as a second step you go for laser angioplasty. But that is something which has not been mentioned, and it is not mentioned in the literature. We can do anything we like, but we cannot propagate it. And honestly, I have never done it.
Tell the trick. How much above the dentate line? 2, 3, 4 centimeter.
2 to 4 centimeters safest.
But it is 2 to 4.
I tell you.
It can
Okay.
be 2 or it can be 4. Is there any difference?
No difference. You have to stay below the anorectal line. So what is the length of the anal canal? It is 4 centimeter in females, 4.4 centimeter in males. So if you are at the anorectal ring, that means you are approximately 4 centimeter from the anal verge. So from the dentate line, how far you are? 2.5 centimeter. Because from the anal verge to the dentate line, it is 1.5. Right? So you are 2.5 centimeter from there. So 2 to 4 centimeter they normally say, but even if you are at 2-3 centimeter above the dentate line,
Is there
the
any
job-
harm if you take stitch up to 4 centimeter above the dentate line?
No. 4 centimeter above dented line, we take person's suture, na? When we go for PPH.
Okay.
So that is the person's suture we take. Then we are approximately 4 centimeter above the dented line. So there is no, I mean, you can take anywhere. But the ideal, even if you stay at the anorectal ring, we are done. Your job is done.
So can we use laser in 4-degree prolapse hemorrhoids?
Yeah, sure. Why not? I showed you 2 videos. I showed you 2 videos. You can go to YouTube, watch it again. It is very easy to use. Very, very easy. Very, very simple. Just inject Hyles. Wait for approximately few seconds, not even minutes. Few seconds means 5 seconds, 10 seconds, 15 seconds, and press it, massage it nicely. So once you massage it, the pile mass is going to fall inside. So once it is inside, how does it matter? It's grade 2 or it was grade 4. The principle is the same.
Use of mileage is basically to reduce the pile mass.
To increase tissue permeability. जो हाइड्रेस का प्रिंसिपल है ना, that is it increases tissue permeability. So once we see all these masses, so this is edema is there. So once you inject into some mucosa, what is going to come out? The water content. Now what I did when I wanted to start Hyles, I just did 1 or 2 cases of laser and radioplasty during Hyles. After that, I just thought, in case it is helpful, let me try in paraphemosis. Paraphemosis. Now, sir, you just inject it.
Definitely. The principle is the water.
I mean, it is a wonderful drug. It is just like a magic. Paraphemosis just instead, like what was the standard teaching? Make multiple punctures. What was the principle behind it?
To reduce the basically fluid.
No, so that the edematous part, the content, the water content that comes out.
You can reduce easily.
Absolutely. So in case you inject it, patient will just say slight pain is there because it is all swollen area and you are injecting it. But within seconds, believe me, doctor, within seconds, everything disappears.
Mileage is available easily.
Very easily. Every ophthalmologist is using it. Every ophthalmologist in the country is using it.
It's in the powder form.
It is in the powder form. One vial is there. I will show you. Today afternoon you can just write the name of the company from where we are procuring. You can just order that. It was 70 rupees. It is not a very expensive drug. So anything else? Should we move to the next topic? Because we have to start up a list also. It's already 11:30. So our next I will try to finish in another 45 minutes. Can you touch my laptop, please?
लैपटॉप ऑन कर दो.
So coming to the next topic, that is fistula in ano. So this is how it started. The credit for establishing Royal Academy of Surgeons goes to fistula surgery performed successfully on King Louis XIV by Charles Franco Felix. Now just remember, Felix was a barber surgeon. In Europe, it was all barber surgeons who were taking care of proctology, whether hemorrhoids or whether it was fistulae. But then there was a strong fight between qualified people and the Barber Surgeons Company. They named it Barber Surgeons Company. So there was a fight, and later on it was officially declared that only qualified surgeons will practice proctology. So from there it started Royal Academy of Surgeons. So more surgeons' reputation have been impugned because of the consequences of fistula surgery rather than any other surgery. Now if we see our practice, it's the same scenario. कहते हैं कि अगर किसी की रेपुटेशन खराब करनी है तो उसको फिस्टुला का केस ले. But I am going to show you so many cases of fistula today and tomorrow It's like we could have called it fistuloma. Different varieties, all fistulas, whatever you have read, A1 to A6, B1, B2, and C also. I'm going to show you all the cases. So what is the goal of the treatment? Now just concentrate on these two things. The most important is how to tackle the internal lobe. How to tackle the internal lobe. In case you know or you can tackle the internal opening, never ever be afraid of fistula. So this is what is mentioned. These lines are from Practice Parameters, American Society. So anatomy, all of you know about all these spaces. I will not go through that. The intersphinctic space, submucosal space, perianal, ischial, supralevator, and deep posternal space. I am going to show you today or maybe tomorrow how to open deep posternal space. This is a deep posternal space. Now how it is formed? The external anal sphincter has got three parts: subcutaneous, superficial, and deep. Superficial gets inserted into the tip of the pons. So once it gets inserted, it forms anacoccygeal ligament. So once anacoccygeal ligament is there, the space which is deep over here, this space, that is called the deep posternal space. How to open it? What is original Henle's procedure? What is modified Henle's procedure? I am going to demonstrate it. Live surgery I will do. Now, I am going to show you one video which I did one case approximately a week back, Now concentrate on this. Now can anybody tell me how come an abscess or an internal opening which is there at 6 o'clock position and 12 o'clock position, the external opening appears at penoscrotal junction in men or labia majora in females? Can anybody tell me about that?
What is the question?
The question is, the patient presents with internal opening at 6 o'clock, external opening at penoscrotal junction. So how the track is formed?
I think it comes through the IS space. It pierces the external space, then it comes through the IS space. And then goes, make a IO at the 6.
IO means internal opening.
Yeah.
And
External means when track, it descends, pierces the external sphincter, comes through the IS space, and comes down, and then it spreads into the IS space.
so that is what the standard understanding is. But that is not true.
Not true.
That is not true. See this part. Can you see bulbous spongiosис and ischiocavernosus? Now many people think, number one, when you read the anatomy of perineum, male perineum and female perineum, many people think bulbous spongiosис and ischiocavernosus, they are present only in men, not in women, which is wrong. In both bulbous spongiosис and ischiocavernosus are present. Now what happens? See this area. So that is the bulbous spongiosис and ischiocavernosus. Can you make out? This my pointer is at ischiocavernosus. That is the bulbous spongiosис. Now this is called the perineal membrane. Now what is this? Perineal body. So what is present over there? Superficial and transverse perineal muscles. Doctor, am I clear?
Yeah.
So what happens? The track, it pierces these bulbous spongiosис and cavernosus. Then it reaches the penoscrotal junction in men and baby and females. That is the theory behind it, right? And the space which already have been marked dotted, see this space. Now this is called deep anterior anal space. We always talk about deep posterior space, but this is a space which is very rarely mentioned in any books of colon and rectal surgery. But this is a space from where the track goes on. Clear? So this is a very important slide which we people normally don't think much or we ignore it. Now, The question now next is, if there is anterior deep anal abscess, which is formed over here. This is a female patient. See this vagina. So how to tackle it? You cannot cut it. Patient will. It's a complex disease. Any fistula, anterior fistula in female is a complex fistula. So what is going to happen? If you cut this area, then you are cutting basically the perineal body. And perineal body is a weak structure. So why is it a weak structure? Because the external sphincter, anal sphincter length is half in females as compared to men. ठीक है डॉक्टर? और जब पेरिनियल बॉडी बनती कैसे है? What are the components which form perineal body? It is the fibers of the external anal sphincter, superficial and transverse, superficial and deep, transverse peroneal muscles. Am I clear about that? So that is the part from where it is formed. So that is the reason it is a weak structure. Now what you do in case a patient presents with abscess, just drain it. And in between the subcutaneous and the superficial part, intersphinctic groove, right? Put a set on. Just put a set on. In males, you can divide it. Females, never ever divide. The same principle which we use for anterior and fistula females. So another very important space which I am going to show you how to open it. This is the deep intersphinctic space. See this. Now, internal opening is present in dentate line. What we do, we just open the dentate, the tract, scoop it out. Axial hammer's technique. What was past technique? Take the whole chunk out. But once we are taking the whole chunk out, what are you removing? Mucosa, submucosa, surrounding tissue, and the fibers of internal anal sphincter. So once the fibers of internal anal sphincter you are cutting, so where are you? You are into a deep intersphinctic space. So the infection lies over there. So until and unless you open the deep intersphinctic space, the patient fistula is going to rupture. I am going to show you each and every procedure today. How to open a deep intersphinctic space, how to open the post-anal space, how to do modified handles, or maybe how to do handles.
Basically, it's a medial sphincterotomy.
No. It lies in between the dentate line and the anolateral line.
We should basically, we go through the IS space, we go behind the intersphincter to the internal opening we cut this. I think this is the basic.
This is a basic fundamental principle.
We call it CID, cruciate intersphincteric drainage. This is the theory behind the vision.
Okay. So that is.
Yeah, I am practicing for last 3-4 years. I am doing CID. We will discuss after this. And I think these are some absolutely marvelous.
But this is the crux of the story. That a take-home message is whenever you are going for fistula surgery, always open this.
Yeah.
Always means always.
This is the only basic.
That is the only basic theory which is required. So this is about the handle procedure which I am going to demonstrate to you today. And see this. This is the coccyx. This is the anococcygeal ligament, and this is the dentate line. So what we do in original handles, which was somewhere in 1960, 61. After that, modified came in 1984. So 61, what he used to do, that he used to continue this incision, the internal, fistulotomy incision, deep. where will you reach? Deep posterior. And why the space has to be opened? Because on both the sides, the issue-rectal foci become. So whatever we are doing, or we should do, it should be based on anatomy. If we know good anatomy, we can have a good. So those are the basics. Another important point, Milligan septum. Now, I don't know how many of you have heard about this, but I came to know about this term very late. Milligan septum, this is CLM. So what happens? The CLM, it has got three components. Medially, this is the intermuscular component present between the subcutaneous part of the sphincter, external sphincter, and the lowermost part of the internal sphincter. So this is the intermuscular part which invites it to the end. Then corrugated cutis ani, because the CLM, it gets inserted into the perineal skin along with fibers of the subcutaneous part of the external sphincter. The ischio-rectal space. Any abscess which is present in the ischio-rectal fossa, until and unless it penetrates the Milligan septum, there will not be any signs of inflammation of the skin. So the patient may not present with any pain, or maybe my teresmus is there, pain during defecation, or maybe says some heaviness is there. So that is an ideal case, you should go for MRI. So again we go for hybrid procedure. So whatever I am going to show, I think discuss with you right now, all the procedure will be shown to you today and tomorrow. So it's a synergistic combination of two or more procedures to increase the efficacy to yield a better outcome. Now many people feel it's a Indian जुगाड़, hybrid procedure Indian जुगाड़ है. मेरे को तो बहुत लोग बोलते हैं, but it is absolutely rubbish. No. The first publication of a combination of removal of internal opening and coring of the distal tract was by Park in 1962. The problem is, people like us, many times we don't study literature. तो जब literature नहीं पढ़ते तो किसी को जो आता है वो देते हैं, which is not true. So this is a publication from 1961. So when to do all complex fistulas, there are indications. Why? To tackle the internal opening more precisely, to obliterate fistula tract with no or least sphincter cutting. When I say least sphincter cutting, I mean only the subcutaneous part of the external sphincter is cut. And if you read the original Park's paper, it is very clearly mentioned you need not to cut any external. Internal sphincter you can cut, He writes you can cut up to the amoractal ring, but there is no need to cut the external inner sphincter. And of course to create least raw areas. So principle already I explained to you that cell cytoplasm water content gets evaporated and there is constriction. So different procedures are there which I am going to discuss with you. So what are these procedures? So the principal laser we know that it is to ablate the internal opening and the fistula tract slop. That is some mucosal ligation of fistula tract. Now this is something which was started by Dr. D.U. Patil. Although it has not propagated so much in the country, but in my book I have mentioned Bohr's law.
It's a very good question.
I have mentioned Bohr's law. Now if you compare slop with lift, slop looks better,
Better and very simple.
right?
Everybody can do it.
But there is a drawback in slop. You are practically doing nothing for internal. You are not opening any deep intersphinctic space. So the source of infection, whether it is lift or is slop, is not. It is not removed. That is the reason why there is recurrence after both the procedures. And just remember, people are fond of inventing new things like tropics is there. What is tropics? Transanal opening of intersphinctic space. Now it is not a new procedure. It is in 1961.
61.
That is the original procedure by Park. And what is lift? It is partial internal sphincterotomy. Again, very old procedure, 40, 50 years old procedure. So what people have done, they have modified the names. As I said, we don't read much literature. The people who read, they change the names. Now that is my take on it. And now see this. So what is the difference between Parks and Eisenhower? Now many people say, you just open the track, scoop it. So what are you scooping? You are scooping the part of the anal gland which has finished, which is over. It has melted because now it's a tract, but the infection still lies over there. So what is the line we are scratching or scooping out? Is the epithelial part of the tract. But still, in case little bit of epithelial tract is left, it will lead to recurrence. So which is a better procedure? It is definitely Parks. Why Parks? Because you are removing everything per se. Internal opening, mucosa, some mucosa, surrounding tissue, internal sphincteric fibers, we are removing everything. So that is the basic difference between these two techniques. Parks 1961, Eisenhower 1958, then he criticized paper of Park in 1962, and then he came up that in 1978, lay open of the track and scoop the internal opening, whereas as I told you, Park did a wonderful job. Wonderful job. So procedure protocol, type of fibers, corona 360 degree. Now there it was sharp tip. Here it is 360 degree round fiber, and the ring size is approximately 4 millimeters. And mode, it's a continuous mode. Dosage 10 watts per millimeter per second. Total energy depends on the length of the track. For example, it is a 4 centimeter long track. So how much energy is 400 joules. Now in my practice, which I always recommend, never ever open tracks which are less than 3 centimeters. So that is a 5 procedure. I think I will have to go to the video, so it is not working over here. इसको नीचे भी गया इसको हेल्प करनी पड़ेगी यार आपको So that is how hydrogen peroxide is can be seen coming out the internal opening. So that is curating on a track. Now this is a railroad method. We are going from inside out, internal opening to the external opening. Now that is a laser fiber. This is 6 French or 7 French infiltrating tube and start from the internal opening. Now if you do this procedure before slough, chances are there that because of the bactericidal effect, the recurrence rate will decrease. So that is keep on pulling the fiber out 1 millimeter per second, 10 watts is the energy. And go up to the end, external opening. Now that is how to take circumambulation stage. Now that is original 5x. Now see this, I have inserted a probe. Now I am going behind the track. Behind the track means circumambulation. Mandir mein people go for parikrama. They take a chakkar behind the temple, right? So it's the same thing. You have to go behind the track. The which suture I am using is Vical 20, 27 mm needle 5/8. So that is the way you just close it and gradually pull it. See the jerk. Now if that jerk is there, that indicates that you are behind the track. Otherwise, that means you are superficial to it. So it is just like closing the internal opening. Same principle we use in slough also. So that is finally widening of the opening. Once you check with methylene blue, that nothing is coming out. So that is a very simple procedure, but overall results are not that very good. So I will not recommend you to go for this procedure. Many people do say that they do advocate that there is complete shrinkage and the blocking of the track. I have never seen it. Openings with single internal opening. Today I am going to show you this case in the afternoon. So you can make out hydrogen peroxide being injected from the different external openings showing intercommunicating tracks. So all these tracks are intercommunicating. The single internal opening at 6 o'clock position. See this? Now that is for demarcation of tracks, because once you are going for fixed season, you should know that the whole track has come out. And the methylene blue is the only solution which will tell you that the shortest track where you can go for fish slot. Now just lay it open. Now this is what is Eisenhammer's technique. Now this is the complete excision of the internal opening. You can see free fluid coming out. That indicates all the tracks they have been separated. And that is the fixation. See this, it has gone inside, and you can make out the whole track which has been brought out. Again, fixation can be used. The whole idea is to prevent, large raw areas. Now, in this case, had I gone for open surgery, instead of 2, I would have created 4 products. You can make out. So that is a complete pouring of the track. Nothing new, as I told you, it is 1961 paper, and that is the winding of the external opening. Now the idea is that all the necrotic material which is there, it should come off. Now mass stabilization we always do in all the cases. You can use rapid, Vical rapid or simple 2-0. So what is the advantage? It decreases the wound size, maintains the hemostasis, the fecal matter doesn't go behind it, and according to literature, even the post-operative pain is less. So all the different tracks which are lying, which we have not gone for coding, there can be laser ablation. So that is how the procedure is done. Little bit problem today because of so this is another interesting case. See, there is one impending opening at 5 o'clock position. It's a horseshoe fistula. So you can make out once I am injecting a solution of hydroperoxide and methyl blue, it is coming out from the 7 o'clock as well as from the internal opening. And both sides, it's an intercommunicating tract. So it's a horseshoe fistula. So just, this is the internal opening. It's internal opening. So one side, the shortest tract which is there, you can excise it or go to fistulotomy. Now that is the removal of the internal opening. So just see, when both the tracts, the center they join together. Once we remove this, both the tracts they get separated, and that is again fixation. See, the complete tract can be brought out. Now this is another important step which I always recommend. In case you don't do it, if you don't close the place from where the coding has been done, fecal matter will enter in this book, the liquid part. So once it enters, then it can lead to infection. And the small tract which is lying over there, you can just separate it. If it is approximately 4 centimeter, that is the cutoff point which I keep in practice. The blue dye which you are seeing below, it is all, that part. Of course, we curate everything. After curating only we go for marsupialization. So that is binding of the external opening. So whatever tissue you are curating, all the necrotic material should always be sent for histopathology examination. So that is aromatrogen which we are applying over there. That is the final one, how it works. Very good video yesterday. Hello sir, hello. So this is synchronous fistula. Synchronous fistula means 2 internal and 2 external openings. You can make out one internal opening at 1 o'clock position, another is at 7 o'clock position. So this is a long tract, approximately 4.5 centimeter long. So that is a railroad method. So that is how you go for laser ablation. So that is proximal fistulotomy. Just see how the fistulotomy is done. Only up to the subcutaneous part, or maybe just even not by cutting it. So that is the fixation. If you do laser before that, it helps you shrinkage of the tract. That is again marsupialization switch. Today we are going to show you all cases where marsupialization is going to be done with the Michael rapid and very small tract. Just see, hardly 1.5 to 2 centimeter, and this is always should be open. Just because we have got laser, it doesn't mean every case should be subjected to laser. So one side I gone for tracheotomy, another side is scoring because I did not want to cut internal and sphincter at two places. So that is the final. One video I just wanted to share with you, or I will show you later on. Sir, are you carrying a pen drive? There is like glitch in the computer. It's not getting attached. So I am also using the laptop only. So this is something slot I wanted to show you. So basically this is the difference between slot. Now when we are going for slot, you always are very near to the internal opening. And for lift, you go into the intersphincteric space. Now when I use the term partial internal sphincterotomy, even if you cut it like this, partial internal sphincterotomy, the results are going to be same as in lift. But both procedures have a drawback. Just see, this part is not being tackled. The part where infection is 9. So that is the reason there may be a lot of recurrence after slop or lift. No, it's not. Okay, no problems. I will show you. So this is all I have shown. And so what to do? Now see this. Now 10 watt 3 seconds for 75 millimeters. Now this is one of the proposed way of dealing with laser of fistula, which is a wrong way. Because in between we are going to leave skip areas. So ideally it should be 10 watts continuously. Never go for pulse mode or just keep on withdrawing fiber every 3 centimeter or 3 millimeter or 4 millimeter or 5 millimeter. It's not required because it's going to leave skip areas. Now this is the picture I just wanted to share with you. Now last year we had fistula con. So 2 conferences were there. One was INSTA, but was by our Association of Coronary Rectal Surgeons of India. So it was fistula con. So one procedure which was shown that proximally you go for lift and distally you can open the tract. Fistulotomy. I don't know how many of you are going to agree with this because in my opinion the recurrence will be always from the proximal side, not from the distal side. So distal, even if you curate, go for laser, the results are going to be good. Set on if you want to place, for drainage purposes, you can place in the distal part. And advantages, high success rate because the basic principle remains the same. Basic principle is fast procedure. And creation of small bowel area, no, or least cutting, no chance of incontinence, daycare procedure, early reduction to work. An ideal technique in fistula surgery does not exist. So this is the first procedure piloted by Wenham in 2011. Success rate 88%. And wall lift, now that is another procedure, a combination of waft with lift. So many people say about that, success rate marginally better. And that is a study which we had 2019, 2020. Now our association is conducting very large study on fistula. It's a multi-centric trial which is going to be conducted all over India. So we are part of that. Ethics committee was कल ही मिली है ethics committee की permission. Meeting is still not there. So these are our results. 93 to 96%. DLPFL distal laser proximal fistulotomy. Now why the results are the best? Because we are removing the whole infection as he said. As he said that we are removing Like जड़ से ही आपने निकाल दिया. Deep intersphinctic space. That is the reason lasers are the best. No, there is nothing else. Laser has nothing to do with that. And pitfalls, variation in the results may be due to type of fistula, length of tract, diameter of internal opening, wavelength, and brightness of the procedure. Thank you. Any questions in case they are there? I am willing to take it. So we can have a 10 minutes, 15 minutes break. After tea we can start. Sir has to start with the last lecture. So 2 topics will be covered by Mittal sir. And sir, boss, first of all, let me welcome you.
Thank you.
Welcome.
For inviting.
Still you are in time. You always make it in time. So
As you told
topics Byron, sinus and fissure will be covered by sir.
Sir, as you told, proximal part is more important in case of nectar fistula. But sometimes we are not able to make out the internal opening. Can you fix it?
Internal opening invariably is always present. Only 2 conditions. Only 2 conditions are there where sometimes we are not able to make out the internal opening. That is number 1, in case there is fibrosis. There is present fibrosis at the internal opening. Then methylene blue HCO2 will not go. Second is the presence of hourglass deformity. But in that case, from the external tract, give a traction outside. Tuck it is called. Give a tuck outside. In case you are able to see anything which is being pulled outside, that indirectly indicates the part of the internal. That internal opening is present. I think Dr. Mittal can just elaborate on that, because how to identify internal opening, he is a master in that. Sir,
You're right when you say sometimes you don't get the internal opening, but you have to realize that that was the same thing I said to my teachers 20 years back. And they said, "No, internal opening you will always get if you work hard enough." And you will get. Your finger is the best digital probe you can have. You have to feel the normal mucosa. That means where there is absolutely normal. You don't expect the opening. You have to feel that area. And then you go to the area where you feel that the internal opening should be there. That is usually posteriorly at 6 o'clock. And feel. If you feel fibrosis, induration, well, that will be the point where it's coming, even though you can't see it. The other thing is you can take 2 cc of saline and inject it around the suspicious area. The mucosa will elevate where the internal opening is not there, and where the internal opening is there, the mucosa will not elevate because it is fibrosed to the underlying structure. The other thing you always do is hydrogen peroxide, but don't use too much of hydrogen peroxide, never more than 1 to 2 cc. And if hydrogen peroxide comes in, well and good. The common mistake we make when we are trying to look for the internal opening is that we insert a proctoscope or a sim speculum or any type of speculum inside. Now that will make the internal opening closed because of the pressure. So you need to put nothing inside and inject hydrogen peroxide. If the internal opening is patent, or even if it's not patent, hydrogen peroxide will make it patent in most of the times. When it is not, like Dr. Kamal said, you have to dissect the external opening and subcutaneous tissue till you get to the fat. And then hold that in Alice and give it a pull. When you give it a pull, you will see a pull inside the anal canal. The other thing is where you feel that the internal opening should be there, take a probe and gently press on that area. If it goes in, then you will see a drop or 2 of pus coming out, so you are sure that that is the internal opening. And that's more or less all of the things for internal opening. But those who are not doing enough fistulas will invariably say, if 50% of the time I don't get the internal opening. And those who are doing a lot of fistulas will say about 5 to 10% of the internal opening is not seen, but they find it ultimately. So it's experience which will get you the internal opening.
Sometimes while cooking, sometimes we make false opening.
Absolutely, absolutely. So I'm saying probing from inside, from anus, not from outside. And when you are probing, remember your finger has to be on the sit down. Your finger has to be on the dentate line. Why? The probe usually goes towards the inorectal ring. And if you are going to follow the probe, then you are going to make a false opening at the inorectal ring or some other place which is not the dentate line. Dentate line is hardly 1.5 centimeter from inner wall. Put your finger, if you are a right-handed person, left index finger on the dentate line. Only a small amount goes in, and keep it there. And then you probe. Then you won't become false track. But if you don't put your finger inside, the probe will go higher up, and then you will make a false track. And multiple false tracks will be made. Anything else?
So can we start now if you are fresh?
Yeah?
So
Yeah.
this time we have to finish per month so that we can have finish lunch and after to at more proper way to start with the ये कोशिश करना कि लग जाए तो सर का लैपटॉप
ये मेरे बच्चों को भी ऐसे सारे किया Hello. Okay. Now it's very difficult to teach a class when everybody is sitting so far away. So I want everybody to come. Because then I can interact with you.
Good morning.
Good morning. और कोई है? आप लोग ट्रेनिंग के लिए आए हैं कि come? No, it's all about interaction. You will know everything from the book. When you ask a question, then you will get an answer. Okay? Now we're going to be talking about anal fissure, which is the commonest problem in proctology. And surgeons don't manage it well. I'm telling you because I have personal experience of patients coming back from surgeons. Most of them are still doing What are you doing, Professor? क्या करते हो? अरे लेजर के पहले क्या करते थे? Oval lateral spindoid. Lateral. Okay. Now, if I ask 100 people, they will all say closed lateral spindotomy or laser and all. But दारू के ऊपर पूछेंगे तो 80% will say I do dilatation. Okay. Now, I got a patient yesterday who was operated in Bombay and laser hemorrhoid surgery was done. साथ में pressure दिखा. That's mostly like insurance thing and inner dilatation किया. And the reason I'm telling you is you have to remember to tell the patient what can go wrong. Patient got surgery on 29th March and 14 days later patient had torrential bleeding. What surgery? Laser hemorrhoidoplasty with anal dilatation. He had torrential bleeding after 14 days. So much so that he collapsed and fainted. Still doesn't know why it happened. He got up, walked a bit and fainted again. So you have to know, you have to tell the patient, I have operated you by laser. Doesn't mean that you start going. So he went on a trip, field trip, 1.5 hours of jeep journey and the road was really bad, so bad terrain, and then he had to sleep for a couple of days. So that is, just because you got laser does not mean that you are going to over-exert yourself. So I said, why did you do it? Well, the surgeon did not tell me. So you have to tell whatever Kamal has said, even though it's laser, you have to tell them to take precautions for at least a month. Right? Now, fissure, anal dilatation, the reason this patient came up. So I saw the patient, I put my finger in and it was loose. ये finger है, ढीला था. And then I asked him, do you have incontinence? बोला yes. छींक मारते हैं तो मोशन निकल आता है. कभी कभी पूरा मोशन निकल आता है. Now that patient can go for medical care. He's already complained and done a lot of things. So anal dilatation is absolutely out. You are doing it and you want to learn how to close lateral. Close lateral is so easy. You might make a mistake. With blade also. You can't make a mistake. With laser you can make a mistake. Because laser में क्या लगता है? You feel you have not cut enough. तो और करोगे, वापस गए और कटोगे. And that is going to lead to damage of external sphincter also. So you cut the internal sphincter and you damage the external sphincter. It's going to cause incontinence. So we know the definition here in the vertical axis of the anal canal. 12 and 6 are the commonest sites, and it becomes a chronic anal fissure when it doesn't heal within 6 to 8 weeks. And this is how I label it. This is kissing ulcers or kissing fissures. So one of the things you need to tell the patient and show. I show to every single fissure patient. This is available on meditool.com. Once they see this video, they understand the problem. The problem is the patient is having a hard stool. It could be diarrhea also, but it's basically hard stool, which when the stool goes down, it tears the lower part of the anal canal, that is below the dentate line. Once that tear happens, then the patient does not heal because there is a paucity of blood supply posteriorly and the mucosa is not supported. Therefore, the tear does not heal. In the process of healing, it comes together, the skin tag becomes big and the hypertrophic papilla becomes big and the patient starts bleeding. Why this is important to show before you do a laser in lateral sphincterotomy? Because post-op, if they continue to have hard stools, the whole thing is going to repeat. Even though you've done a good surgery, 2 साल के बाद वापस आएगा. You said it's not going to reoccur. It reoccurs because they didn't take the precaution. So symptoms you all know: pain, bleeding, swelling, discharge, and pruritus. Urinary symptoms is one of the things you really have to understand. The nerve supply is common, therefore they have dysuria. Then hard motions, differing motions is what people in Mumbai do. The young girls who have this, they don't go to motion because जैसे दर्द होता है तो 3 दिन में एक बार जाएंगे. So once in 3 days they go, or once in 4 days, कि pain एक बार है. That makes the stool harder. And then they take their own treatment. So if I don't eat, there will be no motion, which is false because 1/3 of your motion is what you eat 1/3 is the bacteria inside it, and 1/3 is the shed interstitial cells. So it's only 1/3. Motion will still occur. So acute is just basically pain, fresh blood streak, wound at the inner wall, and chronic. Why I listed chronic? Even if you are doing laser, you have to take care of the skin tag here, hypertrophic papilla, induration of fissure margin, relative venous stenosis, and pruritus, and obviously when you take care of this, that will get taken care of. So these are the secondary changes in fissure. This is an abscess, big skin tag with lot of bleeding, and here acute anal fissure. Okay, so I put it on the whiteboard. So you have to manage these things. You can't just do lateral intersphincterotomy by laser and leave the skin tags there. Because the skin tag patient feels every single day. Now, if you are going to cut the skin tag, there is going to be pain. So you can't say it's a painless surgery. Because you are taking the skin tag out and there is a painful area, it's skin. But that will finally give a patient a good relief. Now, if the fissure is not anterior and posteriorly, you have to think of other things like tuberculosis, anal intercourse, anal malignancy, and deficiency in stones and syphilis. So only less than 1% are laterally, and that could be Crohn's also. And if it's off midline and it is painless, please slow down. Don't go for surgery in these patients. Surgery is not going to heal them, especially if they have tuberculosis, Crohn's, and HIV. Even if you do a great surgery, it's not going to heal. So, if they fail to heal with your conservative treatment, do biopsy culture, examination or anesthesia. Crohn's is multiple asymptomatic. HIV fissures are broad-based and with poor spindle functions. So, current hypothesis is anal sphincter tonicity and anal blood flow. Tonicity is high and blood flow is less. And hard stools or explosive diarrhea, and the anal tone is elevated in fissure patients. But this is not for all patients. There is a category of patients, especially patients who have delivered, who have anal fissure which refuses to heal, but there is lax sphincter. And in that, if you do a lateral sphincterotomy, patient will have incontinence. In those patients, you have to make sure that you do some other procedures, like you do a fissurectomy, that is take out the skin tag, take out the lateral margins, take out the hypertrophic papilla, and the bare area, either bring the mucosa down from above or skin above. I'll show you that. So, weak support of anal mucosa is one of the causes, and local ischemia for fissures for refusing to heal. And when you see them, when you palpate them, this is your buttonhole, your shirt का button है, आपको तो नहीं able feel like buttonhole, जो side में feeling आती है, that's the same feeling. Okay, so you need to take care of that. And proctoscopy only if the finger goes into comfort. You will be able to do it in low pressure. अगर proctoscopy कर सकते हो, so that patient does not need lateral intersphincter. Correct? And if you do it for a patient who has lax sphincter, then look for other things. Look for hypertrophic papilla, look for hemorrhoids, look for anything else which is causing the pain. Look for rectum and anus. Fistula fissure complex can be there, that can cause a lot of pain. But when you put your finger inside, the tone is not high. The pain is because of the fistula which is in the abscess bone. So you have these stages of fissure. This is acute fissure with hypertrophic papilla and the skin tag. Both start increasing in size and ultimately become twisted. When you see the side picture, it gets deeper and deeper. This is the internal sphincter. It involves the internal sphincter. It makes it fibrotic, and then it can have abscess and fissure complex develops. This one, ideally, if the patient has an insurance, acute anal fissure operates, the misery will go away immediately, rather than prolonging it for months and months and half line. And this one, the patient has no choice because there is a fistula there, you have to do it. The other ones you can give a trial with medicines. So evaluation of pain, the simplest way, mark 0 to 10 on the sheet of paper. 0 is no pain, 10 is extreme pain. Patient goes, show it to the patient, and when the patient says the pain is here, somewhere here, 7, 8, 9, obviously they need treatment. So whatever treatment you do, after the treatment, after 1 month, ask them again, if this 7, 8, 9 become 3, 4, 5, that means patient is okay, doesn't need surgery, and if it remains at 7, 8, 9 or goes to 10, patient needs surgery. Don't prolong it. So when you do a PR, you have to see, is this spasm mild, moderate, or PR is not possible. And if you are going to increase your practice, you need to have armamentarium, like you need to have people taking lasers, you need to buy this also. This is expensive, but it gives you a lot of information. You can put it in your pocket, take a reading, 100 readings can be recorded by Wi-Fi onto your mobile phone. So it gives you the pressure. This is the internal sphincter and this is the external. When you put it in and patient is at rest, you get the resting pressure. The resting pressure has to be less than 30 millimeters mercury. If it's more than that, that means the patient has increased stroke. External sphincter pressure, you will only know when you tell the patient to contract. When the patient contracts like eagles, then the pressure of external sphincter is known. So management, how do you manage? You have an acute anal fissure here. You can go directly for surgery, or you can manage conservatively by lifestyle changes, diet control, fluid balance, and other medicines. I'll come to it. It becomes chronic and high pressure. You do chemical sphincterotomy. You can go for botulism. It's not very popular. It's quite expensive, and lateral sphincterotomy is the gold standard. If the patient has a low pressure, this is for high pressure. If the patient has low pressure, you do fissurectomy, that is take out all the 3 things and do anal advanced flap. And conservative treatment. This is the crux. Even if you operate. Told you about the lifestyle changes, toilet training. If they feel they want to pass motion, they should go. Prevent constipation by laxatives, osmotic or stimulative. Do not give fibers on top. Dietary fiber has to increase, that means what they are eating in food, not fiber from top. No isabol, no tripula, because they are harmful. Sea bath 3 to 4 times. Topical analgesia, lidocaine, but nowadays you don't need to give that. You have a combination of sucralfate, lidocaine, and metrogyl, and this comes as Primagel H, Enometrogyl, sucralfate A, Emosum. Anyone, whichever you are using, use it 3 to 4 times a day. This will take away what? It takes away the burning. It takes away pain. But basically burning they have after motion. So they should apply especially before motion. So the pain is relieved. It's got lidocaine, so no problem. Antibiotics, anti-emetic, anti-helminthics as per need. And long life dietary fiber. Now medical treatment means you are giving a drug which causes chemical sphincterotomy. So nitroglycerin is not available, so don't talk about it, GTM. They stopped 5 years back. Calcium channel blockers, you have diltiazem and nifedipine. They work really well, the healing is up to 90%. And diltiazem is available as Primagel and diltiazem. It relaxes the anal sphincter. The healing is 88%, but actually if the patient apply it properly, it goes up to 90 to 95%. What is proper application? It has to be applied inside, not outside. And it has to be applied 3 times a day, not twice or once, or gaps. No gaps, 3 times a day for 30 days, it will heal. What happens is patient apply 3 times a day for 3 days, then twice a day for 2 days, then once a day for 1 day, and no, you can keep over it. But that's not healing. Healing takes 30 days. And headache, drowsiness, I have not seen. But perineal itching, yes, I have seen. These drugs cause, if you change from this to lifedipine, that also causes itching. So I don't think the itching is because of the drug, itching is because of the base, whatever base they are using. Nifedipine has lidocaine with it, relaxes the smooth muscles. Fidonal, Enobliss, Lipicaine, and Escort are the 4 available ones. If you ask me between them which one do you prefer, I would prefer diltiazem. But if the patient has a very tight sphincter, even redesign is difficult to apply because the finger does not go in. So, Fidonal has an applicator which is 1.5 centimeter long, 3 millimeters diameter, 4 holes on all sides. Very comfortably, patient can do it and dosage can be right. So, what do we do in surgery? Inner dilatation annual fissure is what is going to cause. This is normal. And look at this. The internal sphincter and external sphincter are broken in many places. And when this heals with fibrosis. And because of that, because of fibrosis, the plasticity, that means the sphincter does not contract the way it should be contracted. Surgical intervention, basically you have to do a internal sphincterotomy. A lateral internal sphincterotomy is the gold standard. It could be closed or open, essentially no difference in the outcomes, but there's more pain with open and it takes a little longer to heal, but more or less healing is almost the same. Posterior internal sphincterotomy, yes, you have to do it at some time, especially when there is a fistula there, abscess of fistula. There is no way out. The fistula is there. You can't just do that, then go to 5 o'clock or 4 o'clock and do another cut. So you do it there only. Inner muscle tap and fistrectomy. Fistrectomy is mandatory with lateral internal sphincterotomy, inner advancement flap, or even Botox. Therefore, you can't tell the patient it's a painless procedure. So all you do is you palpate the intersphincter groove. Here, your finger, this is the internal sphincter, external sphincter, and I am sure Karan probably told you where it is. You put your blade inside and go up to the dentate line and cut medially. You cut the internal sphincter fibers. And the fibers which are left here because the blade cannot turn that much, you will press it and break it. The blade, usually what I use is not 11 number but 15 number. 11 number, when you turn it, cuts the mucosa. So this is how you do it. That's the intersphincter groove. One finger is inside, the same is at 11 o'clock, giving traction. And don't worry about the bleeding, just cut down. Slow motion, one single stroke, not multiple strokes. After that, you press it, it's called pinch cock. Once you press it for 5 minutes and you leave it, then there will be no bleeding. The thing is, we press it only for a minute, and it starts again. This is how it should be. And I'm going to show you the same thing closer, close view. So that's the intersphincter groove, 15 number blade. Go all the way. That ratchet, the distance of the ratchet is 1 centimeter. That's all you need to cut. You don't need to cut more than that. So one single cut and that's it. And you have to just pinch cock it. Pinch cock his finger is already inside. Press with the thumb. This is one more patient showing you the same thing. Going in the intersphincter groove. You have to cut the internal sphincter fibers, not the external. Some people go from medial to lateral. I don't like that because I don't have any control. Lateral to medial, you have more control. This is pinch cock, how you do it. And in case you cut, don't panic, just take a 4-0 bicular rapid, take 1 or 2 interrupted sutures. Now, open lateral can be vertical, that means this is the intersphincter groove. From top to bottom, you do a vertical cut or you do a horizontal cut. Most popular is horizontal, but in USA, vertical cut is more popular. So, I'm just showing you the lateral one. So you get an incision, half centimeter medial to the groove and half centimeter lateral. This is larger because we wanted to show you how it actually is done. So first you see all the quadrants, what all are there, how many hypertrophic papillas are there. So this is saline adrenaline being given. That's traction. There's another way to give traction. You have 2 right angles, you're pulling it. So incision, even if it's a larger incision, you have to give a suture afterwards. If it's a small incision, small means you can make 5 millimeter incision. Take a mosquito, separate the mucosa and lift it. Remember, what you lift has to be the medial motion. If you lift little lateral, you will be cutting the external sphincter. To cut the internal sphincter, you have to be medial. And after you cut it, you can give a few sutures and close it. So, this is what I'm saying. The muscle you get initially is the external anal sphincter. Don't cut there. You have to cut medially. Medial to the intersphincter groove. Now, what does fistrectomy mean? It means taking out all of this So when you take it out, that's the skin tag, lateral margins here, and the hypertrophic papilla. It doesn't come out like this all the time, but if you put saline and below it, it gets lifted. If it's very thick, then it will come out. Otherwise, it will come out in pieces. Now, anal and muscle flap, what we do is you excise this, create a skin flap, and put it up. Not necessarily so high up, but you can put it up. And it's not that difficult. Now, lateral internal sphincterotomy is a standard surgical treatment, but you can't give it in patients who have low pressures. So sphincter sparing angioplasty is advocated for an alternative procedure for low pressures, and simple cutaneous advancement angioplasty should be considered as the first line of surgical treatment in chronic pressure. So what you do is, after you take out everything, you just cut this much. You cut here about 1 centimeter, 1.5 centimeters across, and 1 centimeter down. After you have cut it, you have ripped it up, you just stitch it. So your line is closed, the fissure area is closed. This is something like that, which I've done. So, what do we do with laser? After all, you've come here to learn about laser. You have 3 techniques: open, closed, lateral to medial, and medial to lateral. So, it's a diode laser, you already know, 1470. Bare fiber is used, and the wattage given is 10 watts continuous mode, millimeter per second. And this is so what it looks like. The beauty of the bare fiber is every time you cut 1 centimeter, it becomes brand new. So you can use it over and over again. I'm just showing you how it looks. This is an old fiber, yet you have the spray which is coming out correctly. So what open lateral sphincterotomy, basically I give a vertical incision and take out the muscle, cut it. I may give a closure or leave it alone. So that's where the laser goes in. So with the laser, you make an incision which is 3 to 4 millimeters. That's all. In the intersphincteric groove vertically, and then you put your mosquito inside here, work with the dentate line with the mosquito, turn it. At this point you can change your gloves. If jelly is on it, this portion becomes quite slippery. It keeps slipping. And once you have elevated this, you just cut it across. And then go back in again. If you see any more fibers, you can cut that also. Just cut it with laser. That's all. It's as simple as that. And I would personally leave the wound open. It heals faster. Then you have medial to lateral, which is the commonest one being used. So what is this in yellow? Yellow is the tumescence. The reason you need the tumescence is you take away the mucosa, it stays away. That's one. Second is it takes the heat also, so you don't damage the mucosa. You go in the intersphincteric groove, go up to the dentate line. Once you have reached there, and immediately you start cutting down. So this gray zone is what it's cut, and that's how the fiber comes out here. How do we do it? The most important thing is identifying the intersphincteric groove. Now this is, I'm taking the faucet down, that's where the intersphincteric groove is, and dips in. So you give tumescence, saline adrenaline, or sometimes I use xalapine adrenaline, which is pre-made, and then introduce the laser fiber, 10 watts for 1 second to introduce, then go all the way up to the dentate line. Once you are at the dentate line, you know where you are, you know you have to go for 10 to 12 millimeters, and your wattage should not be more than 120 or 130. And if you use 400 watts for this, then be sure your H1 sphincter is gone, and that's ice being applied to it. So how do you do medial to lateral? You know where the intersphincteric groove is. In the intersphincteric groove, introduce up to dentate line, and then turn the handle medially and cut down. So when you cut down, so you have cut this gray zone. So I'm coming from up and down, and this step has always to be done, always. So now you know where it is. creating the tumescence. Tumescence helps when the fiber comes, cutting the intersplinter, then it's not good. So I've gone in the intersplinting space. I'm feeling with my finger because you need to know where it is, and then you're coming medially. If you push too medially and the fiber is too superficial, you're going to cut the mucosa. So you have to be really careful when you come down. I use it, but very rarely do I do it. I usually try to go medial to lateral. Have I found any difference between this and medial lateral and lateral to medial? Lateral to medial, they say there is less pain. That's the only difference. But that could be, patient-wise also. I've not done enough to actually say it. In the bottom, I felt some fibers were left. I went back in and did it. So the precautions you have to take, you have to identify the intersplinting groove. Tumescence is a must. Entry 10 watts for 1 second. Ablation is 10 watts continuous mode, millimeter per second. Slow, steady, single stroke. It should not be too slow. 1 millimeter per second. Don't go half a millimeter or slower than that. If you do that, you are giving too much energy in that area. Check the intensity of light. So too superficial will damage the mucosa, too deep will damage the muscles. Apply ice immediately for a minute. So then you have to tackle other things which can be there. You can't leave them there. And this patient had a very big hypertrophic papilla, as you can see here. 2 of them. So I'm showing you again. This is the intersplinting groove. The first thing I'm going to do is create tumescence, and once the tumescence is created, I will also create tumescence here under the hypertrophic papilla because I want absolutely bloodless field. And now I have got my laser fiber there. I'm negotiating it. Be slow. Just wriggle it side to side till you reach the dead line. You're not sure, turn the OT lights off and you will know where you are. And then you start cutting down. It is so slow, you feel that I have come so fast. Because the distance is only 1 to 1.5 centimeters. And when you come out, one tip I can give you is, don't burn till the end. When 1 millimeter is left, leave it because that skin burn will not be there after that. Apply ice. This is what it looks like. Now I'm cutting the lateral margin with the laser fiber. I don't use cotton because too much of lateral burn here. Now I'm left with this. When you are doing this motion, some people tend to go in deep and cut the muscle also. Remain superficial. It's some mucosal problems. Stay on the mucosa, don't go deeper and take the whole thing out. And then you can spray the base. Once you have done that, the most important step in doing all this is you have to cure it. Unhealthy tissue goes away, and after curating, you can again spray the base and leave it alone. So you have decreased pain, decreased recovery time, minimal risk and side effects. But if you really ask me, what is the advantage over closed lateral splenectomy? It's the patients. These patients, you say, I'm going to do closed lateral splenectomy with a blade, will go to the next surgeon. And the next surgeon will be an Ayurvedic surgeon who has a machine. So you need to have laser and say, and then you want to use it, you don't want to use it, that's up to you. But you tell them, I have the laser, I will use it wherever is necessary. Second is, you get 4 times more money when you do use laser than you don't use laser. So if you want to buy the machine, never worry about the cost. The cost comes out, depends on your practice. You have a very heavy practice, it comes out in 1 month. If you have a very bad practice, it comes in 6 months. But it will come out. 1 year to koi lagta nahi hai, 6 mahine ko ऊपर जाता ही नहीं. So are you sure you know everything about the fissure? Why it happened? What is your evaluation? How would you approach? Role of conservative treatment? Which medical therapy? What surgery? And what to do in recurrence? So I didn't talk about recurrence because I wanted to ask you. Patient comes with a recurrence. What do you do? वापस हो गया, वापस दर्द हो रहा है, and you didn't operate. Let's go there. You didn't operate, you operated somewhere else. What would you do?
First first we have to clinically assess the patient.
Yes, you have to clinically assess.
Is
You
there
have to,
any spasm of the sphincter is there?
Yeah.
Is
So, if there is no spasm, then you have to be careful. If there is spasm, then naturally, what will you do if there is spasm?
the spine will do the again.
You have to do it again. That's basically what is said. You need to do it again.
So I think in the lapsing, initially if you're done at 3 o'clock, you can do it at 9 o'clock.
Yeah, that's true. But actually, it's not easy for a right-handed person to do at 9 o'clock. You can do it at 7 also. One of the things you haven't asked me, but most people do ask me, is at 3 o'clock the hemorrhoid is there. So how can you do it at 3 o'clock? Well, you have to realize that hemorrhoid is above the dentate line, and the region you're tackling is below the dentate line. Therefore, you can do it.
So one thing I would like to add,
It's not working. So yes, yesterday we were reading the paper in 1680.
Mind नहीं चल रहा.
चलाएंगे please.
Mind चला.
sir, I think there was a paper in 1680. It was mentioned that the fissure is more common in females during menstruation, and the reason given is at the time of menstruation there is usually spasm of the internal sphincter. Any of you who have seen the similar cases?
I think it's because of the estrogen level which goes up, and therefore the stools become harder during menstruation, and that's why they have problems. They have harder stools.
Thanks.
But you are talking about a time when there was no hormonal evaluation, so they had no idea what with hormones were.
Thanks.
But yes, many patients come and say, this is a very good point he's mentioned. You should ask the patient, does your problem increase during menstruation? And you will be surprised at the answer, yes, it increases. Now the second topic we are going to talk about, is there any question for the first one? For Fisher? Kamal, any questions? Okay, so that means you're all good to go. You don't need any questions. We talked about bilateral sinus disease. Now, we are going to be talking about exit, that is endoscopic, laser, and valve. Valve is endoscopic plus laser together. So this is going to help you. Now, basically what we are going to be treating is a sinus or an abscess, and abscess and episad. Episad is only endoscopic bilateral sinus abscess drainage. Laser for sinuses and valves for sinuses. So what you see are these patients which have subtle changes, and you need to pick up these changes. So you have an opening here, you have an opening here, and you have pits. So don't miss the pit. They're very subtle. Only way you can do it is when you shave it and you take a photograph, you will see it. So everybody has a good camera. If you do a great job of this place and you're not taking care of the pit, the patient is going to have a recurrence. Now what happens is, you see this here, here, this goes in, and once this goes into the pit, so it is going in like this. You can't really see it. If you were a bacteria, you would see it. And actually the hair is like this. You see the scales on the hair? And this is what the hair looks like. It is unidirectional, it's not scales. It can only go in, it can't come out. एक बार अंदर गया तो अंदर ही रहने वाला है, it's not going to come out. And the tip is sharp like this. People keep saying, यार वो कैसे घुस गया अंदर बाल? Because the tip is sharp. And you have a sharp tip like this, 10 or 12 hairs, fine, एक बड़ा सा spear बन गया. It goes in easily, especially people in whom the final area is wet. So moisture makes the skin soggy and it goes inside. And what happens is, the picture on the left is what you have to remember. What it shows you is a normal follicle looks like this. A stretched follicle is this. If it becomes infected, it becomes bigger. An acute abscess can develop. A chronic disease can develop. And this epithelial tube is there. Now, when you are managing these patients, if you don't take out this epithelial tube, they are never going to be well, no matter what you do. So it's a one-way movement. It goes in from here and then it goes out. Doesn't actually go out. It just, you can see the hairs projection. They don't usually come out. I have not seen them come out. So what surgery are you going to do in a vaginal surgery disease? So excision or no excision. So two options are there. If you want to excise, you want to maybe leave it open and heal by secondary invention. You can saucerize it, you can muscularize it, you can apply a wax. If it heals, you do a primary closure, midline or off midline. The choice is off midline. Don't go for midline. Midline closures don't close. And if you use it on the table, it looks beautiful. When the patient comes back, it looks good. After 20 days, it starts opening. After 30 days, the rope is full. Full thing is open. And then, whatever you do will not close. Whatever you do. Okay? So, do off midline. Okay? Then you have flaps. So flaps, the commonly used were limbal flap, bascom flap, and pterodactylus. Limbals is quite easy. Bascom you can learn. Pterodactylus is a little difficult to learn. And no excision, what Kamal and I do, minimally invasive, we have EPSET and laser. So why I don't like flaps? So I show you the patients who I get. This is a doctor who was operated. First the limbus was done, then 1 year later he got a recurrence. Then a bascom was done, then 1 year later he got a recurrence. And he came for minimally invasive surgery. Now it's been 3 years, 4 years. He's okay. I did it by endoscope. I didn't have a laser at that time. And this is a well done limbal flap. You see the recurrence there and here. Now this is a Z plasty. This opening is 9 centimeters long going all the way down. This is a double VY plasty and you see the opening. Such a big grotesque incision was taken and it happens. 50% of the patients are done by plastic surgeon. So you can't blame the surgeon ki unka fault hai. So after midline closure, so this is, we are very happy and this patient's midline closure was done. And here you see the gap. So it doesn't help. So can we do minimally invasive surgery? Yes. So the idea is to go and operate from inside. Please stop thinking कि वो deep nasal cleft को superficial बनाना है. If you see 100 patients, 50 will have deep nasal clefts, but they don't have parietal sinus disease. So that deep thing, उसको superficial करेंगे, that's why the flaps came in. And then people enjoy doing the flaps because you have a lot of measurements and lateral measurements, vertical measurements, कहाँ करना है, how far from the anus. It's really interesting for a surgeon to do all this thing. But remember, for a patient, it's a nightmare. If the surgery took a longer time to do, healing took a long time. Precaution was not to lie on the back, lie on the sides for a few days. And then precaution to not squat for 30 days. मतलब कि western toilet कर सकते हो, Indian toilet नहीं use कर सकते. Because the moment they squat, it spreads and the flap will open up. So after that trauma of 30 days, continuing for 3 months, they see another one coming up. You think they will go for a second surgery? They will not. And that's where minimally invasive surgery comes. Do not touch a parietal sinus without making this diagram first. Okay? What is showing dots is called the navicular cleft. How do we make this navicular cleft? Patient is standing up, both the buttocks are joined, and take a marker pen, draw from top to bottom. Patient lies down. All that is inside usually is a primary pit. You see, pits. and all that is outside is usually a secondary sinus. How will this help? Because you can then grade the patient, what type of disease the patient has. So these, for this patient, these are the pits, and the secondary opening draining sinus is here. And when you make the navigator cleft, that is like outside the navigator cleft. So you have Cass's classification. So you have the types. This only inside. Abscess is there. Multiple sinuses. Some are outside and recurrent. And treatment is accordingly. So the steps I'm going to show you. The steps of EPSET and laser are the same. It is when you want to ablate. Either are you ablating with a cautery or are you ablating with a laser? Now, the first thing is punch biopsy. These punches are available on Amazon. They cost 120 to 150 rupees a piece. You can get a whole set. They are very sharp instruments and they come in sizes from 1.5 to 6.5 millimeter. They are color coded. This one, blue, is 4 millimeters. The commonest one I use is blue, pink and yellow. So once you make that punch, anybody, वो punch से क्या पैदा होता है? Remember the second, third slide I showed you, epithelial tube. How do we take out the pit? We use a 11 number blade and we cut all around it. When you use this, when you use the punch, you don't need to do it. Okay? If you use the right size, the whole epithelial tube comes out, one piece. ऐसा पूरा ऐसा गड्ढा करके एक पूरा piece निकले. So you don't need to do anything after that. Then comes the important step that you have to curate the sinus. Now the problem is when you read, when you see the neck and you see how to do it, you're going to see that they are telling you, take the laser inside, laser the whole thing, curate it and laser the whole thing. Now that's not the right approach. If you take the laser inside or a cautery inside and do it without cleaning it first, the hair gets burnt and parts of hair get embedded in the wall. Actually plane में मैंने बनाया था पूरा फोटो, internet नहीं था, forgot to download that. So those hair pieces get embedded in the wall. And because they are embedded, the patient has a recurrence. So you need, I have taught everybody, पहले clean करो. पहले clean करो, wash करो, clean करो, wash करो. Now sometimes a lot of hairs are there and you keep doing it for a long time, you get tired, चलो करते हैं. Don't do it. Wait till all the hairs have come out. So curate the sinus, and this scope is 3.3 millimeters at the tip. You introduce it. The beauty is that you will get a big view. So after I have cleaned it, I go inside and see. And you will be surprised, even though you thought you cleaned it completely, there were still hairs left inside. So that can be taken out. Then you can use a ball tip cautery which is introduced to the working channel. And this is cauterization of the tract. And outside, this is how it looks. You've not done anything to this area. You have not touched that area. If you see that area after a few months, you will see that it's clean. Now these are the punches, and these are color coded. Color coding is interesting because my staff knows that now this one and this one. So they make sure these two are available. Sometimes I use a 6th one when the opening is larger. Obviously 4 is not going to help me. Why I use 4 is easy for the scope. Scope is 3.3, so I don't keep too much margin to the scope. So that's the yellow one being used. You have to do it. Now remember, always punch the pit. The pits are smaller, so you don't need to use big ones. You see the size. I've never used 1.5, but 2 is what I use. So these pits are small. When you do 2, the whole thing comes as a cylinder. Now this is what I'm showing you. See the pits. 4 here and 3 more here. At this time, I never used to do, I used to cut. So I cut these 4 together and then I cut these 3 individually. But if I was using the pit, I would have used the pits this here and that I would have cut it together. There's no point, there's no margin left. Then you can keep the infiltrating tube which we use in laser to reload the fiber, and the same is kept inside for 24 hours. For any collection, bleeding which was not there, which could be there, that will come out. and this is the dressing done for tube in tube. So the recurrence I've already shown you. Now this patient, you are going to curate the sinus, take out the hairs. Visuoscope is introduced, and this is the light behind the visuoscope. You will see. I will clean with hydrogen peroxide, and after cleaning, I put in the cotton wire, and I do it. And after with the cotton wire, then I will do it properly once again. Now this is all four together, and this step will 40 ethylone, 3rd post-op day, 10th post-op day, 14th post-op day. And this is another patient. This is the first patient I used the punch. Before that I never used the punch. So you introduce the scope goes in, you take out everything under vision, and that's what it looks like from inside. And with the grasper you take out everything. Punch I'm doing. You can see the punch inside. So that's how deep it goes. It goes through the full thickness of skin. And they have minimal tissue trauma, and this is what it looks like in the end. After a few weeks, 3 weeks minimum, it takes and healing occurs. And these, if you see after 1 year, you can hardly see the scars. So minimally invasive, 95% healing, safe with minimal mobility is great in fat people, where the flap is going to be a problem. No limitation of movement from day one. So sometimes I meet these CEOs and I see them in the parking lot. I'm like, क्या कर रहे हो? बोल रहे हैं cigarette पीने आए थे, घूम रहे हैं. There's no restriction. उनको football खेलने जाना, football खेलो. I have left it open. There is no restriction in movement. Now contrast to that, we have flaps where we have so many restrictions. Then we come to laser, and laser, as you all know, Karan has popularized it. The reason he has done it is because he is showing safety first. If you follow the safety steps, you cannot go wrong. If you don't follow it, use your own brain, and I think इसमें ज़्यादा लगना चाहिए, that patient is going to have a problem. Now, the usual machine, he has a NeoV, I also have a NeoV. I recommend it, it's good, it's sturdy. I've had it for 3.5 years. I never had to add it, and the company guy to come and see it. There is no locking on it, and it works beautifully. The fiber I'm going to use in my sinus is a radial fiber. Energy delivered is going to be 10 watts continuous wattage millimeters per second. It's on withdrawal, and the machine obviously is 1470. So if you got a 980, your settings has to be less. If you got a higher one, then you're going to have a problem. So this I've already said, that what I want to say, when you're doing binaural sinus and it's quite big, there has to be fan manner of the sinus if the sinus is wide. All tracks have to be done, and laser ablation of all the pits, which I have stopped doing, but I'm telling you. Now look at this. They make the hole, and the first thing they do is laser it. Now they've not cleaned it, they've started doing laser. This is where the hairs get embedded in the wall, and that's why the recurrence rate is higher. And they're doing the pits. Now, I'm saying instead of burning the pits with laser, you cut it out with a punch. So one step khatam ho gaya, less burn will be there. And after cleaning it, you manage the way they're showing, you manage it like this. They're cleaning it afterwards. You clean it beforehand. And then do it. Your results will be much better. So they've scooped it and put the fiber back in. Now, according to me and hopefully Dr. Kamal, this should not be. Because you haven't taken out the material. Main cavity में से material निकाला ही नहीं. Okay? So that's why you don't take everything you see on the net as the right thing. And don't think because it's on the net it's the right thing. Learn the right thing. So nowadays the new fiber has come in, and this new fiber has a 4 millimeter ring. It's come in last year only. Before that it was a 1 millimeter. What is the difference? when you have a 1 millimeter ring, when you withdraw, only 1 millimeter gets burned. When you have 4 millimeter, 4 millimeter area gets burned. Therefore, you can't stop between. You have to continuously go out. People say 4 millimeter के बाद वापस खींच के करें. नहीं, you can't measure that force. Continuous. Just take it out. So, the primary pits, these are the primary pits, and the secondary openings are here. And the laser fiber, well, how do you actually introduce it? First of all, you put a probe inside. On that probe, you put this infiltrating tube. Infiltrating tube is taken out at one side, it's taken out here. And on that, you load the laser fiber, and then you pull it. Why this is necessary? You think it's going to go straight, but you try it, it gets stuck. So few times it gets stuck, and you pull it out, that tip may get lost inside, and then you lost your fiber. So if you do it with coverage in the infiltrating tube, it's okay. Previously I used to use a tight fitting infiltrating tube. Now I don't do that tight fitting. I pass it through the probe and it's loose, and I just go all the way till I see that fiber coming out on the other side and take the tube out. And how do we do it? Fan shape. So I'm doing it here, I'll go like this, and here I will go this way, and here I will go this way, so I cover the whole thing. Sparing the skin, rapid healing, minimal dressing, no mobilization. Don't do it in abscess or open binary sinus. Now if you give the choice to the patient, मैं flap करूँगा और मैं ये करूँगा. Okay? So you always choose minimally invasive surgery. So those people who say कि मेरे patients पैसे नहीं लेते हैं, तो बोलो मैं फ्लैप करूँगा, it will cost you 50,000. और मैं minimally invasive करूँगा, it will cost you 1 lakh. They will pay you 1 lakh. So I had anybody from Aurangabad. I had a student who was from Aurangabad. He came to meet me this end of March. And he argued with me कि मेरे औरंगाबाद में तो 10,000, 15,000 से ज़्यादा कोई पैसा नहीं है. So I said yes.
7,000.
Huh?
7,000.
7,000.
Income online bazaar.
So 7,000. And he argued. No sir, it's not possible. I said you have to value yourself. You have to do a good job. The patient gets a VIP treatment. You have to treat the patient properly. You have to evaluate everything. Make sure you left nothing out. Make sure you have done the drugs properly, not in a hurry. Make sure your follow-ups are good. Make sure you yourself dress the patient. You don't send that you whatever you do that dress for. I still do every single dressing myself. Because that dressing is going to train me. I know where things can go wrong. Sometimes when you do this, the external opening closes and there is just serious fluid collection there. The dressing person will just clean on top and go away. But when I feel something clogging, I just open with a mosquito or even maybe with a probe, just open it and the fluid comes out, that's all. That's all it takes, but you have to do it. And then tell the patient, 50,000 open, 1 lakh close. So this, he came to me after 5 months. बोला सर 5 महीने में मैंने 150 केस किए and I have earned 1.25 crores. वो आदमी जो आर्ग्यू कर रहा था कि 15,000 नहीं देते and I said अभी कितना चार्ज करते हो? 1 से 1.5 लाख. अभी कैसे देते हैं? क्योंकि आपने बोला, मैंने मांगना चालू किया. So you don't ask. You are just worried. वो दूसरे के पास जाएगा. जाने दो. If your work is so good, वो घूम के आपके पास ही आएंगे. But it doesn't mean कि आप चुपचाप कर रहे हो. You have to be known in your city. The general practitioner should know. The gynecologist should know. The surgeon should know. You should start giving lectures. Everybody is aware. Then they send you patients. When Kamal came out, I said, you take yourself कि you are being successful only when you start getting patients from surgeons. Now he gets patients from surgeons. I said, now, top of this is you are successful when surgeons themselves come and mera surgery karo. So he's getting it now. That's the ultimate. Who's the person who decides to worthwhile ho ki nahi? Ek aur surgeon. When they see your work is good, they will send patients to you. मैंने कहा हमारे पास तो इतना लेप्रोस्कोपी वर्क, आई डोंट हैव टाइम फॉर दिस. ठीक है, तुम बैठे हो ना करने को. You get it? So my majority of my work is from surgeons, and because either it's a recurrence or it's mostly recurrence or a difficult case. So let's see how to do it. 24-year-old Hirsut. This is what she was before 1 week before surgery, and I gave her antibiotics, cleaned up that place. This is on the table. The buttocks are strapped, and the primary fits and the secondary fits in yellow. Now I open this up and I try to pull out things. Nothing comes out basically. Then you take your curate and you go in. That's the first step. Now see the amount which is coming out. So using a 4 millimeter here because the opening was big. I need to take the walls. I've shown you how it looks. And there, that tip was big. So 4. See this ring? That whole ring comes out. So the epithelial tissue comes out. And this was a smaller pit, so I used a yellow. Again you see the ring. And then you put in hydrogen peroxide. And you clean it out. Dry this, that means take a mop and press on it because you're going to use laser. So, wattage I'm showing you, the radial fiber which is going to be used. I cut the tip of this infiltrating tube, pass the laser fiber into it, and now take it out on the other side. And on withdrawal you do it. You start your ablation while pulling it out. And you got the suction is there on the other end. And that's how you have to do it, fan shape, going from each of the openings. Then from the other opening. It's all on withdrawal. Don't do it while pushing it in. Because you really don't know where you are. Pit I used to do, I've stopped doing the pit now. That's how you do it. And waterproof dressing, you can apply on top. This is next day when the things come out, and this is where I take the tube out. Now, this is going to show you everything possible you can do. This is a tall, obese patient who had multiple external openings. So I'm just going and showing you the tracks up and below. And we need to take all of this out. One of the ways you would put the thing is, I put the probe in, and on that probe I loaded the this thing, punch. And I'm taking it out. ये रुक क्यों गया? Battery is running low. Okay. मेरा बैग कहाँ है?
So just click on basically there is complete excision of the track.
How intelligent the laptop is. बैटरी कम हुआ तो रोक दिया होता, otherwise नहीं रोकता. Okay, so I've got my waft instrument inside. So under vision I'm just seeing and cleaning everything. So it gives a good view, very big view, depends on how big the. See, I thought everything's clean, you can still see a few fibers, hair fibers. That's why it's important. A single hair fiber can lead to a recurrence. And after you do, suppose you're doing laser, after you do laser, you need to go in and curate it. Because the fibers which are embedded in the wall, once you do it, they become loose. And you'll be surprised कि अरे इतना clean करने के बाद कैसे fiber आया? It comes. So after everything, I'm doing cleaning it again. Now, you have, because this is a minimally invasive procedure, you can't fall short in curating it. Curating is one of the most important steps. And people tend to just put the fiber in and do everything, come out, बोले एक बार में वो लेजर से अंदर गोंद बन जाता है, that is the magic solution, it will stick to it. No. Laser is an unusual device which is going to take out the unhealthy tissue. I put laser in, come out, वापस अंदर गए वापस आओ. First time I curate, the second time I curate again. Unhealthy tissue comes out. Rest, the nature is going to take care of it. Now this is how we do the railroading, which is quite simple. Probe is helpful. So you put this in and take it out on the other side. And on withdrawal, the same thing, just I'm forwarding it. Then again, with the scope, I go back in to see if everything is okay. So, even a really bad one like this would take not more than 1 hour. The other ones would take about 15 minutes to 30 minutes. So, you are earning 2 to 4 times more, and the patient is spending 1/3 the time. Now, you should ask me कि आपने हेमोरॉइड्स में कूलिंग किया, प्रेशर में कूलिंग किया, इसमें कैसे कूलिंग करते हैं? So you take ice in a kidney tray, put saline on it, and wait. In 5 minutes, it becomes ice cold water, and then just flush it with ice cold water. So that is going to cool everything down. Cooling is to prevent the latent heat. हम लोग बोलते हैं latent heat नहीं समझ में आया, तो हम एक गैस के ऊपर तवा रखो, गैस बंद कर दो, हाथ रख सकते हो? That's latent heat. That's latent. So combination I've already shown you, but what it looks like when you are there. This is how you can take it out with a grasper. All the things inside, clean it, then you can put the laser fiber and burn it. So this I already told you. Now I said don't do it open. I just said don't do it open. This patient had secondary opening, pit, and this was all open. Ideally I should not be doing it. But this is 2 months back. So I told him कि जो बाल दिख रहा है ना वो बाल निकाल दो. So he took it out. And he kept sending me the pictures. This is the first picture I got. And 1 month before, his cleaning, his healing is becoming narrower. And this is 1 week before and at the start of surgery. So I go and see where the tract goes to, and that's the tract. Now I have the option of doing a flap or doing it with laser and endoscope, and the lower portion, close it. So that was a risk. I told him I'm going to close. It's a midline wound. I don't want to create another wound. Let's see. And it was quite superficial. So upper portion I managed by laser and by endoscope. This is withdrawal. That's the wattage. This is how it looks. You curate it. Now see this. You saw the hair? That's after laser. After cleaning, after laser, it was in the wall. And this portion, I just elevated. Curate the thing, elevate it and close it. That's how it looked at the end of surgery, and this is healed at 8 weeks. Now this is Kamal's picture. He said कि खाली laser के साथ करना है to be thorough in the track and make sure you don't miss anything. Creation of a second opening. So how that is done? You put a hanger diameter inside, the thinnest one, 1.5 millimeter, and wherever it goes, that end point, you elevate it and make an incision on the skin. That's the hanger diameter gone in, and that's where it was fed and it came out. And then you have this whole track which you can approach from top and bottom. You can clean it, you can wash it from both the sides, and after doing all that, you're very thoroughly is there. Now, this is when the patient has only one opening, and that was the bit. And then this is the hairs which were inside. Then the wash was given from top and wash was given from bottom to make sure everything comes out. And when you're giving this wash, you have to do it with force. So anything which comes in, comes out. And in withdrawal, now I would like to sort of just mention the point where the pit is. That skin has to be taken. If you don't take that skin, it's already gone in. So it's never going to close to the epithelial tissue. That has to be taken care of, and this is how it looks in the end. And I think this is the last video I'm going to be showing you. Do you see the fits? 4 millimeter in the secondary fit. Secondary sinus, it should be sinus. And then you clean everything out, curate everything out. Now it looks so subtle, and this is 2 millimeters. See how the ring forms? And then put the scope in. Now if you want to really advance in proctology, you need to buy, you have to invest about 25 lakhs. You need to buy the laser, you need to buy the valve, you need to buy the anal manometry. If you don't invest, you don't get the money. Only if you invest, you will get the money. ऐसे खाली मुफ्त में नहीं आता, खाली एक scalpel लेके you can't do it. You can do it, but the number of patients will be less, and you're not going to go in the higher bracket. One more. This one. Now, a young girl who wants to get married, but she had this 3 months after her surgery. And it's a nightmare, traumatic for her. She just doesn't know what to do. So she was sent by a surgeon, please manage. See how this is going in here. This is what I said. If you don't take care of this, it will come out. And I've got the probe there. And now what I'm going to do is pass the punch on top of it, and so that I'm very accurate and I take the track in the angle of the track. So, grasper is passed, and grasper, what it basically does is cleans out and takes out all the hairs. So you see the hair there, that's going to be taken out, and I will make sure that there's nothing left inside. The rest you can cure it out. Unhealthy tissue you can cure it out. But the hairs you have to pick up individually. So the scope is gone for the below up. Principle is the same. There's nothing new, little changes, that's all. Kept an infusing tube, 21 days, washing it, and it's healed. This is 21 days. So, 2 papers. First is 237 patients, healing 90 to 98%. The second one is by Kamal. He did really hard work, and he also coined the term VALAPS, video assisted pyramidal sinus, laser ablation of pyramidal sinus. In our study, we showed 95.3% success rate. The future of parental sinus surgery, the shift is towards endoscopic treatment. I'm not saying this, it's come out in the reviews. Parental sinus disease, review of current practice and prospects of endoscopic treatment. So if you don't start now, other people in your city take over and they start doing it. And then you say, oh God, I learned it, but I didn't do anything. So don't wait it. Laser and parental sinus is the fastest way up, and it's time for change. Yes.
So any questions you can ask? I have listened to his lecture for the first time, and I am always there with him. Give me a laptop. Give me a laptop there.
देख लो नहीं तुम्हारे ये होना चाहिए कोर्ट ये है ये वाला
Lunch is ready. We will just proceed for meter after that. Doctor Sahab,
Yeah.
any questions?
Yeah, I have.
हाँ बोलिए बोलिए बोलिए
So one question.
We are online.
या बैठ के बोलो
One is what drain you have used between the two secondary pits. Drain.
intervening tube.
Infantry.
The one I use to railroad it, same one I
Oh,
use.
same.
Is 7 number or 8 number.
Second.
Ah.
You always close the primary pits.
No. Sometimes you will leave them open. They will hit in the same rate. If you want to close, not more than one suture.
When we
Light
should,
on कर दो.
when we should stitch or when we should not stitch.
When the opening is large, suppose you have not used a yellow one, you have used a blue one.
Blue.
That opening is going to be big.
Six.
Great, 4.
Okay.
So then you, अरे light चालू करा दो. Then the opening is big.
Then single switch.
That single suture is enough. That's it's surgeons.
And we have to basically put the disease margin of the that pit.
So it's not the disease margin. It is the skin which is
So
bothering. The
undermined
problem is
margins.
सब कुछ करते
Undermined
हैं.
margins.
So they, if you cut that skin,
Definitely.
that's what
Otherwise
Bascom
we will
said. Bascom's cleft surgery was that only, taking out that pit. That's essentially the most important part.
And one more question.
Yeah.
After doing the laser,
Ah.
you again curate the crack.
Yes, I do it
Then
because
second time.
yes,
you
second
can
time I
do
cure it
laser.
again. I do laser again and cure it again.
Okay.
So people do
lastly,
only
lastly you curate
Cure it.
or you laser.
cure it. Laser is going to leave dead tissue. Laser does not give you glue inside.
First laser, then
It is,
curate,
remember,
then laser, then
लोगों को लगता है laser is a magic solution. It's not a magic. It's an energy source. It's like cotton, but it doesn't give that much heat. The lateral burn is not that much, and it's radial. So everything gets corrected. So I curate it afterwards because I need the healthy tissue out. Once the healthy tissue is out, the wound is going to close. Why shouldn't it close? Okay.
So post-operatively you irrigate, we advocate the patient daily irrigation or
Not daily irrigation, but I call them how I do it. First post-op day, he's already in the hospital. Then 2 days after that, they come. Then 3 days after that. Then 4 days after. I feel there's something wrong, I call them earlier. And then you can teach the patient. It's very simple. Irrigation cannula is there. It costs about 500 rupees. And you just push the line through it. That's all. So everything inside you will come out. Initially you might have some collection. Initially you may have to take a curate number, the tiniest curate, go in. You don't need to give local. It's very fine. It is smaller than the hole. So as long as you're not touching the skin, when you put the curate in, patient is not going to have pain. Inside there is no pain. It's only when you come to the skin. So that why I'm curating it? The dead tissue which is there, I'm just taking it out. I leave it to nature to heal. And it heals.
when you remove the drain, then it ready to
24 hours, 36 hours, either at the time of discharge or next day after.
sir, routinely you are using MRI to investigate or
No, what investigation?
Special investigation.
For binaural sinus, I think I must have done only one MRI till date. And that was because there was pain at the coccyx also. So I wanted to know what's the relation with the coccyx. And the patient also had doubtful fistula genu. Otherwise, for hydradenitis, I don't do MRI. I don't do any investigation apart from routine blood investigation, chest X-ray, ECG. You don't need to investigate. At the most, if you have an ultrasound in-house, you can see for secondary tracts or abscesses. And I think surgeons should now learn how to do it. If you have one in the hospital, so go and sit with the radiologist. It takes only a minute. Okay, but I have it. I don't use it for 5 minutes. Work rate?
Mr. Mirani, tell us that we next finish our lunch and we have to proceed with the course.
KG. KG.
कुछ प्रॉब्लम नहीं है आ जाना चाहिए था
थोड़ा सा वो कम करो, हाँ, this is fine, that is fine, that is fine.
दीदी थोड़ा ये हट लो।
थोड़ा स्लो करो, फोकस करो, हाँ, that is good. पर जो भी दिखाना ना इतना इतना नजर आना चाहिए अंदर, हाँ. Give me 3 golf pieces. So this is the first case which we are going to start. The patient is having bleeding per rectum, and it is second degree hemorrhoids.
Karan, just wait, live me one. Hello.
Yes sir, I'm waiting sir.
Just a minute. There's no point to public need it पाएगा तो क्या करना?
ये थोड़ा सा ना ये साइड पे करो, मेरे को टीवी देखना होगा साथ में ना. हाँ, that is fine. So I think everybody can come in the OT and stand behind my back. You can watch on the TV whatever exactly I am doing. So this is a small skin tight which is present. We will see what is to be done.
Yeah. Can you lift the skin tag? I think there's a filter under it. Okay.
No sir, actually when I was putting the
Okay. You're live.
yeah.
So lag है, you're live.
Yes sir, right sir. So first step sir is the assessment of the hemorrhoids. So I'm just inserting 3 gauze pieces and then gradually I'm going to bring them out. Just to assess the degree of hemorrhoids. Jelly please. So this is a half cut proctoscope which we are going to use. There's so much motion is there here. Go.
So you can, yeah, 3 gauge pieces you can push it.
Yes sir. So we are just going to put one analysis at 3 o'clock position and just pull it outwards. And then with the finger of the left hand, palpate the vessels. Doctor sir, glass here please. I want all of you to.
Where do you palpate the vessel?
Sir, it is 3 o'clock, right?
No, outside.
Sir, actually, this is the dotted line.
Can you point it out?
Yes, sir. I just will point it out.
Your head is coming in.
एक 7:30 देना भैया.
Yes. Now we have to put it.
Please don't talk across. This is a live workshop. Please don't talk across. Sir, these are the columns of organic
Yeah.
and this is a dented line.
Okay.
So can you make out?
Yeah, we can take out.
And this should be the intersphinctic group, white line of Hilton. I think the color can also be made out. This is it. So can you make out over here?
Yeah, if you take your quarter from upper below, it will dip there.
See sir, it's dipping over here.
Yeah.
So that is what I think you always teach, how to find the intersphinctic group, right sir?
Okay. Very well seen.
Yes. Please come, please. So those who are present in OT, they should palpate the vessel. See this. Below my finger. At 3 o'clock, just try to palpate the vessel. It will take 1 or 2 cases for you if you are not doing already. It is such a beautiful vessel. Such a beautiful vessel. Right? Okay, please come. Is it okay? Right? ठीक है ना? नहीं, you're fine ना? Just prepare this here.
dented line पे कितने की नजर
You have to go to 2 centimeter of the dented line, 2 to 4. Next, please.
change
Here also. Here, rubber just see, palpate it, huh? Yeah. Very clear? Absolutely, right? Next, please.
आइए डॉक्टर साहब, कैलकुलेट कीजिए, नो प्रॉब्लम, कैलकुलेट कीजिए, नो नो, हाँ, यस, पुट द फिंगर इन देयर, हेलो, यू पुटिंग इट ऑन प्लीज, हम तो लेकर डर क्यों रहे हैं, राइट, डोंट बी अफ्रेड, हाँ जी. Now show me inside please. So this is a 20 Vical 5x8 27 mm round body needle. Please. That's a 3 3 सवा 3 के बीच में. 3 and 4. ठीक है ना? ठीक है? So this is the supination and pronation. This is just show it to me. मेरे हाथ में focus कीजिए आप. So this is the way we are going to hold the needle holder. You can make out on the screen also. So this is a supination and pronation movement of the wrist. That is the way. And this is the way the needle should be held. इसके ऊपर focus कीजिए please मेरी needle के ऊपर. Very good. Very good boy. Very good boy. And see this. This is the end of the needle holder. And this is the end of the needle. That is the way I am holding it. Can you make a? Okay. So now we are going to take. Sir, is it clear? From inside you can make out?
Yes, we can.
Okay. Right, sir. Then I am going to take a figure of 8 stage, and I am going to use second needle holder just to catch hold of the needle. Just पीछे अंदर से दिखाना हमको ना, नजर आना चाहिए सारा. अगर बीच में कहीं अंधेरा आता है मेरे को बता देना आप. कोई बात नहीं. शाबाश, वेरी गुड. Now this is figure of 8 stitch I have taken. Now see the hands of my assistant. Now she is going to make it down. And the head end is 15 degrees down. That is basically for disengagement. Please. So that is the way we are going to ligate it. Now see the palpebral vessel again. Yeah? So this is fine. Next, keep on rotating. You are clear about this now? पता लग गया था ना, palpate हो गया था ना. So there is another vessel that is at around 5 o'clock position. अंदर की तरफ दिखाओ प्लीज, अंदर की तरफ. हाँ, जब मैं दूसरी तरफ आऊंगा ना, क्या नाम क्या है आपका?
संजीव
जी. जिस तरह मैं दूसरे पास आऊंगा ना, सेकंड साइड पे मैं आऊंगा, तो उस समय आप मेरे लेफ्ट शोल्डर पे आया.
ठीक है सर.
राइट शोल्डर पे. अभी आप मेरे लेफ्ट की तरफ हो ना, उस समय आप राइट की तरफ आएगा. हाँ जी, मैंने थोड़े घास के ऊपर चक्को, कुछ फाइबर आ रहे हैं. घास की इस आइडिया. Yeah, actually, Dr. Sir, क्या है कि ideally we take mucosa, submucosa, but invariably the fibers of they will come. It's a blind procedure, and they are going to come. And in a way, that is good also. That is not bad, because if you see Dr. Chipte's procedure, so when you take interlocking sutures, so what you are doing over there is you are fixing the mucosa so that the prolapse mass doesn't come down. So it's the principle is same. All the techniques, whether it's DG Hall or it's FG Hall or it is Dr. Chipter's procedure is dearterialization. Of course, the principle of EPH, as I said, is also same. But dearterialization, there are so many papers when it has been proved complete dearterialization never happens with PPH. They have done a lot of studies on that.
Okay.
So
So that is at 7. This is the third ligation I'm going to do. So, sir, can you make out inside? No. अरे सर को दिखाइए please. It's not visible. It is not visible.
Yeah, I believe yes.
Yeah, sure. इसको हाँ बिल्कुल ठीक है. थोड़ा सा इसको वो कर लें.
Much better.
Right, sir. So I think needle can be made out very clearly inside. I'm surprised, sir. The camera person is new, but he's doing a good job. I wanted another needle. Sister, let's head thing to.
खड़ा हो जाऊंगा खड़ा करके चेयर
एक और मंगाना है ना उसके बाद Jogindar, you are fine? Yeah, you are comfortable? See this please. Sister, मेरे को needle change हो रही है. नहीं बेटा, इसको साइड पे रख दे. I don't want this needle now. So as I was telling you about RAR, mucopexy, Blaisdell or Farag procedure, I will show you in the next case. Huh? This is not a case for that. Show it. So when we are taking it out, no, so never catch it up from the tip. So because it was inside the mucosa, that is what I did. So my needle at the tip got bent, you know. So that is very important. प्रशांत प्रशांत
कुमार भेजा अंदर
नहीं वो डॉक्टर वो देखना था कि वो यार वो ना जो आपका देख लेना जो यूट्यूब है ना उसमें चैट में अगर क्वेश्चन आते हैं तो हमें बता देना वी लाइक टू आंसर दैट ओके Next, please. Actually, to all the people who are standing behind me, one thing I would like to request that just train your staff. Everybody, your OT should be trained. That's the dhyan rakhna hoga. They should be able to palpate the vessels. If they are able to palpate the vessels, then there is no problem. That means you have taught them well, and secondly, you are yourself very confident. She has done more than 200 surgeries with me. We started laser 5, 6, 7 years ago, and she's my first assistant since then. So that is the so this is the most difficult quadrant, but it is not because. It is difficult to take a stitch, but see how I am taking. Just concentrate on my hands, you know. Just see how I am taking. It is so easy like that, right? Second
Sometimes, sir, we
What
puncture
is
the
the length
vessel
of the
also.
needle holder?
Sir, it is 9 inches, sir.
Okay. And the second needle holder is the same?
Same, sir, same. Actually, sir, original AMI, this I got originally from AMI when it purchased Doppler, but that is very expensive. 25,000 rupees, I think, was the cost.
Okay.
But the same needle holders are available at Bombay. जहाँ से सर हम लेते हैं ना एकता surgicals.
Yeah.
So I think it cost around 2,000 rupees.
Yes.
Here you can make out it's written AMI. यहाँ पे कहीं लिखा होगा. Germany, no? So this is from Germany. two countries are very good in making instruments. One is Germany, second is Pakistan. They used to be the biggest surgical industry at Jalandhar, but eventually, gradually, it vanished because everything has been taken over by Pakistan. Done? So you have to palpate all the vessels, you have to rotate 360 degrees and make sure nothing is left. Laser please. Now whosoever is standing at my back should be with goggles. Don't look directly at the fiber, you can look at the screen also. हाँ अभी आप ना इधर से आइए प्लीज संजीव जी हाँ जी आप इधर से आइए
How many did you tie?
सर इट वाज
Four.
सर 5 I think ligations
Okay.
5 3 4 3 sir 4 ligations sorry sir
Three,
at,
five,
at one
seven.
place I repeated because my thread was broken and my needle was bent it is 4 ligations sir
Okay.
3, 5, 7.
sir there is a study where it is mentioned that whenever you go for any proctoscopies, ligations, and in 33% of patients, there can be one even vessel. I mean, I don't know the importance of that study, but yes, it is mentioned, sir. I mean, it's the same thing that 1, 3, instead of 5, it may be 6. So one even and remaining is, hold it please, laser fiber. So what laser I am using is 360 degree. So you can watch over there, that will be more clear, right? So I am going to first tell you where is the dented line and where are the other things. हाँ मेरे को लगाइए please. हजीब को लगाए.
सर मैं इसे ले लेती हूँ मैं.
Okay, then see there. So that is the, now see this. These are columns of organdini. That is the sawtooth appearance. So you come over here. Now this is the place. See this, the depression. Sir, am I clear about it?
Yes, you are.
So this is the place I am going to make an entry. This is a mucocutaneous junction. So this is 6 watts 1 second pulse. And I am gradually going to push it.
Light off.
Lights off, please. Show the light. Now this is a very bright light. I am bringing it close to mucosa to show you. It should not be that bright. And this is very dull. So that means I am pushing the light towards the internal sphincter. So this is an ideal light. Can you make out?
Yeah.
Okay. So just automatically the tip of the fiber will stop at the hall where hall has been done in the submucosal place. So just now see the crackling sounds. Can you hear the crackling sounds?
Yes, we can.
Sister, 6 for 3 second pulse?
Yes, sir.
Yeah, these crackling sounds indicate that I am right into the sinusoids and this is breakage of the hydrogen bonds. I am not going fan shape in this. Boss, please. Because it's second degree only. Hold it please. अंदर से clean करो ना. यहाँ से clean कर दो. हाँ, शाबाश अली. Good girl. See this lights. हाँ. Now show from other side please. मेरे आप right shoulder से आइए. मेरे right shoulder से आप आइए please. हाँ. बिल्कुल ठीक है. ओके. अंदर फोकस कीजिए. थोड़ा सा मैं ऐसे हो जाता हूँ. आप आइए प्लीज. हाँ. ओके. फाइन. See, the total energy which I am giving is hardly 4 pulses. So 4 means not more than 72 joules, right?
Okay. So why are people giving so many?
Sir, I really don't know. I mean, to be very honest, I think both of us have been telling people repeatedly that, hardly, because sir, actually we are pulling every half a centimeter. And the total length is not more than 2.5, 3 centimeter. So I don't know why they're giving so much energy, 400 joules, 500 joules. I could never understand. And I think you have been very vocal about it in all the conferences.
So giving the higher
Lights
dose is going to injure the internal sphincter muscle and also the external sphincter muscle, depending on how much you're giving.
Absolutely right, sir.
So I have seen patients who have come in with incontinence after laser radioloplasty simply because the energy given was too much. Second thing we have to remember, when we are doing embroids, do not expect embroids to shrink on table. So that means do not follow the embroid. Do not change the embroid size. It will not shrink on the table. Please remember, it's going to shrink over the course of 3 weeks. So just do the amount suggested. For a larger hemorrhoid, you might need to do a little more, but then do not exceed.
Lights on, please.
It was 5 second pulse. 3 seconds.
No, I never give pulse more than 3 seconds. No? Doctor, जो theory मैंने पढ़ाई है ना 6 watts into 3 seconds.
Yeah.
Theory will not change.
Okay.
Whatsoever. Now, sir, this mass is lab. So I will teach them the way you taught me how to remove it. Give me proctoscope, clean proctoscope, put some jelly over it, and give me cautery or bare fiber, anything you can give it. Whichever is easy, you can give it to me. It's not going to make much difference.
Use cautery because when you use laser,
Yes, sir.
it reacts with the plastic and it starts to burn. I learned it that way.
Honestly, I did not know about it, sir. So this is what I learned from my own teacher, Dr. Kushan Mittal. See this. Now this is a tag, right? So how to do it? So the proctoscope inserted in like this. Now the advantages are we are going to cut in a radial way.
Okay.
And excess tissue will never be cut or excess skin will never be cut.
Horizontal. This would be horizontal. not
Yeah.
radial.
So radial means according to the the round shape of the proctoscope. Okay. That's all. Can you make out?
Yes.
Yes.
It is so
Correct.
easy.
Very nice.
Thank you very much, sir. Thank you.
Total energy is roughly
So-
hardly 244.
Yeah, total sir energy given in all the pile masses is 240. Sister, वो तो जल्दी मेरे को ice finger. Ice finger, please. Acha, one thing I would like to tell you, many people say when to put ice finger. Now that depends upon the thermal relaxation time. And what is thermal relaxation time? That is time for the tissue to dissipate 66% of heat. Larger the chromophore, more time it will take. For example, when you go for tumescence effect in EVLA, endovenous laser ablation, you always give lot of tumescence. You cold saline, why? Because at that time the chromophore is more. Chromophore means the tissue is more. So more volume is there. Over here it is very less. So even if you just put it for 8 minutes, 10 minutes, it is just fine.
More than this, you said that.
Sister, मेरे को वो दो, आपने स्टेमिना मिस कराया. एनोमेट्रोजिल दो. I want एनोमेट्रोजिल. I want to put it like that. दो sister एनोमेट्रोजिल please. No, I don't want any. Now this is something which I've learned because basically we are taking stitches through mucosa and all, no? So it's always better in case you put enometrogel and then insert this finger. So that's all. So we'll take question and answers if there are any. You can just switch off the light for 5 minutes till the next patient is taken in. Nero?
Yes, sir.
Just put the notes 3, 7, 11. Ligation at 1, ligation at 3, 5, 7 and 11. And followed by LHP. And secondly,
Skin tag test.
and the skin tag at 12 o'clock. ठीक है? Radiant surgery. मेरा पीछे से ऑफ करो, मेरा माइक ऑफ करो. हाँ जी, अपना जोगिंदर जी, you've done a good job. So sir, this is a case just इसको freeze कीजिए please उसको. Focus कीजिए.
स्टैंड थोड़ा इधर ही
Sir, Bali you are sitting ना?
इधर कर ला, इधर कर ला, इधर कर ला। इस पास देखो, बिल्कुल इधर, फोन इधर।
This is fine ना?
ये थोड़ी सी अंदर आ जाता है।
Sir, is it visible outside?
Yes.
Sir, okay, right, sir. So, sir, this is a patient who presented with the fissure in ano in 2019. At that time, I advised him to go for surgery, but he never went for it. And later on, he developed fistula. And so you can make out lot many skin tags are there.
Yes, he has been struggling with his motions.
Yes, sir. And fissure, active fissure is not there, but some cut is there. But that is not at the anoderm. मेरे को दिखाइए जरा. Sir, that is not extending up to the dentate line. So under.
Anyways, you're going to be doing a fistuloctomy, it doesn't matter.
Yes, sir. So that is what I wanted to actually convey. Ki because I am going to go for fissulotomy, in this case, it's a very small tract. So as such, it's an intersphinctic tract, and the external opening clinically is at 11, and internal opening is at 12 o'clock. So first step I am going to do is I am going to inject hydrogen peroxide, and proctoscope I will put later on, because otherwise this tract gets stretched, and sometimes the dye doesn't come out of the internal opening. नहीं जाने बेटा मेरे को प्रोब दो एक मिनट. This is fibrost. Fibrost. It's not fibrost. जा रहे. ये इनका थोड़ा सा क्यूरेट तो देता है. क्यूरेट थोड़ा सा क्यूरेट करके देख लो. गॉस प्लीज क्लीन करो उसको. Keep it clean. You should be clean. चलो शाबाश. So sir, it's a very fibrous tract, and I think instead of going for fissulotomy, maybe I will just excise it. Okay. Sir, can you make out the dye coming from the internal opening?
Yes.
Yeah. So I will now put the proctoscope, half cut proctoscope, please. Shoot from inside like this. थोड़ा सा एक गॉस पीस और दे दीजिए मुझे. Give me forceps.
This is called a bumper fissure. Look at the number of hypertrophic papilla inside.
Yes, sir. So this is called
Bumper का crop होता है ना, hairs.
okay bumper. Right, sir. So sir, I think this hypertrophic anal papillae may be at the site of internal opening. I will just put the dye. And
So when the hypertrophic papilla matches, call it the lighthouse. That means it points to the direction of the fistula internal opening.
no sir, actually it is not there.
It's not there, it's near.
Yeah, it is there, sir. So can you make out the dye inside? अरे प्लीज उसको ठीक कीजिए. कैमरा आपका आप वो तो देखिए ना, आपका डल आ रहा है यार.
Rotate करो अपना proctoscope. Yeah. Now clean it inside. We'll see how far away.
अंदर से क्लीन करना पड़ेगा.
Fecal matter also.
छोड़ दो. Now to forceps please.
ग्लासेस है
नहीं, यदि हमने आ रही पहले आ रही थी. अरे हजीर no, feeding tube is outside. ज़्यादा मत उसको ना वो करना पेपर से ना स्ट्रेच हो जाता है. 1 minute. 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 1
Just show it. ऊपर दिखाओ ना. Can you make out, sir?
Yes.
थोड़ा सा और घुमाइए. यार आप कैमरा इधर ले आओ प्लीज. Bring the camera this side. No, it is coming from inside, right? So can you make out it's coming very freely from inside? थोड़ा सा ना इसका ग्लेयर कम करो प्लीज. हाँ.
It is fine. We are convinced.
Okay.
आप क्या करने वाले हो ये बताओ.
Sir, actually, first I will demarcate it with methylene blue. Sir, it's coming from inside. The अंदर.
Yes.
You can make out, sir.
That's
Now, sir, what I am going to demonstrate to them, I can go for fistulotomy with complete excision of internal opening. So first I will go for excision of the internal opening, and the remaining tract which is there, then I will excise it.
Why not just do a fistulotomy? That way everything will be laid open.
Sir, actually that is Eisenhammer's technique, but in that you have to go for scooping. Instead of scooping, I will prefer to just take out the whole internal opening. And sir, I am going to teach them because this is the thing which they are going to see in the next email. क्या था आपको? ये मिल गया था आपको?
मैंने बनाया है सर.
ये स्टेराइल है ना?
जी सर.
ये है ना internal opening? This is internal opening. Sir, can you make out the internal opening?
Yes.
So
Yes, I can
now,
see.
what Park actually advocated was that you go approximately 5 millimeter below, means towards the dentate line or above the dentate line. So what I am going to do is I am going to put markings over here, and it's a oval shape incision I am going to make. So what I am going to remove is the mucosa, the submucosa, surrounding tissue, and fibers of the internal anal sphincter. इसको पकड़ो. Now the difference between two techniques is that once you open the tract and then you go for scooping, that is scooping of the infected part, because gland is no more present over there. It doesn't exist once it gets infected. ऊपर दिखाइए जरा. यहाँ पे I want to show. Sir, can you make out inside the white fibers?
क्लियर करना.
Focus.
थोड़ा सा focus कीजिए please.
Yes, you can see it.
So that is white fibers are internal sphincter. The light pink is CLM, and reddish brown is external sphincter. Now that is one way of knowing. Secondly, if I touch and if there is twitching, that means I am touching the external anal sphincter. Bleeding out. नहीं है नहीं है. थोड़े ऊपर है ना, थोड़े ऊपर. हाँ, गुड. नहीं हुआ नहीं है. नहीं, थोड़ा क्लीन कर लो, कोई बात नहीं है.
Just press for a minute and talk about something else till then.
Yeah, just show it to me. Just show it to me. Show it.
This is, yes, you got it. This is one of the reasons why if you have an internal opening at 12 o'clock, you should do the patient in front.
Actually,
That way, you are looking down into the internal opening, and your test section is, although this is a good test section is good.
मेरे को ना थोड़ा सा सारा क्लीन करा आई वांट टू क्लीन द होल एरिया जस्ट इसको हेमोस्टेसिस पहले मेंटेन करो
Now what Dr. Kaman is showing you is that the internal opening is taken along with the central disease. Central disease means the cause of disease. That means the cryptograndular origin of the fistula that is taken out. Once you've taken out the source, everything else will heal. So everything is done. Now remains the external, the tract and the external opening.
So sir, now from the external opening, I guess. Sir, can you make out? It is very clearly coming out
Yeah.
from the inside.
Yeah.
So that means the tract has been separated. Now I will go for fistulectomy, sir. In this case, it's a very small tract, but it's highly fibrous. Forget man. Probe से sides दो ना, probe अंदर डालो यार. Any probe will do. चलो ये दे. See how small this tract is now. It is hardly 2 centimeters something. Right? So instead of going for simple fistulotomy, I am going for fistulectomy. This tract is very fibrous. Always include the external opening, right? Very good. It's good. Good, yeah. Shekhar, yes. Good job. ये बनाया कैसे बर्तन साफ करने वाला? Good, very good. So see, I am going all around it. The idea is I should not be able to see the Methylene blue. See this? That is a muscle now. That is internal sphincter. Now once I am just, because it's intersphincteric fistula, I am going to cut the internal sphincter. Can you make out? Can you make out the muscles? Sir, can you make out the muscle over here? अरे दिखाओ ना.
Which muscle are you showing?
Sir, this is a sphincter, external. I am going to see the twitching. This is the internal I am cutting, sir.
Oh.
It's intersphincteric. So now because I have done this, I need not to bother about fissure now.
No.
Doctor, BP and all everything is fine.
Yes, sir.
Dr. Malik, anything you would like to add?
Yes.
Dr. Malik,
Yes, sir.
anything you want to add?
Perfect, sir.
Slime. Need a slime.
Sir, is it fine?
Slime दे दो पहले.
Very good.
10 cc needle ना 10 cc.
Yes, you got the whole track.
Yes.
जल्दी.
I have
So
to
the
check.
area you are presently
Sir, actually, I would like to check the intersphincteric, deep intersphincteric space again. अजीत बेटा मेरे को ना यहाँ पे दिखा दो मेरे को ना अंदर की तरफ दिखाओ हाँ मेरे को अब वो दो और ये दो ना
No, give me saline with the on fine needle. Saline on fine needle. Show me inside, please. I want to have a thorough look inside.
रैपिड लेंगे
हाँ सिस्टर रैपिड जी इसको ऐसे पकड़ो मेरे को ना क्यूरेट दो जरा
You
See
open
this?
the deep eye space.
Yeah, absolutely.
Because we have
Yeah,
problems.
absolutely, absolutely.
Because we
Now
have
see
problems.
this, see
Yeah.
this, right?
Yes, yes.
So I just want to be very sure. Now see this, mucosa, submucosa. These
Yeah.
is the internal sphincter. Can you make
Yeah.
out?
Yes,
Can you
yes.
make out the fibers?
Yes, yes.
So this is the deep intersphincter space I was talking to you.
Yeah.
So in case I can open it or I can curate it, the patient, the recurrence is not going to be there.
Slide.
So I'm just going to slightly open it more. Dr. Malik, this is I think what you were talking.
Yes.
Sir, am I clear about this, sir? Sir, the deep intersphincter space I have just opened. Dr. Malik, I think this is what you were talking to me
Yes, yes, yes.
in the
This-
morning,
this-
hours,
yes.
right? So, just let's finish this.
Perfect. Very good.
So the thread which I am using is rapid, Michael rapid,
Yeah.
and this is marsupialization. I'm going to start. दिखाइए अंदर से जरा. Haji, show me from 1 o'clock position.
हाँ जी
Good job. शाबाश.
रैपिड ला करना पड़ेगा
कट निकालेंगे ना, सभी निकालेंगे बाद में. अब
स्टिच चलेगा
पहले निकालना.
स्टिच
इसको वैसे ही दो ना, कॉटी कर देता हूँ. All papers to be cauterized. हो गया? Any doubt? किसी को कोई क्वेश्चन पूछना तो पूछे. Now this is marsupialization. What I'm going to do? So marsupialization, you know, advantage.
Now, not correct here. The
No.
more would be less.
हाँ, नहीं डॉक्टर साहब एक चीज़ और मैं बताना चाहूँगा. बाकी तो मैंने सब बता रही थी. Now what happens? The tract, no, that is lined by stratified squamous epithelium.
Okay.
Nero, if I'm wrong, correct me. Huh? The tracts are lined by stratified squamous epithelium. So what happens if you go for fistulotomy like this?
Right.
Fistulotomy, two edges are there.
Yeah.
Now, in case you don't stitch this as this side, this side.
Okay.
So what is going to happen?
Neutralize.
The track is going to fall back again.
Yeah.
This is called bridging effect.
Oh.
So once the bridge is formed, 100% access is going to be there.
Yeah.
So that is the reason this should be allowed to heal with this wall, rectus
Okay.
side,
This should
this
be-
over here. And
Yes.
secondly, when we talk about the skin, all of us know the skin heals faster than mucosa,
ये रोल
right? So that those are advantages, the additional advantages of marsupialization.
No bridging effect.
Yeah, absolutely no bridging effect. No bridging effect is no bridging effect. Now they're very interesting things. You know, I mean, you keep on going through publications and suddenly you realize different people think differently.
Yes.
So there are many studies now where it is very clearly mentioned that in maybe approximately 21% of patients, the whole tract is not epithelialized. The whole tract is not epithelialized. It is only near the external opening where the tract is epithelialized. But I mean, somebody's observations, not much interested. I don't know what is the authenticity of such papers, but it is a PubMed journal. अरे मेरे को तो फुर्सत दो ना. अरे क्या सिस्टर नेक्स्ट क्वेश्चन है देना थर्ड में नो ये नेडल देना ये राउंड बॉडी है डोंट गिव इट. अरे इंदिरा जी नहीं है ना, इंदिरा जी नहीं है ना, कटिंग है तो कटिंग है. चलो पहले दूसरी तरफ को लो यार. Should I move it? I wonder about this.
So the radiological investigation in this case pre-op
Not in this case. Not in this case. We go for MRI, but not in every case.
Not in every.
Not in every.
No fistulogram.
Insurance companies demanding.
Fistulogram is outdated. No, it is not old.
Okay.
But sir, insurance companies demanding for medical patients.
Yeah, you
Then you
demand,
mention it.
you
No,
always
otherwise-
say that, no?
Yes, sir.
Actually, I prefer, I do two things when a medical patient comes on. So two things we do. One is when it's a case of hemorrhoids. So what we do is, we always take a picture of sigmoidoscopy and send it, sister, change my thread. Throw this needle out, 30 mm. Throw this needle out. Don't give me any rapid set now. Huh? See this?
So you are talking about that hemorrhoid image.
Yeah, actually, you know what we do? Prashant has got a very beautiful instrument, huh?
Yeah,
you can
video-
talk to him. It's a
video
video, this
endoscope.
proctoscope.
Yeah,
So I have got 3 video proctoscopes. One is from Prashant, second is from Dr. Sunil Kavte. But the advantage of Prashant's proctoscope is the resolution is very high.
Okay.
Because I think they are using some 3 pixel camera. Prashant has got maybe something around 20 pixel camera. Huh?
Okay.
So resolution is very good. So what we do is, we always send the report, whatever is there, no? We click a picture and we send the diagram, for example, of hemorrhoids or fistula, huh?
Okay.
At the time of sure.
Pre-authorization.
Yeah. It's always better, you know. If you are not lying, why you should be afraid of anybody? क्या कहते हैं डॉक्टर? जब डरना तो तब है ना कि झूठ बोल कर दो। मैं झूठ ही नहीं बोलते फिर क्या डरना है? वो भी तो हमारे जैसे ही हैं। And they are very clever people. They come to know.
Cover your life.
Yes, sir. Sir, actually, I was telling them that whenever you are sending any patient for medical leave, no, it is always better to send the pictures also. The reason being, why to give any chance to anybody, whether hemorrhoids were there or not, fissure was there or not. Many of us, you know, what we do when we are operating hemorrhoids, we just write fissure is also present. So I think if it is present, we'll send a picture. There is no harm. And secondly, in fistula, I think it's always better to enclose a report of MRI. It's very important.
In any fistula, always MRI?
To be very honest, Dr. Sir, we are talking about medical legal, no? Not medical legal, medically.
Okay. Otherwise, routinely, you don't have MRI for fistula patient.
Actually, you know what happens? Many people are sitting over there, they raise unnecessary objections.
Okay.
And you don't have so much time to deal with them. So your TPA department should be given proper instructions that in case, before they ask anything, you enclose all the reports. Whether it is, MRI or just a picture, there is no harm. One advice I will give you, that we do so much work, so much good work, and we hardly get anything paid. And I was going through some article, abroad proctologists are the highest paid surgeons. I seldom do fistulectomies because even in the literature it is very well mentioned that there is not much difference. But this track was very fibrous. I was slightly skeptical about this, that in case I go for
आपने आई थॉट वी हैव ऑलरेडी चलो छोड़ो 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 देखो नीडल टेली होगी ये स्किन में ना लो अंदर से ले लो स्किन से जरूरी नहीं है गो फॉर सब क्यूटिकुलर ना बॉस ऑलवेज डज सब क्यूटिकुलर देखो आएगी नहीं आ जाएगा उसी कर दो टिप ना बस हो गया किस चीज़ ले रहे हो just showed me inside everything is fine just keep it clean मेरे ऊपर मोशन भी लगा हुआ है यार हाय राम all this curry jam हाँ अरे give me groceries यार मतलब दो give me half a proctoscope lot of motion is there ना the worst part of our profession.
So you give something for preparation before surgery?
Yeah, I always do it. This patient came in the morning actually.
Okay.
So I didn't want to give anyone.
Normally what you give?
We give Delcolex, that is Bisacodil, or Cremalex, one tablet, patches. No enemas in the morning because you know what I have realized over the time that it is all dirty feet.
Saline देना कभी
नहीं मेरे को उसमें नेडल पे दो हाँ सभी काटे सक्शन प्लीज Let me see any papilla. No, inside there are no papilla, right? Can you make out? Nothing is there, huh? Shekhar, इसको side पे रखिए. Keep the bone clean. Now give me Alice's. You know, fistulectomy wounds they take more time to heal as compared to fistulotomies. एक गॉस पीस दो मेरे को biopsy of the internal opening just keep it Nero
Yes, sir.
just mention about that huh
Right, sir.
biopsy का ना रख लो उसका internal opening facial and nano sir what is the cause of so many skin tags which are present over there? These are not hypertrophic papilla because
Inside.
no I'm talking about outside.
Okay.
There's so many skin tags.
There's so many.
Yeah, this may be because of this last particular
Recurrent healed fissures.
So you have to rule out secondary causes of anal fissure.
Okay.
Take a biopsy.
दिखाइए मुझे प्लीज सिस्टर दिखाइए सर एनीथिंग एल्स यू वांट मी टू डू आर यू सेटिस्फाइड
सर एक बार इंटरनल व्यू से इंटरनल ओपनिंग के सामने
How is inside? You have taken care of the hypertrophic papilla?
Yes, sir. Sir, everything has been removed. I will just show it to you.
Yeah, it's fine. Absolutely fine.
deep intestine.
Sir, can you make out from inside?
Yes.
Yes.
Sir,
Yes.
nothing is there, sir.
Yeah.
Everything is clear. Right, sir? So nothing
Yeah.
is there.
एनोमेट्रोजल
Thank you, sir. Enometrogen, please. Sir, one thing I would like to share with you. Lately, what we have done is we have started putting HB spray inside fistula wounds. The tunnel once we go for pouring out. Sir, results are just excellent. Neeru has got many pictures of HB spray, so she will just share with you.
ये लो अपने मोबाइल से सबको दिखाओ जरा. Thank you. Fine? Any doubt? So 5 things. Number 1, the wound becomes small, mass realization, right? It doesn't go inside.
Patient had squirt and his HP was 5.9. After that, we had given 2 units of blood, and of course, the patient was put on aldosterone also, along with that, the flavonoids, that means. Oh, it's all full of motion, right? Saline there also. So this is a fissure. Can you make out?
Yes.
This is a fissure also.
कहाँ
6 o'clock or so.
ये जो होल दिख रहा है वो I don't think that's a fissure.
That's a fissure.
इंटरव्यू ओपनिंग जैसा लग रहा है. हेलो,
करो क्लीन करो.
गुड आफ्टरनून. बाहर की कहाँ है ओपनिंग?
नहीं सर, दिस इज हेमरेज.
ओके
ब्लीडिंग हेमरेज. ये देखिए ऊपर से ना.
ओके. अरे इधर ये
अरे इसको यार मेरे को 3 गॉस पीस दो, ऊपर से बांध के इसको क्लीन करो.
थ्रेड देना, ट्रेस थ्रेड देना.
लिनन थ्रेड हो, उसके ऊपर बांध दो. So once, as I told you in the morning, in case the fissure is also present, then we should go for lateral intervention. नहीं इसमें लिख जाना फाइंडिंग्स में. She is outside.
Yes, sir.
Write to the findings 3, 7 and 11 o'clock hemorrhages with fissure mid and posterior. Rub it up. Jaldi. Half cut. Same motion is there, huh? ये करो थोड़ी देर. Alice, please. बहुत ही good, ठीक है. This is fine. BP is fine.
इधर कर रहे हैं तो उधर से ही दिखा. सर इधर इस साइड वो इधर का वो है तो उधर से. उसमें नज़र नहीं आ रहा ना कुछ.
Just show it inside, huh? So this is the first vessel, which is at not at 3 o'clock. It is at approximately 4 to 5 o'clock position. देखो ना पूरी लेबर जो है ना कॉर्नर से पकड़ी जा रही है. आई डोंट नो व्हाई स्टेडी हो रही है. थोड़ा सा केयरफुल होकर चलेगा. ये देखो बस बैक पे टेडी हुई है. नहीं बोल रहे शाबाश. Best.
Lose.
लाइट ना और नीचे लेने देना ना. एक मिनट. जस्ट ऊपर का चला था. जस्ट ऊपर. So that is ligation at around 4 o'clock position, 4 to 5 rather. So once we rotate the proctoscope, we will come back again to 3. Can you just manipulate it? Huh? Right? Yeah? ये देखो ना नजर नहीं आ रहा सिस्टर थोड़ी सी टेबल लागू हैंडलो करो कुछ करो सिस्टर I can't see very clearly
बस
better see even after taking a double stitch no still the vessel was palpable so same place I have taken one more stitch so just remind me I will teach you how to do Blaisdell or Farag or Mucopexy in this patient I will just perform that procedure sister बाहर पेशेंट में फिंगर्स निकाल दी दोनों में I have doubt at 6 o'clock there is a
accessory.
Yeah, there is a question I will let you know.
Yes.
ये कहाँ पे? Is it a fissure or what it is? What is it?
पेशेंट की कौन करो
हाँ क्या बोल रहे हो धर्मेंद्र बोलो अरे बिल्कुल रिलैक्स करो डॉक्टर साहब बीपी वगैरह चेक करो आप थोड़ा बनी टू कम इनसाइड भाई
बीपी फाइन 94 है तो बेस लाइन में कटी है डोंट वरी
Dhavinder, just relax. Doctor, patient is not comfortable. शेख थोड़ा ध्यान रखो यार पेशेंट का सिस्टर दो घूंट पानी एक
गिला कर दो कहीं जाना है तो जल्दी करते हैं नहीं करते पूरा क्या ख्याल है जाना तो नहीं है ना अरे चलने तो काम सर्विस पे होने दो कोई बात नहीं भी ठीक है नहीं देते ना इसलिए नहीं तो मैं तो सुना देता हूँ
नीरू कल जो भी पेशेंट ऑपरेट करने हैं ना उनको पहले टाइमिंग के हिसाब से फास्टिंग रखो nobody should be fasting for more than 4 hours
हाँ बिल्कुल 4 आवर्स ज़्यादा नहीं करिए देखो मेरी बात सुनो ऐसे करोगे ना मेरी बात सुनो देखो तुम्हारा ऐसे शोर करोगे डॉक्टर का ध्यान इधर उधर हो जाएगा तो काम तेरा नहीं ठीक हो सकेगा ना मैं फिर सुना देता हूँ बुटरों से भर लो 6 फुट कल ठीक है अभी नहीं फिर
another vessel
कोऑपरेट करो इतना किया है ना कोई नहीं मम्मा बाहर ही खड़ी है बस उठ गए
अरे मामा को थोड़ी ऑपरेशन थिएटर में बुलाएंगे धर्मेंद्र
चल अभी कोई बात नहीं 2 मिनट में तुमको नींद आ जाएगी सो जाओ मैं जहाँ के लेट नहीं करता ना
नहीं डॉक्टर प्लीज अननेसेसरी ना करना
नहीं पेशेंट पता की है
ज़्यादा शौक पाएगा तो
जिधर भी थिएटर जाता है ना पेशेंट इज टेरराइज्ड
हो गया जी छोटा
ये लेके 6 बजे थोड़ा दिल घबरा सकता है तुम हौसला छोड़ रहे हो इसलिए ठीक है अभी मैं तुमको हौसले वाला टीका लगा देता हूँ हौसले वाला टीका लगा देता हूँ अभी ठीक खुद बोलोगे कि हौसला बढ़ गया
ये now see this mask this is 11 o'clock now so I'm going to teach you how to do mucopexy right
बस ऐसे नहीं करना गलत हो जाएगा
डॉक्टर मेरा ध्यान डाइवर्ट हो रहा है डॉक्टर प्लीज
बस कुछ देखो ना एक पर्सन सिलेक्शन में दे लेने दो ना
गिव इट नो प्रॉब्लम
किसे पसंद दे दो
तेरे पास बस
एक ना आपके तो बूटर भी पास के रेडी रखते हैं ठीक है जरा पेशेंट जरा भी आप कंफर्टेबल है दे दो
मम्मी
यार उसकी मम्मी को बुला के लाओ बूटर में देंगे ठीक है
ठीक है
नहीं 2 मिनट मम्मी को एग्जाम खुद बुला लेंगे
ऐसे मत करो धर्मेंद्र
पेशेंट ऊपर जा
सर
रहा है
कोशिश करते हैं अपने आप को उठने की नहीं हो
अच्छा
रहा
कोई
है
कोई क्या हो रहा है ऐसे क्यों कर रहे हो
Can you make it a big
बाहर
dark
आ गए
by mass?
Yes, sir, at 11 o'clock.
At 11 o'clock. See the large by mass.
क्या दिक्कत क्या हो रही है
यस बहुत हो रही है दिस एक्सटर्नल दिस इंटरनल
हमारा सब कुछ मशीन से बता रहा है
हाँ सर
So whenever you're going to go for Blaisdell or Frav or Mucopestin or rectal
सिर्फ 5
you have
मिनट
to
हो
stay
जाएगा
above the dental.
5 मिनट सो जाते हो तुम्हारी सारी तकलीफ ठीक कर
laser and doing
सिर्फ
it
5
or doing
मिनट
it
घंटी के
without giving laser.
Sir, first I will go for laser and after that I will go for Blaisdell. She has already reduced it.
सर खाना नहीं खाया सर
और हाँ ये बात है ये इसलिए भी हो गया बट हमने यहाँ
सर बताया करेंगे सर
ग्लूकोज लगाया ना इसमें ताकत सारी चली जा रही है ये लगाया हुआ ना दौड़ के जा रही है ठीक है तो टेंशन नहीं है सो जाओ हाँ आप सो जाते तो अपने खुद बंद कर ले नहीं तो वो छींटे पड़ जाएंगे ना दवाई के वो नुकसान करेंगे
So I think there is reduction in the pile mass after ligation, but we will go for laser and rhinoplasty. After that, we will go for Blaisdell or for anything. So literature, I don't know why different people have talked differently, but the procedure basically is same. सिस्टर मेरे को ना एक थ्रेड और चाहिए होगा हाँ
कल या परसों का परसों का 17 वाला नहीं परसों का
सिस्टर रख लेना कौन होगा होना चाहिए था द शुड बी वैसे बोलेगा है ना So just see at 2 o'clock. 2 o'clock. 2 o'clock. 2 or 3. Let us see this. Because initially I could not palpate and I was not convinced. अरे ये नीडल रोड क्यों घूम रहा है सिस्टर कितना नीडल रोड है What are you doing? What is she doing? What are you doing? Laser, ready please. Laser ready please. Check 360 degree all around. Sri Vessel is there. Sister, thread please. See, this is the 6th ligation.
Sir, can you bring slightly BP up?
हाँ हाँ ले आने का
थोड़ा सा 100 110 में
हाँ जी हाँ जी वो तो टर्बिंग बनाया था कितने में
हाँ जी सर
ये बात करो
वेरी सरप्राइजिंग बेटा जल्दी दे ये कैसे खोला हाउ यू ओपन दैट बेटा इसको बाहर निकाल कर रखना हाइट ऑफ से कुछ पूछा सोचो भी सेम ना 5/8 सिस्टर डॉक्टर साहब को ना उसका खाली वाला वो दो जरा इट इज 27 mm 5 when she is milking na you are supposed to release the LCS 20 ठीक है see the reduction in file mass can you make out
Yes, sir.
Just see clinically this is the first step we have done and whatever I have seen you can see 30-40% reduction in case the stitch has been taken properly because it is yeah disinvolved no immediately dearterialization no?
Yes.
So in case you keep on milking so the venous stitches which is there they will also go up done all they not and laser please गॉगल्स पहनिए पीछे जो मेरे खड़े नहीं तो उधर देखिए प्लीज हाँ सी टुवर्ड्स दैट डोंट वी आर नॉट सपोज्ड टू सी डायरेक्टली टुवर्ड्स द फाइबर एज सच 1470 टू बी वेरी ऑनेस्ट with this fiber there is no problem that is shafted but in case you are using bare fiber yes the problem is there
बीपी चेक कर लो 100 बार लगाओ
ठीक है
Wait, sir.
You have to give
light off please
face to the cameraman, he can't see.
Sir? हाँ जी सर
there is no transmission
मैंने पकड़ा
Great transmission is there, but you and your assistant were so close, now we can see beautifully.
right sir.
Yeah. Okay, so I can hear the crackling,
Yeah.
I can see the fiber light, I can see your withdrawal.
Right, sir. So you can hear the beep of the equipment also?
Yes, I can hear the beep of the equipment.
No, sir, in this case, it was slightly bigger pile mass. So this is the way I am going inside.
Fan shape.
The fan shape. Clean it immediately. Come on, sister.
Actually, sir, setting temp पे
6. See this again. I am going to say this. I think this patient was previously operated by in Bihar or somewhere by some doctor. Do you am I right? There is a history of surgery, right? I can make out some scar, some fibrous tissue. I can make out.
So they got it done from some Bengali doctor.
Some Bengali doctor. Sir, in Bombay also you got Bengali doctors?
Yeah, too much.
Everywhere.
In rural area also, sir.
So
In
you
rural
you
Maharashtra.
cannot use the word Bengali doctor.
No, sir, not I mean
पुलिस ले जाएगी तुमको.
not to insult anybody, sir.
सब जाना.
सब जगह ही.
They are not Bengali, they are just people who have no education or qualification and practice.
Okay. So Bengalis are very talented people. Everybody knows. I think in literature they are very good.
Like,
Show it to me. I can't see anything. So you can rotate it slightly, huh? My fiber is getting stuck, so you can rotate it slightly. Not very vigorously, but slightly. Gently, very gently you can rotate it. So in case there is bleeding from this side, from the site of entry, keep it pressed for some time. Now, put it there. Now, what I'm going to teach you is how to do rectopexy or mucopexy, but this procedure is different than what has been recommended by Morinaga. Morinaga's procedure is DG half with rectoanal repair. So, Farag and Ornero, do you have papers? अगर है तो उनको दे दो सभी को ना. Sir, some important papers. I think we can request Dr. Neeru. She can keep the presentation. Last time she distributed for Park and Eisenhammer, if I'm not mistaken.
Right.
So you can, any publication if you want, you can request her. She will give you the prints. Everything should be evidence based. So this is it. I am going through and through. Just take me to auto. Forceps go. Give me one forceps. Just show it to me very clearly. I want to show it to everybody. Can you make out on the screen if not here?
Through this pile mass.
This is a pile mass. See this is what I am going to do now.
Okay.
Just show it to the good girl. I did not push it inside. Huh? No, you push that inside. Huh? Then not with this. The forces you push it. Now see this what she is going to do. Now this is a through and through.
Yeah.
Yes, sir.
Right?
Yes.
It's not a superficial stitch I have taken. Now see this. Now can you make out?
Yes.
Now this is a stitch. Come on, leave it. This is first stitch, right?
Yes.
So this is Farag's procedure and very popularly and very nicely done by Dr. Pankaj. Dr. Pankaj Gupta, he is from Nagpur, and in his publication, he is very good in publications, he has mentioned this Farag.
Yes.
When I was going through different publications, I came to know that he has already mentioned Farag. I have been teaching this, and about Blessdale I used to teach, but then I came to know there's another gentleman who recommended a similar procedure.
Yes. I have taken training, sir.
From Dr. Pankaj?
Yeah.
Oh my God.
Before
Then
5
you-
years.
then you should
Before
teach-
5 years.
Then you should teach us something. No, I mean, honestly, in case he has taught you something different than what we are doing, we would love to listen. This is a teaching workshop, right? Not only you are supposed to learn, even I am supposed to learn. See this, right? One, two, or three, depending on the size of the mass. But you have to stay above the dented line. That is very important. You know, the immediate portion, which is at the dented line, that is sensate. You know, sensation, light sensation is always there. Of course, the area which is above that is also parasympathetic and sympathetic nerve supply, right? देखो, दिखाओ मेरे को. हो गया. This is done. Now see this dented line. I would like, just let me show it to them. Now see the dented line. See this. I am above the dented line.
Definitely.
Right? You can make out. Oh, this too much stress. See this, right?
Yeah.
So I am just above the dented line. छोड़ो इसको. Harjit, show me at 3 o'clock. Is it required? No, it's not required at 3. Can you make out over there?
Yes.
It is not required, huh?
Yes.
So,
Yeah,
similarly,
we can make it out.
yes, sir, even 7 it is not required. Sir, what is this? This is not a fissure.
You have to put a gentle probe to see what it is.
Okay, just give me a probe.
Don't use force.
Yes, sir. ऐसे करो, मुझे ना एक blunt artery दो, mosquito type.
Sir, any previous scar you were telling he has undergone already?
Yeah, maybe that is the reason. Yeah, I don't think it's a fissure. Sir, it's not a fissure. When we clean it, no. Sir, can you make out? Sir को दिखाइए please. I want his opinion.
पहले दिख रहा था, अभी नहीं.
अभी नहीं है ना sir?
ऊपर से दिखाओ.
हाँ. Sir, can you make out? Sir, this is a scar formation actually.
Yeah.
Sir, अंदर जा रहा है थोड़ा सा.
हाँ.
I think I should open it. ये देखिए सर जा रहा है ये. So there is no harm in opening it, right sir?
Okay.
दो कॉटी दो. नीरू?
Yes, sir.
इंटरस्फिंक्टिक ना जो स्पेस है
Right.
उसके बीच जा रहा है ये.
This is
उसको थोड़ा सा ओपन कर देते हैं. There is no harm. Now, somebody was asking a question.
Sir, it is not
Now,
intraspintric.
what do you see once you open it? What is below that?
Sir, it is the
Internal.
internal sphincter, sir.
Show.
I will show
Yes,
it, sir.
very nicely.
Yes. One second, please. One second. Let me just. Harjit, there's a very small video. ना? निकालो इसको पकड़ो. Okay? Sir को दिखाइए. Sir, this is an internal sphincter. Can you make out, sir?
So I can make it out.
Right, sir. Shekhar, well, good job. Scotch Brite, very good job. Done. I'm done.
Fine, sir.
ठीक?
एनोमेट्रो सर
इसको निकालें.
आइस फिंगर हाँ जी
रेडी है तो दो यार. अरे मेरे को अपने हाथ में रखने की आदत है, ध्यान रखो यार. Like this. So, no bleeding, nothing is there.
Yes.
Right?
और फिर
I had little bit bleeding at time, and sir said why there was bleeding. The boss is sitting outside. I don't know if I'm bleeding now. Okay. So, any questions?
Post-op and
हाँ जी हाँ जी
First here, we should have changed the position. मेरे को irrigation riddle दो. Give me irrigation riddle. So it's a case of recurrent fistula. I only operated this case, huh? You can. ये मेकआउट
Yes, sir.
ये वो नहीं है हाइड्रोजन नहीं है
नहीं सर
Line लग रहा है.
नहीं हाइड्रोजन मान लिया
सर पहले क्या ऑपरेट कैसे किया?
एक मिनट
Dr. Kamal, please describe the case.
Sir, actually this patient, he had a horseshoe fistula and I had operated him around 4-5 months ago.
What is this coming out?
Sir, this is a hydrogen peroxide which I have injected from an opening at 5 o'clock position,
Where?
about 8 to 9 centimeter from the anal verge.
Oh, okay, we can't see that.
Sir, it is, sir,
To
just,
zoom out.
just show it over here.
Okay, we didn't see that.
Okay. So sir, actually, I just wanted to show them that whatever we do, every time we don't succeed. So they should bear in mind. Now this is one. Sister, मेरे को एक needle और मिल सकती है?
हाँ जी है
Give me another needle, please. Irrigation needle, please.
Cannula.
Or you, yeah, irrigation cannula. इधर संजीत कहाँ पे है? Okay. We can remove it also. Second we can remove. Here. So sir, can you make out? This is another opening.
Yeah.
So I just inserted the irrigation cannula, and sir, again it is communicating.
Okay.
So I will just see, I will just put a proctoscope now, half-cut proctoscope please.
And this sit-on is put in from where to where?
Sir, actually it was from deep post-anal space. I had opened at that time, there was a communication, like, you know, a hysterectomy was done, and set-on now placed किया था मैंने. I think there was an additional opening also over here from where the set-on was placed. But sir, now a problem I am facing is that this patient, yes, see this sir. So this is actually coming from 6 o'clock position. इसको ना अच्छी तरह खोलना पड़ेगा आपको. Give me two Alice's. It is slightly tight.
Put a probe through the sit-on area.
Probe through set-on area, right sir? Give me a probe. कर दे दो. हाँ, okay. 1 second. Sir, can you make out from both sides? I was just trying to figure it out. So it is coming at 6 o'clock position. So
Okay.
it means the source of infection is still there.
Yes.
Yes. So from the middle. Now you want to see this set-on, from where it is coming. So I
Yeah.
will just put a probe. हाँ जी, जो set-on है ना, इस साइड से probe डालो आप. यहाँ से नीचे से. ऊपर जा रही है? ऊपर? Sir, again it is going up. 6 o'clock position.
Same hole or a different hole?
Sir, same hole. It looks like a same hole.
Now you-
But I will put a straight probe.
Yeah.
ये ले बेटा.
This shoulder. कहाँ जा रही है?
It is going up.
So it is going up. It is definitely not coming here. They show it to me.
So
They show
that's
it.
what I said. Now you have to put a.
Sir, it is at the back of this. एक मिनट हरजीत छोड़ दे बेटा.
It is in the interspending space.
It should be, sir.
So you have to cut over that.
Sir,
When you cut the internal opening,
sir, I am not convinced. Actually, it is. Harjit, first convince yourself. In case it is going up, I will just open the whole thing. And we will improve. Can we remove this set on? Set on? Yes. Okay, okay. चलो शाबाश. हाँ जी, अपना क्लीन करना. ग्लूको सेंटर में. ग्लूको सेंटर में क्लीन कर दो पहले. हाँ, बिल्कुल. Absolutely make the area clean. Good shape. Very good. So this granulation tissue which is there, that is hypergranulation. So that indicates the underlying infection. It is going sir back at the back.
that's not the.
It
what
is-
MRI done?
Sir, repeat. I have not got it done. कहाँ पे है जी? I think what I will do is. It is here. Okay. Let's do one thing. We will just demarcate both the tracks with methylene blue. Center part we will remove. Right? I will open that in case it is required. I will extend it. नीचे लेके जाता हूँ. Handless procedure करके deep anal posterior space open करता हूँ. Then we will see from where this probe is going. Right? Sir, what I am thinking that from 5 and 7 o'clock, I will just inject methylene blue. It should come at 6 o'clock in the midline. So I will open. I will, remove the internal sphincteric internal opening. I will open the deep intersphincteric.
Kamal, hold on. You know 5 and 7 when they're opening. So put methylene blue at the seat-on side. Then you will know where it's opening.
Okay. Okay. Give me set on. This thing, methylene blue.
With hydrogen peroxide.
With hydrogen. With hydrogen. थोड़ा सा हाइड्रोजन मिक्स कर दो उसमें ना.
Yes.
इरिगेशन नेडल एक और देता है इरिगेशन नेडल. First let's demarcate all the tracks. Three tracks are there. Three tracks are there. So we have to demarcate this. I show you. Oh, so it is coming from two places.
Definitely from even going up to the internal opening.
Second place down, first place put above.
First place is at 6 o'clock. And please show it to sir, no?
Underneath the graph.
Show it.
Light.
Please show it inside.
It's a light cable.
लाइट थोड़ी पीछे के हाँ जी
Here.
Sir, can you make out? One opening is here. I will show it to you. Sir, one opening is here.
Yeah.
Another is here.
So my suggestion is you start cutting opening. Open this.
First, I should open it, right?
Yeah.
Okay, give me portrait.
Can I give one suggestion, sir?
Yeah, sure. Please go ahead.
Just cut in the IS space and do the medial fistulotomy with including IO.
No, that is what we are planning. No? Yes, sir. That is what we are planning.
Please tell him that that's exactly what you're going to do.
That is exactly what we are
Yeah.
doing. See, this is first. I will open it. I will extend over here. I will remove the whole face.
Yeah.
And I will separate all the tracks. No? That is exactly what we are planning.
Laser
इसको
both
book
it.
Now see, we have to learn this.
Yeah.
That okay, there is no place of laser in this, huh?
Yeah. नहीं जो
अजीब मेरे को ना अंदर प्रोब डाल के प्रोब के ऊपर कटवाओ.
हाँ.
Put a probe inside, and then I will cut it. Angulated, no?
शाबाश, गुड गुड। पहले आराम से ना एक बार रिलैक्स हो जाओ,
लाइट फोकस कर देना।
लाइट प्रॉपर फोकस करो। हाँ जी, ज़्यादा चुप ना हो देखो ना।
टेबल ऊंचा करना।
सिस्टर थोड़ा टेबल ऊंचा कर दो। यहाँ तक कुछ पैल्पेट होती है ना, आई विल कट ओवर इट। सर ने जो बोला ना कि 2 ओपनिंग्स हैं, दोनों को पहले मिला लें। वी विल ओपन डू फिश रॉड में। ठीक है सिस्टर, थोड़ा हेड एंड लो कर देना। स्लाइड हेड एंड लो सिस्टर, स्लाइड।
बस बस
मैं एकदम पीछे है, थोड़ा बहुत नहीं है। अब बिल्कुल पीछे है।
कुछ ना कर दो बेटा, खुद ना। इसको क्लीन करो। हाँ जी, अपना इसको ना बिल्कुल मेरे को ना वो ले लो आप, जो फाइन सेक्शन टेप ले लो।
ओके सर।
टेक फाइन सेक्शन टेप। हाँ जी, मेरा तो बिल्कुल बैक से है। आगे कैसे मिलेगा? This time open the deep ocean space. Can you palpate it?
किधर है? हाँ जी, एक साइड।
मेरे को ना डायलिसिस दो प्लीज। गिव मी डायलिसिस। ये डिफिकल्ट केस बट आराम से करते हैं। शेख मुझे ना आप अंदर दिखाओ, मैं आई एम नॉट हैप्पी इनसाइड।
जी से ग्लव्स पहला ना ट्रॉली के सामान।
मंदिर मंदिर वॉश। बेटा इनको पकड़ दो।
हाँ जी।
आप उसको इसको
प्रॉपर इसको पकड़ दो बस।
मेरे को ना एक्चुअली पहले प्रो पैकेट कर देना। लेट मी पैकेट द प्रो, छोड़ दो उसको। नीचे बढ़ी है।
पीछे हाँ जी।
ये लगने रही कि क्या उतर रही है बार बार। आप ऐसे करो, आप ना उसको छोड़ दो, इसको देखो क्लीन कर दो। क्या कर रहे हो यार?
The transmission is very clear. So have you opened till the base?
No sir, actually I'm just trying to open it. This is a deep ocean space, sir. This, इसको calculate करो, hold it. Just see, here it is. एक बार देखो ये यहाँ पे लगाओ इसको. I can see that side. आपका हाथ ऊपर आ जाता है. ये नया नहीं है?
ये नया।
ये तो निकालो ना.
So we have palpated the internal opening.
हाँ जी, do one thing. हाँ, it is. अब मैं भाई. Now see this. Sir, can you make out the probe inside?
ये छोटे ट्रैक्टर दे दो.
So now you have to palpate and see how much spindle is involved.
इसको निकालो. Take it out. Take it out. So this is a ring I can palpate and posterior to suction.
हाँ जी.
हाँ लगा सेंसर लगा.
इसमें सेंटर पे ट्रैक्टर है.
एक है और लगा ये ना. ओके सर. स्कॉच ब्रेक आउट.
एक स्पॉट पे और दे देना। और नीचे तो ये दे देना 40।
अंदर 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 अंदर
लंबे वाले लेते हैं। अभी लंबे रिफ्लेक्टर
Is it okay? So this I have opened. Sir, I have opened this track. I don't want to cut more of the external sphincter, sir.
Okay.
This is a subcutaneous, superficial, and sir, this is a deep posternal space.
So take out the internal opening.
Yeah, I am going to do that, sir. उसको ना पहले demarcation कर दो. Internal opening के लिए ना, give me methyl blue. अजी अंदर बेटा साफ करो. Yellow canal should be very clean. हर चीज़ आराम से दिखाओ. ऊपर ऊपर दिखाओ. जरा लाइट दिखाओ अंदर. Sister, please show me the light inside. Light is here.
लाइट सेट करें
Kulveer. I can't see anything inside. हाँ, वही चाहिए, हाँ? क्या था यार में?
इधर से डिस्कनेक्ट हो गए
Sir, can you make out the dye coming from above?
Yeah. Where did you put?
नहीं पाना. इधर से डाल दे. अच्छा, नीचे दिखाऊंगा. दिखाओ, बेटा ऊपर.
नीचे जैसे नीचे
नीचे आई है. Sir, from here the dye is coming in that deep intersphinctic space. So I can put a seton over here, sir. So just see, sir. So can you make out inside?
Hello.
Sir, is it
जूम करना
ऊपर से आ रही है?
हाँ जी
ऊपर से आ रही है.
दिस साइड
ऊपर आ रही है. बेटा अच्छा नहीं आ रही.
नीचे आ रहे हैं
ऊपर वाले को कर ली.
ऊपर से आ रही है. कहाँ से आ रही है?
गोद पे से प्रेस कर देते हैं ऊपर
तो वो इधर से कर रहा है ना
इसको
प्रेशर डाला लेफ्ट साइड में या अंदर
नहीं, ये इधर आई. अजी, ये
स्लाइड
मेरे को सलाइन दो.
स्लाइड दो
मेरे ग्लव्स सारे खराब हो गए. सिस्टर, मैं ग्लव चेंज करूँगा. नहीं अच्छे नहीं आ रहे हैं. पहले तो बहुत अच्छा आ रहा था ना ये. हाँ, यहीं पे. It is from here only, ना?
हाँ जी
वो केवल जाने का.
स्लाइड देना है
So basically this is the intercommunication with the deep posternal space, ना?
सर ये तो जो आपने ले ओपन किया है
हाँ उसका वो सुपीरियर पार्ट से ये इंटीरियर पार्ट से हो रही है
हाँ, ये एक्चुअली जो डीप posternal space है ना,
यस सर
ये वहीं से आ रहा है ना. जी जी ऊपर वाला ये है. इसको भी disconnect करवाना. want to cut it, please be careful, huh? जान जाएगी वो PSR का कलर है. वो देखो वो आ रहा है ब्लू कलर का ना. इस लाइन में. Can you make out? So it is coming from here, right? So we can put a seton from here, no?
यस सर
We can put a seton from here. हाँ जी, यहाँ पे सेटॉन है, उसमें से डाल. नहीं बेटा ये जो नीचे वाला सेटॉन ऑलरेडी पड़ा है ना.
हाँ जी
नहीं, now what I am going to do is, you are right. सेटॉन वाली जगह से गया ना.
हाँ जी
From here we will put a seton now. मेरी बात समझ लगी है? वी आर गोइंग टू रिमूव दिस सेटोन और वहां से डालेंगे वो और इधर से भी डाल के देखो ये तो ऊपर से आ रही है ना, so we will remove the internal
पहले थ्रेड
ऐसे टर्न डाल सकते हैं ना ये अपने आप ही आ गई ना ये सिस्टर
आर्टरी ना हो गया, एक आर्टरी दे,
एक मिनट आर्टरी ले लो यार, आर्टरी ले लो
ग्लव्स से कटिस और
जो ग्लव्स है ना
लॉन्ग,
हाँ जी लॉन्ग आर्टरी,
जो ग्लव्स है ना उसको काटो, मेक इट सेट ऑन, ये अपने आप आ गया ना, सी दिस
दे दो मैंने सीजर भी
sir opening at 7 o'clock that is intercommunicating with the post anal space, so that is a normal communication which we expect because there is intercommunication between on both the sides with the rectal fossa, so that is expected finding. Dr. Malik, am I right?
Sir is outside.
He's outside?
Yes.
नहीं सर ये sitting है सर आपको
नहीं डॉक्टर मलिक
So, why don't you clear the post-anal space?
Sir, that is what I am going to do now. Sir, what I am going to do now, I am going to put a seton over here. Sir, see this, it is very nicely, it is coming. Double smash. Okay, tight. Sure. अरे हो गया कुछ अच्छे दो पकड़ो
सीजर है ना बहुत तरह
और है
इसे सब जुड़ जाएगा ये जो है ये डीप पोस्टरनल स्पेस ओपन हो गई
पहला वाला सीटॉन निकाला कि नहीं?
सर अभी निकालने लगा हूँ ना, जस्ट गोइंग टू टेक इट आउट। अभी सर क्या है कि ये डीप पोस्टरनल स्पेस ओपन हो गई, सो इट मींस ये जो ट्रैक है वो डिस्कनेक्ट हो गया। इसको पहले वाला सेट ऑन निकालो, पहले वाला सेट ऑन निकालो, ओपन, टेक इट आउट, टेक इट आउट। हाँ, नाउ अब मेरे को ना दोबारा सलाइन दो, शो इनसाइड, इसको क्यों नहीं कर देते? दिस इज ऑल डीप, दिस इज मस्क्यूलर। Can you make out on the screen?
Yes.
आगे बेटा, ऊपर ऊपर टुवर्ड 6 o'clock, हाँ ये वाला, हाँ वो देखो ब्लू स्टेट हुआ पड़ा है, दैट इज हाँ ये क्या है, यहाँ पे अंदर जा रहा है और दिस इज गोइंग इनसाइड।
There's a margin.
How long? Oh, that is good. So I will open the internal opening and the deep posterior space. Deep intersphincter space. Now, sir, can you make out the clotting material is coming from the deep intersphincter space?
I know that I'm saying you have to clean that area.
Yes, sir.
And you have to make sure the internal disease, central disease is taken care of.
Yes, sir. Yes, sir. देखो बेटा, इसको ऐसे करो। This all is a blue stained tissue, no? This is missing blue stained tissue. Three. छोड़ो इसको।
लाइन दे
इसको निकालना पड़ेगा। एक मिनट, इसको थोड़ा खींच लेना ना, जगह थोड़ी ब्लीडर है, इसको वो करना है। अब ये काम करो, देखो यहाँ से ना फ्रॉम 5 o'clock मुझे एक इरिगेशन कैनोला के ऊपर सलाइन दो, सलाइन के ऊपर इरिगेशन कैनोला।
Check it out.
Yeah, out.
अब ये ऊपर जाना चाहिए ना। It is coming from above. ये ऊपर के इंटरनल ओपनिंग से आ रहा है। ये देखो, लाइट दिखाओ प्लीज टोटल अंदर। ये यहाँ से ट्रैक सेपरेट हो, यहाँ से आ रहा है। ये कैन यू मेक आउट? यहाँ से ट्रैक सेपरेट हो, यहाँ से आ रहा है। सर, कैन यू मेक आउट? इट इज कमिंग एट अराउंड 5 o'clock पोजीशन from where a track has been separated. Sir, it is coming from here.
What is coming from where?
Sir, this is saline which is coming from here.
सर ये जो क्यूरेट किया था आपने सर,
जो after curating now.
So the message is.
Just show it to me. Just show it to me.
It's just a post in space which you open, and into that post in space
It is
you have all the pictures coming.
Yes, sir. Yes, sir. Sir, this is the place from where it is coming.
yes sir.
So do the fixation of the track.
Fixation of the track. Okay. Yeah, करते हैं, कोई बात नहीं. It will be easy. अरे तो लेके आना. Sir, give me fixation. लंबे वाला मेरे को दो. Give me the longer one. जो 8 देखते हैं उसका टैग करते हैं तो लेजर कर देंगे। We can do laser also ना, उसमें क्या है? नहीं सोच ले। We can do it. ये नहीं जाएगा भाई, इसको मैनुअल प्रोसेस वहीं पे आना चाहिए। Just try. You have to just try it. Now what we will cure it and laser it.
Angulated probe दे देना।
Angulated probe है उसके पास। अजी exactly same जगह पे आनी चाहिए। थोड़ा सा भी अभी तो सीना अंदर ध्यान दो, बाकी छोड़ना। अभी यहाँ की जो उंगली है ना, इसके नीचे ओपनिंग है। बिल्कुल तेरे टिप ऑफ द फिंगर के नीचे ओपनिंग है। इसको पकड़ो, ये भी कॉटन, ये भी कॉटन, डोंट वरी। हजीब दिखा बेटा, यहाँ है, आगे देखिए नीचे से।
लाइट थोड़ा कर देना सर अंदर, कौन है जहाँ कॉटन चल रही सर की
ना ऑक्सीजन रखे आएंगे वहाँ पे।
लाइट की बात
कुछ
नहीं,
आ गया
कुछ नजर नहीं आ रहा।
नहीं ये तो छोड़ो, छोड़ो। अभी कैन भी कम फ्रॉम इनसाइड। मेरे को वो दो, गिव मी इन्फेंट फीडिंग ट्यूब, इन्फेंट फीडिंग ट्यूब। अजी बच्चे इसको लेके जाओ, मुझे सी इफ देयर इज एनी कंटिन्यूएशन। बिल्कुल बिल्कुल एब्सोल्युटली राइट, एब्सोल्युटली राइट। क्रॉस सेक्शन सराइए।
थैंक यू सर।
हाँ जी सर।
नहीं 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 ये नहीं लिया, ये क्या है? थोड़ा विड्रॉ करना, विड्रॉ करना बच्चा कहाँ जा रहा है?
टाइम लगेगा ना मुझे।
So sir, when I am going from the separated track, the saline is coming out at 5 o'clock position. Very freely it is flowing. So what we can do is right now, इसको कैसे करें ट्रैक को? इसको सेपरेट कर दिया। सेपरेट करने पे अगर सेट ऑन पड़ जाता है
पहले इंटरनल ओपनिंग कर लीजिए, ये पीछे सन स्पेस में हो जाएगा।
ओह गॉड, चलो सेपरेट करो। So this is how the
Totally easy.
cases you should know. It is very easy to show easy, simple cases. So now you can make out from internal opening where we have separated. From there the track is going. अब कितना पीछे जा रहा है I don't know. It is going like this, right?
Yeah.
So we are not able to go from external to the internal, but internally when we had from where we have separated the track, so we are not able to do fixation also. Because the track is
This was not exactly
But it is a
horseshoe. Right has opening
It is
different and
it is a horseshoe. Like
different,
this.
yeah.
It is a horseshoe like this, like this, like this. So this we have separated, this we have separated. This is the post-anal space. हाँ जी, अब मेरे को ना वो दो, मेरे को हाफ कट प्रोसेस को दे दो। Give me half cut प्रोसेस।
अरे नहीं,
हाँ जी, मेरे को देख लेना बेटा। Just let me have a look. मेरे को तक नहीं करो। मेरे को क्लीन करना पड़ेगा प्रॉपर्ली। मेरे को ना लाइट सिस्टम से मिल सकती है?
दूसरे टेप लगा दो सर।
It's not going to be that easy for me, भाई ध्यान से जरा। और लाइट अंदर दिखाओ जरा। हाँ। तो नहीं, इसको ना ऊपर से करके रखना पड़ेगा। Now this is the internal opening which I will do. पहले क्लीन करो। I can't see. If I can't see, the audience will not be able to see, no? शेखर जी, जब मेरे को नजर नहीं आएगा तो ऑडियंस को क्या नजर आएगा? Yeah, this is the plan. हाँ? पहले नहीं देखना। Sir, this is a anorectal ring.
So can we use anal retractor for exposure?
Gap is there under the, how much space is there in the anorectal ring?
Sir, I'm almost there.
Almost.
So don't go up, go down.
This is anorectal ring.
Yeah.
Can you make out? This is anorectal ring. देखो दिखाओ जरा। मेरे को तो लगता है कि निकल गई है। दिखाना जरा मुझको एनालिसिस हो यार। Give me analysis. असिस्टेंट डायरेक्टर का उनका राइट एंगल। एक मिनट एक छोड़ दो। उनका राइट दिखा दो मेरे को प्रॉपर। Sir, that is anorectal ring. Exactly anorectal ring. Saline there. Manjeet.
नीडल लगा, सीधा नहीं जाएगा।
वो actually
नीडल डालनी है।
इरिगेशन नीडल
दिखाओ अंदर दिखाओ। नहीं आ रहा यार, इसको अंदर इसको प्रॉपर करो। अभी इसको लेके जाओ, प्रॉपर नहीं है।
अरे नाउ इट्स कमिंग।
जब मेरे को दो
स्लाइड
या आपके उस पर डिटेक्टर हो
अभी
गया।
प्रॉब्लम कहाँ पे है?
सर प्रॉब्लम है कि वी हैड पुट वन डिटेक्टर फ्रॉम 5 o'clock, तो जैसे डिटेक्टर लगाया ना, so there was no saline coming inside. They showed me.
तो गामा फ्री फ्लो है।
So we have already separated the internal opening as the track. So I have to remove this part now, but I have to be very watchful. अरे अंदर कोई नजर नहीं आ रहा भाई।
Part है।
लाइट
दिखाओ भाई। हाँ। So this track is separated from there ना? Listen to me. This is separated
जो
from
ट्रैक
there.
सेपरेट हो गया उसको स्टिच कर लो।
सर उसमें स्टिच नहीं लेगा ये। It is all fibrosed. ये स्टिच लेगा नहीं सर ये।
फाइब्रोटिक पार्ट को काट दो।
Sir, I'm very much afraid of this ring. देखो दिखाओ जरा एक। Let me take a final decision ना। एक उनकी कॉल है। दिखाओ जरा, ऊपर दिखाओ।
ये अपना ये रिट्रैक्टर निकालो फिर सल्फेट करो।
एक मिनट ये जो है ये वाला पोर्शन है ना, इसको हमने वो करना है। इसको देखो कैसे समझना है। हाँ। We have done it. It has already been opened. लाइट अंदर दे सकते हो सिस्टर? दिस इज अ वे टू शो यार। अंकल वो ना कुलबीर, हाँ जी सर, तो कहीं जाम मच गया तो ये इधर है। यहाँ पे नहीं है। अरे मेरे से वो मत खुला देना यार, डीप में पोर्शन रिंग ना खुला देना। ये यहाँ पे जा रहे हैं ना। मैंने केवल दो ये देखो ना, ये यहाँ जा रहा है। ये रिंग कितने है?
नीचे है ना,
दिखाओ बहुत से आके ना ऊपर रखो, उसके ऊपर दिखाओ बेटा, लाइट ठीक करो।
बजट में मतलब सर
That is not a ring. Are you sure that is not a ring?
कौन सा सर?
ये जो यहाँ पे मैंने डाला हुआ है।
सर नीचे, ये चीज जगह नीचे।
डाला हुआ है। डर लग रहा है।
ऑक्टोस्कोप निकाल के रिंग फिल कर लो दोबारा एक बार आराम से।
रिंग के नीचे है।
किया है
रिंग के नीचे है। No, this is of no use. ये सेपरेट हो गया ना, दिस हैज बीन सेपरेटेड, ठीक है जी, दिस हैज बीन सेपरेटेड, दिस इज वेरी क्लियर। हाँ, इसका कोई गड़बड़ नहीं होने वाली। तो मेन जो प्रॉब्लम आएगी ना हमें यहाँ पे आ रही है, तो ये मेन से ये पीछे फ्लोर से बेस है ना। So plan is that I will try that the place which you were saying na, to open it. I will open that place only. I have palpated the internal ring, this anorectal ring again.
Okay.
And below that I can make out little bit of my this thing curate going.
Okay.
So I will try to open that part only, sir. The idea is to open the deep deep intersphinctic space, and we are just trying that in case we can come out from 5 o'clock to the separated track. Maybe we can put a draining set on.
Okay.
नहीं? छोड़ दो.
When you are putting this patient in position, you strap the button.
Yes, sir. So you can make out it strapped both sides.
Yeah, but you didn't tell any of your students you strapped it. It's an important step.
Yes, sir.
What happens is everything becomes superficial.
कौन सा प्रॉपर्टीज को दे सकते हो आप? इससे बड़ा कौन सा है आपके पास? सिम्स. सिस्टर. इससे बड़ा सिम्स कौन सा है? This is number 2. Give me number 3. देखो सलाइन भर के दे बच्चे. निडल तो है ना हमारे पास. निडल है जी. कोई बात नहीं, मुझे उसकी फिक्र ही नहीं है. वेरी ऑनेस्ट विद यू, मुझे उसकी फिक्र ही नहीं है. जो स्टेक्स साइड सेपरेट हो गया ना, आई एम कंफर्टेबल विद दैट.
सर अब सिट डाउन.
ओह वेरी गुड.
क्यूरेट दे.
हाँ ये यहाँ पे है. वेरी गुड. ये कहाँ पे है?
ऊपर से नीचे आ रहा होगा.
एक मिनट. सही. हाँ इतना होते जा रहा है. इट इज गोइंग फॉर अप्रॉक्सीमेटली 2.5 सेंटीमीटर. ट्रैक सेपरेट हुआ ना अंदर से, बट ये पता क्या है, जो इंटरस्पेक्टिव पे ऐसे भी तो आ सकता है ना.
ये ऐसे आ रहा है.
ये इंटरस्पेक्टिव स्पेस है ना, so I have to open it. If I don't open it, how patient will be fine? हाँ ये this is what I was telling. ये कितना आगे जा रहा है? No, I don't know how to cut demonstration. मेरे को क्यूरेट दो यार. मेरे को लेजर दे दो. ये ले लो. How much I should cut over here? That is a question only. पकड़ो इसको. अभी तो उधर बड़ा खींच के रख. खींच के रखो उसको. इसको क्लीन करो. चलो. तो इसको क्यूरेट करो ना यार. अंदर क्या दिक्कत आ रही है? क्यूरेट करके इसको निकाल लो. यहाँ पे सूम कर दो. जरूरी थोड़ी हर चीज में पार भी कर लें. या फिर बस इसके अंदर नीडल डालो.
फाइन नीडल.
Sir, I am going to scoop this area out, sir. I can make out some necrotic material over here. Can you make out? ये देखो. ये यहाँ पे है.
देना. चेंज कर.
अरे उसके ऊपर लगा वो दूसरी जगह.
हाँ जी.
We open this space, no? Where is the problem now? Irrigation to the air, इसके मध्य. Now see this. What is this? Shampoo. Sir, can you make out this space? Guruji? Sir, can you make out this space?
I can.
So then, this is the deep intersphinctic space.
Okay.
So what I have done, I have curated it because I am too close to the.
Okay.
So I am just curating it, and it is still this much deep.
Okay. So what are you going to do?
Sir, I think after curating, I can go for just laser ablation.
Okay.
And I should call it a day. There is no point of taking any risk, sir. इसको निकालो. Maybe this is fine. This is absolutely fine. इसको मेरे को वो दे क्लीन करो इसको. ये कोई इंटरनल अपने मैंने निकाल ली है.
जो पीछे सीट-ऑन डाला है.
जी सर.
You really need the सीट-ऑन. इसको भी लेजर कर दो.
सर मुझे लगता है कि if I keep it for some few days, it will act as a drainage. अदरवाइज देखा जाए तो है तो पोस्टरनल ही ना.
Okay.
So from the separated track, we are just going to. इसमें से लेजर नहीं जा सकता क्या? लेजर फाइबर. एक मिनट मेरे को डुबो दो. Give me saline.
किधर जा रहे हो? कितना जा रहा है ट्यूमर तक?
सर मैं देख रहा हूँ अभी भी.
वो जगह निकल जाए.
It is not coming out. ठंडी है दीदी यहाँ से नहीं आ रहा.
पकड़ के रखो निकालो देखो कितना लंबा है.
नहीं
ज़्यादा नहीं है. ये रोल हो रहा है.
I know.
अच्छा ये ट्यूब क्यों डाल रहे हो?
Sir, we are just trying in case we can bring it out. So we can think about going for laser ablation.
No, the uterus को external opening ना?
Sir, external से नहीं ना आ रहा.
Is blocked?
Sir, actually external से saline is coming, but tube is not coming. Haji इसको बेटा नीचे से लेके.
Can we use copper probe?
We use it also. We use it.
Is the probe coming?
No, sir. See, sir, when I'm putting saline from the external opening, it is coming from the separated tract. This is fine. What is the problem with this? Here separate the tract, ना? क्या दिक्कत है उसमें? Tract separate हो गए. Infection वाली site आपने निकाल दी center portion. So let's pray to God it heals. Sir, any other suggestion you want to give? Because from external to internal, from the external to the separated tract, it is coming very freely, the fluid. Then intersphinctic space.
I want you to put that in probe which is in front of the fixation device.
Manual probe मेरे को ऊपर लगा देना.
नहीं, वो fixation device पर.
हाँ सर वही कह रहा हूँ. Manual probe जो fixation पे ऊपर आता है ना. Manual probe which is coming on the fixation device. हाँ इसके ऊपर probe लगा दे दो. छोड़ दो इसको. So what is the take home message? Every day is not Sunday. जाने लिए कहाँ से चले जाएगी पता नहीं चलना कहाँ जा रही है. You want to put वो डालना चाहती है यूरिटिक एसिड.
निकलेगा नहीं
अंदर से और बाहर से लेजर कर दो कितना होता है.
हाँ सर ऐसे करता हूँ, अंदर से जितना जाता है वहाँ से लेजर, जितना बाहर से गया वहाँ से कर देता हूँ। इसको क्यूरेट करो पहले।
स्लाइड रेडी रखना है।
The tissue is not coming. Slide there, beta. Irrigation. नजर नहीं आ रहा शेड में।
गॉज लेके इतना साफ करें, गॉज में है।
हाँ जी, बेटा उधर बिल्कुल क्लियर नजर आ रहा है। ले बेटा सलाइन दे।
जल्दी आ जा।
उसकी आंखों में यार गैस छींटे गया है, कर दो।
दूजी दूजी
नहीं जाएगी टूट जाएगी।
नहीं सर, इतनी भी इधर अंदर लेजर नहीं करना।
नहीं जाएगी नीचे, नहीं जाएगी। मैं कह रहा हूँ वहाँ बैंड आएगी।
कुछ नहीं कर रही, इतना एरिया लेजर कर दो मैं क्या।
लेजर ऑन कर रहा है सिस्टम। देखो सामने दिखाओ, सामने बिल्कुल सेंटर में ना जो डीप इंटरफिल्टी स्पेस थी वहाँ पे दिखाओ। शरीर को दोस्तों में टिश्यू बढ़ाया ना
नहीं मैंने करा था ना।
कर दिया नीरू। स्कूपिंग आई हैव डन इट, दैट इज द रिकमेंडेड प्रोसीजर ना। जो डीप इंटरफिल्टी स्पेस है, हैं? ये स्कूप आउट कर दिया मैंने इसको। यू कैन मेक आउट। स्क्रीन पे नजर आ रहा है?
यस सर, आ रहा है।
और सेपरेट जो ड्रैग हो नजर आया?
वो भी नजर आया।
Neeru, I hope we don't have any vacuum fistulas tomorrow.
No. We have fresh fistulas. No, Jian Sharma
It is not recommended. ये hysterectal fossa है. It is not recommended. Trunk shrink करने के लिए expand कर जाएगा. Abscess बन जाएगा वहाँ पे. नीरू, इसकी जो भी ड्रेसिंग है, एक्चुअली स्प्रे उनको प्लस करनी। अच्छा मेरे को ये बताओ, जो सर ने बात पूछी थी, ये ड्रेन रखने की जरूरत है सेट ऑन? इसको निकालो, ये टेक आउट निकालो, इसको निकालो। फॉर्चुनेट आपका पहले तो बड़ा अच्छा चलता था, तो मुझे लगता है उल्टा लगा दिया इसमें। पहले तो बड़ा इंप्रेस हो गया। इसको क्लीन करो। इसमें से हम देख रहा मेरा स्लाइड दो। देखा बच्चा बड़ा निडल से लगा देते हैं, नहीं गया क्योंकि कहाँ से आया मेरा all the tracks have been separated. Where is the problem? Huh? You want to please sit down? Sit down का रोल क्या है? Sir, is there any role of sit down, sir? गुरुजी?
नहीं।
सर आप देखिए, अब फाइनल में आपको पिक्चर दिखाने लगा हूँ। सर फ्रॉम 5 o'clock दिखाओ सर को। हाँ। ये सर मैंने ट्रैक सेपरेट कर दिया, यू कैन मेक आउट। सर आई एम कमिंग वेरी नाइसली।
हाँ।
ये 7 o'clock। सर अगेन इट इज कमिंग वेरी नाइसली। अजी ये जो है ना बच्चे, इसको क्यूरेट कर रहे हैं। और मेरे को ना एक बार फाइनल
जो अंदर की ओपनिंग है 5 and 7
जी,
उनको अच्छे से क्यूरेट करो और लेजर कर दो।
ठीक है सर। जो 5 and 7 है अजय बच्चे ये यार तेरा ट्रैक है ना, ऐसा लगे अच्छा लगे इनको क्यूरेट कर दे। इसको निकाल दो यार, इसको निकालो पहले। हो वेरी गुड अजय, रिकॉर्डिंग मुझे रिलीज करनी कर सर। हाँ हाँ Oh, but he so much necrotic material, huh? What though? Precision करूँ? Precision दो यार। Give me precision instrument. सबसे बड़ा वाला दे दो, मोटे वाला। अरे गुड्डी, रॉड देंगे पहले। दिखाओ यार थोड़ा अंदर। वो देखो सारे नेक्रोटिक दिया है। पकड़ इसको, होल्ड इट। कोई लोग घास दो बेटो, कि मैं घास पे सो गया। वो दो, सलाइन दो। पकड़ इसको। Sir, I have removed the whole track.
Hello.
Sir, I have removed the whole track. Instead of lasering it, I just went for precision, and from 7 o'clock, the whole track is out.
दिखाओ।
Sir को दिखाओ क्या क्या है। Keep the track over here. Give it to me, na? Sir, this is what has come out. Give me slide. Good. Okay. This is fine. और जो ये मोशन पास करेगा
मोशन में पास करेगा तो लिक्विड पार्ट ऑफ स्टोरेज में एंटर नहीं करेगी. बट सिट डाउन एंटर करेगी वो. बाद में अगर होगा तो उसको खींच खींच के कट कर देगा ना. Am I right?
इन्फेक्टेड होती रहेगी.
इन्फेक्शन होनी ही नहीं है वहाँ पे. Because it's a cavity which has been created now. टनल है वहाँ पे. ऐसे टनल है. दो ग्लव्स दो सिस्टर और दो don't want to take a chance. ठीक है. रोको का जीव है. जीव कैसे रोको? I could tell. They didn't touch Karan. नोट्स डाल. वॉश योर पिछला. ठीक है. एक्सटर्नल ओपनिंग 5 o'clock. Length on a track 9 centimeter. And second external opening 7 o'clock. Length of the track 9 to 10 centimeter. ठीक. Post anal space open. Deep post anal space open. And both tracks seen communicating from there, huh?
Right, sir.
Both tracks separated. Marked fibrosis at the site of internal opening. वो पहले लिख देना. H2O2 injected, huh? From 5 and 7 o'clock and seen coming at 6 o'clock, huh?
Right.
हाँ दिखाओ. मेरे को फाइनल दिखाओ. Let me see कोई इंटरनल ओपनिंग का कुछ करने वाला है. Give me the detector. Very good. देखिए यार ना अगर तीन ही रखो.
ठीक
है. अब देखो ये जो चीज है ये बिल्कुल सेंटर में रह गया. बेटा see this.
परसेंट देना.
This is what is in the center. अगर हम लोग इसको रिमूव कर सकते हैं. लंबी ऐसी ठीक है. आपके हाथ में ब्लीडिंग बढ़ना है. ब्लीड वेरी वेरी इंपॉर्टेंट. देखकर इसको पीछे रखो. मेरे फेस पे लग रहा है. Saline dो. दे बेटा दे.
सलाइन दे दो.
मेरे को ना सलाइन उस पर भी दे दे. ये वाला भी दे दो. दूसरे वाला भी दे दो. ये तो लिख देना. डीप इंटरसिम्पेटिक्स के स्पेस नो हाँ क्यूरेटेड स्क्रू. दिखाओ दिखाओ. ओह माय गॉड. ब्यूटीफुल. जस्ट सी दिस.
आपको भी बताओ कि आप यूज करें.
सर बिल्कुल देखिए कैसे ट्रैक पीछे से जाके ना जो बेंड था इट हैज बीन सेपरेटेड सी हाउ नाइसली इट हैज बीन सेपरेटेड सी हाउ फ्री फ्लूइड इज कमिंग सर कैमरा बिल्कुल अंदर रखना है
मैम सर
सी दिस सर absolutely free flow of the fluid
कहाँ से इंजेक्ट कर रहे हो
sir we are injecting from 5 o'clock
क्या किया उस ट्रैक का
सर उस ट्रैक को हमने थोड़ा सा यहाँ पे जो इंटरनल ओपनिंग के पीछे डीप इंटरफिटेड स्पेस है ना सर उसको हमने थोड़ा सा और ओपन किया है सीधे सर
वो डालो ना ठीक से
कुछ चीज़ें डाल के देख ली चलो सर कहते हैं डाल के देखो ये ना वी हैव नॉट मच मोर एक्सपीरियंस देन अस जैसे सर कहते हैं करके देखते जी थक गई चल ना Sir, actually there is a bend. That is a problem we are facing. We are just trying. Sir, actually we are not able to reach there. ये drag है ना sir, आगे से it is curved like this. We are not able to reach here. Angle is there. देखो ये सेंटर सोर्स निकल गया ना तो फिर नहीं होने वाली इसके नेगेटिव तो लाइट वाइट पड़ी तो है
टर्बो कैरियर उससे भी गति वो
नहीं लाइट वाइट पड़ी है हमारे में सिस्टर गाइड में आ गई सर आ गया सर We are outside, sir. Can you make out?
किसको दिया हरप्रीत को दिया था ना
Sir, Hajit is really married. She has got more. मैसेज आ रहा जोर है उसका. चल बेटा. Good girl. अब क्या करेगी क्या करोगे ये बताना. ये तो लेज़र था बोल रहे. इसको क्लीन करो यार. सर को दिखाओ पहले. देखो these are the cases ना. सिंपल तो कोई भी करके निकल जाएगा फिश लॉट में. कैसे? आप कौन सा बेबी कर लेंगे
7
नंबर फीडिंग ट्यूब अंदर की पिक्चर ना लेना जब मैं कर रहा हूँ ना एक ही पिक्चर अंदर की लो मेरी बुक आ रही है उसमें डालेंगे नीरू जो इनकी सर के पास फोटो है ना ये फोटो लेना एक इनकी जो अंदर से लेने का खिंचवा ले एक अपनी टीम को भी खिंचवा लेना ना चल आराम से यार नो गिव इट अवे हाँ संजीत अभी बेटा आराम से वो पीछे पड़ी है एक मिनट हर चीज आराम नहीं तो जोर नहीं लगा रही तो व्यवस्था कितना नहीं हुआ छोड़ दो नहीं मतलब तेरा से क्लीन करना पहले सेंटर शेखर क्लीन करो उसको
छोटा माउंट
रुक दो छोड़ दो ना यार कोई बात नहीं उसको पकड़ ले साथ में निकल जाएगी जी उसको पकड़ लेके जा नॉर्मली प्रॉब्लम ये चाहिए इसमें थ्रेड तैयार रख लेते हैं सुटेबल डॉक्टर साहब बस 10 मिनट्स मोर
मैंने 2 घंटे लगा था
ये बताओ वाप स्कोप क्यों नहीं यूज करते?
सर एडिशनल फाइंडिंग तो आपको मिलने नहीं वाली
ट्रैक तो मिलेगा।
सर ट्रैक ऑलरेडी मिल गया हमें हम लोग बस उसको ना वो आ गई सर बाहर आ गई तो हमारी अभी इसमें सूडो पैक डाल रहे हैं अभी दिखाओ
अच्छा सूचो पैक के 10 स्ट्रिप्स मुझे चाहिए।
सर के लिए कल सुबह पैकेट पूरा निकाल के दो
मेरे को बॉम्बे में नहीं मिला।
अरे
सब
सर
नाटक कर रहे हैं आके।
अरे सर आपको देखे हुए
जो लोटस वाले आए और एक तो कंपनी और आई बोले सूचो पैक नहीं है।
बेटा एक मिनट सर एक 1 सेकंड सर बेटा क्या है ना बिल्कुल मेरी तरफ
कुछ नहीं दिख रहा
सर नहीं नजर आएगा सर एक मिनट वी आर एट अ वेरी क्रूशियल स्टेज एक मिनट जी बेटा तेरी हाँ तो तेरी कहिए इसके अंदर
अरे एक्टिव फोर्सेप्स से पकड़ के खींचो।
हाँ सर वही कर रहे थे ना
मेरे 2-3 और दे बस एक्सेस का ध्यान देता हाँ दे
नहीं आता नहीं है सूडो पैकेज कितना पड़ा हूँ सिस्टर दे सूडो पैक दे दो जल्दी दो ना इसको लगा दो पीछे तो बदल नहीं है तो करेंगे ये जस्ट गोइंग टू गो फॉर सेकंड में उसको जगह दिखाना है सिस्टर को डॉक्टर सिम्स को दो सिस्टर वही छोटा सा सिम्स दे नंबर 1 नंबर 2
एक मस्कीटो स्प्रे में रखो एक बार नीडल के आई में गया तो दूसरा मस्कीटो से खींचना पड़ेगा।
आके नहीं जाएगा
नहीं सर
अरे यार सामने तो दो
एक
दो
मिनट
एक मिनट
नहीं कुछ नहीं
कर सकते हैं
वो पढ़ना
मुझे सामने तो क्या है यार इतना बड़ा होता है हाँ शाबाश गुड रुको 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 अरे ये तो अच्छा है कोई एक मिनट दीजिए बच्चे मेरे तो ना मैं आपको बता हाँ ठीक है इस कुड़ी में देखो भाई फिलहाल कैसे डाल रहे हैं ऑनलाइन दिखने वाला बड़े से एक मिनट भाई जी का खोलो
कर दो
उसका बिल्कुल सामने पड़ा उसके ना मैं तो उसको लेकर बिल्ड कर दूंगा
कमल तुम डालो तो यू आर इन डायरेक्ट विजन
सर एक्चुअली ना
शी इज एंगुलेटिंग या उसको बैठने दो बैठ के कर लेगी
बोलोगे आ गया सर टेडी बन गुड गर्ल चलो ध्यान दे दो
छत्ती छत्ती
अभी तो कोई नहीं मेरे को क्या पता था तेरे हाथ में अब क्या करना है बोलो
बस कुछ नहीं
कुछ नहीं
फिक्सेशन करना है सर क्या
तुमको ज्यादा टेंशन लेना है तो ये एक तरफ एक लूप बना लो और लूप के अंदर दूसरा स्विच फाइल डाल दो और वो खींच दो अक्रॉस तो निकल आएगा
सर मैं ये सोच रहा था अगर आप ठीक समझे तो सर इसके ऊपर लेजर करके निकला हूँ
किसके ऊपर ये कट जाएगा वो
नहीं नहीं इसके ऊपर अभी वो इनपुट ट्यूब डालेंगे ना
हाँ
2 इनपुट ट्यूब
नहीं लेजर करने तो बाद दोबारा पाना थ्रेड
नहीं पानी तो
तुमने क्यूरेट कर दिया ना
सर क्यूरेट कर दिया
तो लेजर की जरूरत नहीं है
तो सर आपने क्यों लगवाया
नहीं आई थॉट यू वर गोइंग टू कीप इट एज अ
ट्रेनिंग
तो ड्रेनिंग के लिए वो डाल देता हूँ ना इसके साथ वो डालो शेखर
जी
इसको पकड़ के इसके साथ बोलो रबर
या इसके ऊपर इंक्रीमेंट डाल के लेजर डाल लो देखो
यहाँ से मैं वही सोच रहा लेजर कर रहा हूँ आई वांट टू लेजर ग्रेजुएशन पिछले मुझे ट्राई करना So message for everybody, yeah? Life is not that cool. Gone out. And Ajit and Neeru, when we were operating at SGT, na, everybody 110 surgeons was sitting to see this procedure only.
Okay.
But that is because it's a recurrence and that was a fresh track.
Okay.
If you, these are the cases one should
सलाइन डाल के साफ कर दो बाहर
सर कर रहा हूँ सर अभी सब कुछ कर रहा हूँ सर अभी
मैं विजन अच्छा नहीं है इसलिए बोल रहा हूँ
जी सर
एक दो गिली गॉड
बेड कॉल सर मेरे को बोलो हाँ जी देखो बेटा खींच ओके लेजर ये लो लेजर कॉट उठा दो कॉटे का भी काम है क्या डाल सकते हैं? सेटॉन वही तो मैं पूछ रहा हूँ तेरे को फर्जी सेटॉन क्यों नहीं डाल देते हम लोग?
सर जी अभी तक इतना
कुछ टाइम तक के हम वॉश कर सकते हैं उसको।
अभी नहीं
तो मैं
कर
अभी लेकर आने सर सेटॉन डल जाएगा तो हमारा प्लस का
और
लेजर
लेजर
है।
को साफ करके लेजर डाल दो।
सर सेटॉन व्हाट इज योर ओपिनियन सर?
सिटॉन तो पड़ी हुई है।
कर दी।
सेटॉन तो निकल जाएगी।
अगर तुमको ज्यादा प्रॉब्लम है, ये ट्यूब को ऐसी रहने दो, नीचे पर टाइप कर दो उसको हाँ ऐसे करेक्ट, एकदम सही किया।
तो सर दैट इज ए ड्रेनिंग एक्चुअली ना?
क्यों आइदर डू लेजर और डू ड्रेनिंग, दोनों के बीच में कंफ्यूजन क्यों किया? अब
So-
लेजर डालो और कर दो। Since you already taken out the internal opening, so you will destroy the hypertension tissue.
लेजर के साथ अगर मैं कर भी दूंगा अंदर की तरफ से, अगर सपोज वहाँ पे खून गंदा हो गया लिक्विड, तो उसमें वो हो जाएगा। जबकि सेटॉन अगर डालूंगा तो नीचे से जब हीलिंग शुरू हो जाएगी तो सेटॉन निकाल देंगे। जो सर कह रहे हैं सेटॉन की भी बात ठीक है उनकी। यू डू वन थिंग, मेरे को रबर ग्लव बेटा यहाँ से लगा देगा ना।
नहीं इसको वापस धागा डाल दो, धागा में कवर खींचते हैं।
इसी के साथ टाई करके
हाँ दोबारा खींच देंगे ऐसे धागा, ये रबर बांधने नहीं।
कॉटन कलर का नहीं है, ये भी तो सही है सर, जो कटना ही बस है।
नहीं यार ये इसको नहीं डालना ना, या तो मैं सिल्क डालता तो सिल्क से बेटर है कि आई शुड पुट वन सेट ऑन। देखो जिस चीज़ों पे हमें फेथ है वो काम करता है, इसमें लेजर के साथ वो रहेगा नहीं। इसमें लेजर के साथ वो रहेगा नहीं। मेरे को दो यार, एक कहीं से एक तरफ ट्राई कर लूँ।
रीडिंग टू भी इतनी गई है ना,
ज़्यादा लोग लिक्विड लगी है लोग। उसके खुलने के चांसेस कम हो गए।
ठीक है
तो खींचना दिक्कत है। ओह गुड गर्ल, छड्डो जी। छोड़ो इसको, काटो
सीजर
छोड़ो जी। ले लो सेपरेटेड ट्रैक्स यहाँ पे है ना, लिख दे सेट ऑन पेस्ट। सर क्यूरेटिंग वगैरह सब मैं कर चुका था।
हेलो या
सर मेरा दिल नहीं माना कि मैं सिर्फ लेजर करके छोड़ दूँ। सो सेटॉन मैंने इसलिए डाला है कि इन केस गॉड फॉरबिड को इन्फेक्शन अंदर से होती है ना, तो इट विल कीप ऑन ड्रेनिंग, और नीचे से जब एक बार ग्रैनुलेशन टिश्यू हेल्दी आ गया और इन्फेक्शन अगर वहाँ पे ना रही, सो देन इट विल बी हेल्पफुल। और जहाँ पे सेपरेट हुआ है ट्रैक, दोनों ट्रैक वहीं पे गए। अरे ये नीचे वाला से बाद में डाले ना, जहाँ से वो निकला। ये रबर वाला सर जो है ना, इट हैज गॉट ए ड्यूअल पर्पस, इट कट्स आल्सो। सही कर रहा हूँ
जी सर।
चलो रात डिनर तैयारी है।
नहीं सर, मैं घर जाना हूँ 7 बजे नहीं करूँगा स्लाइन देना।
रजिस्टर लाइन में भी आज
सर
हाँ जी
रजिस्टर लेगा आज।
लेट हो रहा है सर, स्लाइन
चलो
देना।
दूसरी तरफ भी दो, इधर से भी जाओ। ब्यूटीफुल हो जाएगा, ठीक है
सर एनोमेट्री
दो यार एनोमेट्री हर चीज़ तो ले यार, हर चीज़ लगा।
हाँ।
ठीक है।
सर मेरी इतना साफ बहुत पीस है ना।